Conference of American College of Physicians, India chapter on the theme, The Art and Science of Medicine. It is indeed an honor and a privilege to welcome you all as we embark on a journey of discovery, innovation, and enlightenment. American College of Physicians is the largest medical specialty organization. It is a body of 161,000 physicians. India chapter has a growing membership and encouraging internal medicine physicians in our country to become members, helping members to advance fellowship, recognizing members for their achievements. This program is a testament of American College of Physicians' shared commitment to the advancement of medical science. It brings together brilliant minds from various disciplines, fostering collaboration and the exchange of ideas. Over the next few days, we will delve into the frontiers of research. Distinguished guests, esteemed participants, and honored attendees, we are gathered here today for a momentous occasion, a tradition that symbolizes the illumination of mind and warmth of welcome. It is my distinct privilege to invite Dr. Anuj Maheshwari, Governor, ACP India, on stage. Please give him a big round of applause. I am delighted to invite Dr. Anil K. Virmani, the scientific chairperson. Please welcome him with a round of applause. And Dr. Jayant Panda, the organizing chairman, on stage. Thank you, gentlemen. As is our Indian tradition, we would begin by taking blessings of Almighty. The lamp before us represents the illumination of minds, the dispelling of darkness, and the ushering in of a new era of understanding. I request the dignitaries on stage to kindly flame the auspicious lamp and let light shine out of darkness. एक दिया ऐसा भी हो, एक दिया ऐसा भी हो जो भीतर तलक प्रकाश करे, एक दिया मुर्दा जीवन में फिर आकर कुछ श्वास भरे, एक दिया जो भेद मिटाए क्या तेरा नायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि दीपज्योतिः परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम संध्यादीप नमोस्तुते. Now I invite Dr. Anuj Maheshwari, Governor, ACP India, for the opening remarks.
Welcome you all in this 8th annual conference of American College of Physicians India chapter, IM ACP India 2023. My greetings as a Governor of American College of Physicians India chapter to all of you. And I am really grateful to local organizing committee in the leadership of Dr. Jayant Panda for organizing such a wonderful arrangement for success of this conference. As you all know, for any conference, the scientific agenda or scientific program is just like a menu for any feast. So if the menu is not good, obviously people will not going to enjoy the feast. So this scientific feast is going to be more and more enjoyable by a wonderful menu which has been created by our scientific chairman, Dr. Anil Kumar Virmani. So Dr. Anil Kumar Virmani has done a lot of work on this agenda, He has remained involved with this agenda throughout the year, and still he is facing a lot of complexities, like many people are postponing their travel, some flights are getting cancelled, adjustments, and all those things he is doing very successfully. And I believe that this conference is going to be scientifically wonderful success after this will be over. And I believe that all of you shall be enjoying this conference like other previous conferences you have enjoyed, and we shall get the similar level of the appreciation from all the attendees. Any attendee, any problem, facing any problem, you are welcome to come to me or Dr. Panda. We shall always be there for support of your problem. At the same time, I must tell you, apart from the organizing team, apart from the very good scientific faculty, this is the conference which is also going to witness 83 research papers. And 83 research papers shall be presented in these 3 days. And this is a huge number, and we have also gathered the huge galaxy of evaluators to evaluate these papers. As you all know, the best paper in the publication category, best paper in the research paper category, and best paper in the clinical case category shall be given a support to travel main conference of the American College of Physicians at Boston for traveling tickets, by traveling tickets. So this is an attraction for participating, and you all are welcome to be a part of that. Without taking much time, we'll request Dr. Vermani to give the address of the scientific chair before starting the Congress.
Thank you, sir. Respected Dr. Professor Anuj Maheshwari, Governor, ACP India Chapter, Dr. Jayant Panda, Organizing Chairman of this conference, respected seniors and dear friends. It was a great responsibility given to me by the Governor to ask, when he asked me to make the scientific program. Making a scientific program is indeed a big challenge, especially when you have got more than 100 faculty as speakers and almost 200 persons as chairpersons. And that too including international speakers, some national speakers who have got limited time, so they need a particular time for their talk, flight schedules, everything has to be adjusted. Despite all the efforts that we did put in, unfortunately there are few changes at the last moment because some flights have been cancelled and some flights have been diverted, so the speakers are not able to arrive in time. So there will be a slight shift in the speakers of today and tomorrow, and I'm sure you will bear with me. The biggest thing was that this scientific program not only covers a wide area of internal medicine, almost every topic in medicine is covered, and due to the efforts of the local organizing team and Dr. Jayant Panda himself, we have got 12 credit hours from Odisha Medical Council. That is a big achievement. I would like to thank the organizing committee, the local scientific committee headed by Dr. Behra and his team, who have worked day and night to make this conference a success. The academic feast is before you. You have to tell me on the third day whether you really like the quality of topics and the quality of speakers, and you should give a feedback of how further we can improve in the future. With these few words, thank you. Please enjoy the scientific program.
Thank you, sir, for the warm address. And now I invite the organizing chairperson, Dr. Jayant Panda, on the stage for sharing a few words.
Good afternoon, dear Anush, Dr. Virmani, my teachers, senior faculties, friends, and all who are there at the onset of the scientific program. of American College of Physicians, India chapter. It's a privilege to host the 8th Internal Medicine American College of Physicians, India chapter conference at the holy city of Bhubaneswar. Bhubaneswar, as you know, is a metropolitan city with a beautiful natural ambience where you find more than 100 temples, granary, and the attraction of Lord Jagannath and very ancient places like Konark, Chilka and Dhauli brings people of the country and abroad. We are very grateful Odisha got this opportunity. My postgraduates, my faculties, people of Odisha are very energized to host this prestigious conference at the Bhubaneswar city. And on behalf of the organizing committee, I welcome all of you to the program. We have 3 different halls, as Dr. Virmani told you, and we have an inauguration in the evening and the award ceremony tomorrow, and free papers, beautiful concepts, research papers, publications, case presentations, clinical scenarios are being discussed. We have best of the faculties, good food and Taj hospitality. Hopefully, this will be a memorable landmark event for all of you in the history of ACP. Again, I welcome all of you and wish that you enjoy this scientific feast and thank the ACP governor and the team for giving this opportunity to us. Thank you all.
Thank you so much, sir. Now we will proceed for the first session, and that session is medicine mysteries. And I'm delighted to invite the chairpersons on stage, Dr. C.R. Panda from Cuttack, Dr. R.K. Jaina. Welcome, sir. And Dr. M.K. Chautre. And now I turn the time over to the chairpersons for the session. Thank you.
Good afternoon. Good afternoon and welcome to this first academic session. First topic is asymptomatic transaminase. How should you interpret it? And very important clinical scenario. And the speaker will be Dr. Anavendra Naik. Now I invite Dr. Naik to come to the dais to give his deliberation on this important clinical scenario. Dr. Naik, please.
Very good afternoon to all my teachers, my seniors, my colleagues and friends, and thank you, chairpersons also. It's a privilege, and I'm very much thankful to the scientific committee to give me a chance to stand here before you. The subject given me is about asymptomatic transaminase, which is we are facing in day-to-day practice nowadays regularly because of increasing rate of metabolic disease in our country. So what we are going to discuss regarding introductions, pattern of liver enzymes, normal pathophysiology, common causes, approach and conclusions. In the last 2 decades have been seen an enormous increase in the number of liver function tests being performed in healthy asymptomatic individuals. There is many reasons because of some executive health checkup, pre-employment health checkup, and because of awareness, sometimes what happens, the person concerned himself or herself doing tests. We are encountering these things, coming with a 10 or 20 pages reports, and asks us to evaluate and give advice. About 4 to 8% of asymptomatic population have elevated transaminase level nowadays. When you face with elevated transaminase in an asymptomatic individuals, the clinician need to address a number of issues. Could the liver enzyme level be a laboratory error? Is the level significantly and presently elevated? If so, what is likely the cause? And how to plan further evaluations? For the evaluations, it is a big question because there is no clear-cut consensus or guidelines how to proceed. It's depend upon person to person. And now about the liver enzyme, let's see the AST, how it got increased when having hepatocyte injury, where sense cell permeability is happening and release of LDH, LK, LST. At the same time, in cellular death, also release of cytoplasm mitochondria, where ALT, SLT is increased. In case of ALT also, because of the aminotransferase or transaminase having some coordination and reaction with alpha ketoglutarate, pyruvate glutamate, amino acid alpha ketoglutarate, where it is deficiency, particularly in the alcoholic liver disease, that time also ALT is increased. In terms of escalane phosphate, is a specific marker for cholestasis and is found in liver, bone, kidney, placenta, intestines. And the physiological rise of ALP after post-fatty meal is seen, and as per the report available in the literature, it is happening in group O and B very much. Now about GGT, it is sensitive for marker as a cholestasis, where we can have an isolated increase of GGT in alcoholism, obesity, and some drugs like phenytoin, phenobarbital. Now the normal level of our liver enzymes, as we know, everybody knows it is around 10 to 40 units per liter, but this subject is of debate. However, the new recommendation for ALT for male, they have said it is less than 30, and in female it is less than 19. It is coming up as per the latest literature. Now the cause of transient hypertensinemia, one is a viral hepatitis, particularly in hepatitis C and B, hepatitis caused by other infectious agents, and toxic hepatitis because of some herbal medicine and unknown substance people are using, and in some cases strenuous physical exertions. The definition of persistent elevation is also debatable. Conventionally, chronic transaminase has been defined as persistent transaminase elevation for more than 16 months. But recently, the practical consideration have redefined a period of 4 weeks as persistent elevation. So at presently, this 4 weeks is the guidelines we follow. Now the elevation of transaminase without cholestasis, the common causes obesity and metabolic syndrome, where hyperlipidemia, hypothyroidism all are included. Some viral infection, alcoholism is the main problem, and medication, because of self-medication and medications, where it had effect in the liver. The uncommon causes, hemochromatosis, celiac disease, MASLD disease, Wilson disease, autoimmune hepatitis, and granulomas. Very rare, alpha-1 antitrypsin deficiency, thyroid dysfunction, adrenal insufficiency, glycogenesis, hemolytic anemia, particularly hemoglobin E disease, hemoglobin E trait, D6 deficiencies, and some occupational disease. Now drugs, the drugs is one of the major concern about the asymptomatic liver enzyme elevations. Number one drug is acetaminophen, which is used randomizedly from the prescription without prescriptions. Statins we are using very much nowadays because of comorbid condition with lifestyle diseases. Sulfonamide, nitrofurantoin, which is used very much in UTI. Ketoconazole and fluconazole in fungal infection. Coke, amoxiclav, which is used in particularly in RTI. Amiodarone is prescribed very usually in cardiac patients. Then NSAIDs, one of the culprits, INH and others shown in the slides. It is difficult to attribute liver injury to a specific drug when patients with several comorbidities are on multiple medications. In such cases, it may be necessary to empirically discontinue a suspected medication or replace with an alternative and monitor for recovery for liver chemistries. Liver biopsy helped in determining the severity of liver injury caused by the offending agent, and it is indicated in case of acute fulminant liver failure to know the cause and find out the reason behind it. Now elaborate AST with normal ALT, termed as macro AST. High molecular weight macroenzyme formed when AST bind with other plasma components. Macroenzyme formation delay renal excretion of the enzyme and prolong its survival, thereby increasing serum level. Usually a benign process can be associated with autoimmune disease, rarely in malignancy. It is not associated with liver disease, particularly in the autoimmune disease, it's happened. Alcohol-related hepatic injury, where AST-ALT ratio is usually more than 2:1. Chronic alcoholic deficient in pyridoxal 5-phosphatase, vitamin B6, coenzyme for ALT, increasing AST synthesis. On the other hand, alcohol stimulates the synthesis of and release of mitochondrial AST. Also, marked elevation in gamma glutamic transferase (GGT) due to damage caused by alcohol leads to GGT enzyme induction. Again, ratio more than 1. Non-alcoholic liver cirrhosis. This is where AST-ALT ratio is more than 1. And during chronic hepatic stages, where ratio is less than 1, particularly in hepatitis C, hepatitis B. In some muscular disease, AST-ALT ratio increased due to the release elevated AST via LT content muscle fibers. GGT levels are normal in this case. The diagnosis of myopathy is confirmed by finding significantly elevated creatine phosphokinase level and other investigation. Some muscle disease can remain asymptomatic for many years, and that to be very much concerned when the person present with elevation of AST-ALT without any symptom. An AST-ALT ratio when it's less than 1, it is particularly NFLD, non-alcoholic fatty liver disease, spectrum of disease for hepatic steatosis to NAS, where ALT is less than AST, GGT elevation up to 3 times of upper normal limit. Reversal of AST-ALT ratio explained by the increased mitochondrial damage and decreased hepatic clearance of AST. This is a marker of poor prognosis, suggesting the initial or advanced fibrosis. Our prevalence of NFLD, high risk factor generally associated with type 2 diabetes, morbid obesity patients, and in some patients, in some cases, and thyroid disorder. For confirmation, though liver biopsy is not done in regular basis, it is required sometimes. Then AST-ALT ratio, it is equivocal, particularly in chronic viral hepatitis, where hepatitis C is much more common than hepatitis B virus. And here 2 to 5 times more the value of AST got in comparison to upper normal limit. And AST-ALT ratio approximately in between 1. Patient may be asymptomatic or mild symptoms. For confirmation and further evaluation, serological test for hepatitis B, C, and PCR and other confirmatory tests is required. Increase ALT with GST normal with ALT level. Mainly extrahepatic sources. Physiological, children due to high osteoblast activity. Pregnancy in late stage by placental ALP. Old age, where 1.5 of upper normal limit is considered. Pathological, Paget disease, bone pain 11th ALP, though ALTS is normal. And hyperparathyroidism. This is the cause of increased ALP with normal GGT, ALT, AST. The first syndrome is a paranephrotic rise of ALP level in the setting of renal cell carcinoma without liver metastasis. It is not always found, but in case of renal cell carcinoma, occasionally found. ALP more than 2 times than ALT, where 2 to 3 times decrease. It is a sign of polycystic liver disease, particularly primary biliary cirrhosis, primary sclerosing cholangitis, associated with elevated or extremely elevated disease level. Confirmed by antimicrobial antibodies like AMA, MRCP may be required for the bile tech abnormalities to see. Liver biopsy will be needed to confirm or rule out small duct primary sclerosing cholangitis, associated with ulcerative colitis and other syndromes, including other granuloma. Hypertension with hypergammaglobulinemia. It is particularly happen in autoimmune hepatitis, where apart from the ultrasound, antinuclear antibody, anti-smooth muscle antibody, and the liver kidney muscle antibody is required to do to confirmation for the diagnosis, but most confirmation is done by liver biopsy. Elevated AST/ALT and serum ferritin. It is happen in hematochromatosis. It is predominantly male, where transferrin saturation value is more than 45%, where elevated serum ferritin level may be non-specific. Liver biopsy, where hepatic iron index is 1.9, predicted presence of homozygous hereditary hematomosis. Diagnosis is confirmed with finding of homozygous C262Y mutation of the HFE genes, which is to be done in if you suspected hematochromosis to avoid liver biopsy. And the decreased cellular activity, this we know, everybody knows, it is Wilson disease, where present is only elevated liver enzymes without any clinical symptoms. In slit lab, KF ring will be found. Serum ceruloplasmin level reduced up to 85%. 24 hours urine copper output is greater than 100. And confirmation is from copper concentration more than 250 microgram dry liver weight when the liver biopsy is performed. So hypertensinemia with presence of anti-transglutamine antibodies. It is common in celiac disease, and to make diagnosis confirm, anti-transglutaminase antibody specific for celiac disease to be done. If high level persists in a patient with suspected celiac disease, other possible causes of hypertensinemia such as celiac-related AH should be investigated. And for confirmation, endoscopy-proof duodenal biopsy is required. Hypertensinemia with presence of low alpha-1 antitrypsins. This is alpha-1 antitrypsin deficiency. It is identified in early childhood, uncommon cause for liver disease in adults, particularly when the patient present with pulmonary disease like emphysema. Then low level of serum alpha-1 antitrypsin, lack of rise of alpha globulin bands in shape is found when we are going for investigation. Now, the medical history of a patient with asymptomatic elevation of transaminase is very much important, because patients come with a liver abnormality, enzyme abnormality without any clinical sign and symptoms. In that situation, history is much more important. You have to give little time to evaluate, because history of itself limiting fever with or without symptom infection, consumption of drugs, herbals, and other dietary supplements have to be asked thoroughly, including comorbidities like celiac disease, thyroid dysfunction, diabetes, metabolic disease, other disease, hyperlipidemia, all that to be thoroughly evaluated with asking for a history. And alcohol consumption, which is very much important in this situation. And if the patient gives a history of alcohol consumption, how much he is taking regularly, how many grams, it is very much important. One is the asthenia without or without muscle pain. Then joint symptoms, particularly in case of autoimmune disease. And in strenuous physical exercise prior to taking sample for laboratory test, that history should be taken. Because ultimately, when the asymptomatic patients come, the history and clinical examination is one of the major factor and cause to evaluate the patients. Diagnosis, as per, symptom clinical finding, because you have to be very careful, should not do over laboratory tests. But serological marker for viral infection like hepatitis B, C, hepatitis E, polycystic enzyme, and autoantibodies even is suspected like ANA, asthma, AMA, cerebrospinal and 24-hour urine copper level, ferritin, serum iron test span saturation, serum protein electrophoresis to rule out, hemoglobin E trait, hemoglobin disease, creatine phosphokinase and adulterase for muscle disease, then Ig antibodies and a thyroid profile. Apart from this, abdominal ultrasound, elastography, MRCP, and sometimes CT scan may be required to make a proper diagnosis in case of asymptomatic increase of liver enzyme without any clinical finding. So indication of liver biopsy when mild hypertriglyceridemia with all non-invasive tests are negative, then for the confirmation of diagnosis, liver biopsy may require, because this give you the assessment of prognosis and disease staging. At the same time, therapeutic management or decision can taken with this liver biopsy report. The specific liver disease has been confirmed like Wilson disease, alpha-1 antitrypsin deficiencies. And now how evaluating an isolated mildly elevated neurotransmitter level, this is a very busy chart. You can follow this elevated LLN testers or aspirate when it is history and physical examination, then repeated and confirmation if it is doubtful. If it is normal, test for hepatic virus, particularly C, then amyloid level. If it is still elevated for 6 months, and then disease specific markers. If it is abnormal, then disease suspected things like non-alcoholic fatty hepatitis, autoimmune disease, Wilson disease, hematochromosis, viral hepatitis, and alcohol-related dark indices. These to be followed gradually. This is also a busy chart evaluating in isolated mild elevated alkaline phosphate level. And if first is history and physical examination, then confirm the diagnosis with hepatobiliary source like if it is normal alkaline phosphate still elevated for 6 months, then you have to go for a primary colonial angiopathitis, viral hepatitis, primary, all these things, like considering ultrasonography, biliary dilatation, all these things, and that to be followed. And last, if it is inconclusive, liver biopsy is to be taken. Treating the patients, as I told you, the proper history taking is important, careful counseling, and avoidance of causative agents like drugs, alcohol, and the treatment should be disease specific according to the disease which we found during evaluations of the high LFT. Now some literature shows in the Kundras et al. Only 0.5 of 19,877 healthy Air Force trainee had elevated as GPT levels, and a cause of for elevation was found in less than 12% of this individual, of which 2/3 were due to hepatitis B and C. In another study, 149 asymptomatic patients, 56% had fatty liver, 20% had non-A, non-B hepatitis C, 3% had hepatitis B, 11% had alcohol-related SANS, 8% had other causes, and no cause was identified in 2% of patients.
Time's up.
Have to wind up in 1 or 2 minutes.
And
1 minute.
this is an Indian data. Among patients with elevated transaminase level, where 30% had history of antiretroviral drugs, 20% were chronic alcohol abuse, 20% had chronic hepatitis B and C, and 10% had NAS. So it is very important for us because data is from India. This data is derived from AIMS, which is Tertiary Referral Center, and may be biased because of the referral pattern, maybe. Analysis of all available data suggests that commonest cause for incidentally elevated transaminase are chronic viral hepatitis, usage of potentially hepatic drugs, alcohol abuse, and hepatic steatosis, particularly NFLD and NAS, is one of the main factors. So Indian scenario, the chronic alcohol, the antiretroviral drugs, the chronic hepatitis, and NAS is the main factors. And in nutshell, wait and watch. If the trend of time is increasing, proper history is important. Fatty liver resulting either from alcoholic or non-alcoholic is the main cause. History of drugs, personal habit to be taken. Treatment approach should be specific according to the patient and should be cost effective. Liver biopsy at last to be required, to be done if the conclusion is not coming up. Thank you very much.
Next.
Okay, thank you, Dr. Naik, for elaborating this very interesting and very important clinical scenario of asymptomatic elevation of the transaminase. We can take up one or 2 points of important questions to start with. So, do you consider that these asymptomatic elevations of the transaminase, where you, in spite of all investigations, don't find any etiology, still it is can be considered as a risk factor in certain clinical scenario?
Yes, maybe in a long run, sir. Because in a long run, because that may lead to chronic liver disease unknowingly.
Sir, I'll give one example, say, clinical scenario where we face as a hematologist who have treated with chemotherapy, any hematological malignants, the chemotherapy has been stopped. Whenever you go to start the second cycle of chemotherapy, we sometimes find that AST or the LP is still sitting high over
Sir.
300, 400. We are afraid we usually delay it. Do you think that is really rational to delay till the AST or LT comes down to the base level beyond it? Is there any data to show that the raised transaminase level can be detrimental for the patient?
So it is very difficult to say actually pinpoint, because in certain situations we found now patient admitted with high bilirubin like 2450, so 24, 13, 14 like that. We did all evaluation, particularly viral marker, everything, but everything was negative in certain situation. And ultimately patient recovered. So without hepatitis B, C, E, D, all these things. So this scenario also we're facing sometimes.
And my second point, that is there any in critical sick patients, do that the raised transaminase level has been proved to as a risk factor so for morbidity, mortality, or prolonged illness is concerned?
If the comorbid condition is there,
As a standalone risk factor.
if the other comorbid condition is there, then in elder patients that may be considered as a serious matter.
Yes, sir, we can take up one question. Yes, sir.
On a statin. Yes, why? If no, why?
Sir, you have to properly evaluate the patient properly, whether patient having chronic liver disease or not, number one thing. But in the cardiac point of view, you have to maintain the low dose of statins. Because once you start statin, if the liver enzyme, what happened with it? When we start the statin, after 2 or 3 months, we used to shake the LFT particularly, whether the statin induced things are or not. So judiciously you have to prescribe. Continue with low dose. With low dose. With low dose for a cardiac event to prevent. That's what I'm telling you. So we have to continue the statin. That's what I'm telling you with the follow-up. And repeat again. But in case of chronic liver disease, established chronic liver disease, we have to be very careful.
So I think we'll end this session here, Dr. Man. It's already time, and we'll end this session here. Or you have any question?
Pitfalls also very safe in liver disease. That is the only statin you can prescribe in liver disease. Or you can repeat as you told But if you want to give aggressive statin, then you have to go for pitfalls.
Pitfalls is a safer alternative, but in high intensity statin therapy, we monitoring the liver function. Thank you for the presentation. I have a appeal to the speakers.
It's a lot of echo. It's not audible actually.
Yeah, because it's starting there.
A lot of echo is coming.
Yes, they're correcting. Keep sound. Little more sound. So we have started in time. We have to move on time. So 20 minutes is the time for the speaker, and it's 18 plus 2. So 16 minutes. There will be first bell where have 4 minutes more. 18 minutes you have second bail, but 2 minutes more. And if you leave 2 minutes, there will be discussion for 2 minutes. And complete 20 minutes, there cannot be any discussion. Request to speakers, make your presentation maximum 16 to 18 minutes. So you can have 4 to 2 minutes for the discussion. Number one. Number two, chairpersons to keep time and to encourage discussion so that it can be quick and at the same time we can take up. That happens at the beginning. We can move forward. So we have missed gastroenterologist Professor C.R. Ponda, who had to moderate this session, but Professor Jenna has very nicely moderated. We'll move on to the next two, Dr. Chotra and Dr. Jenna, chairperson.
So we'll be moving on to the second topic of this session, that is liver mass in ultrasonography. In our day-to-day practice, we go for ultrasonography for any cause any symptom in the abdomen. We go for a ultrasound, and suddenly we find that if there is a report that there is a mass in the liver, it gives a concern to the patient as well as the physician. So it may be malignant, it may be benign. If it is malignant also, whether it is primary or secondary, that we have to find out. So on this topic, I would like to invite Dr. Anubha Verma to speak on liver mass in ultrasonography. Madam.
Thank you. Thank you, respected chairperson. It's a out-of-the-box topic, though we routinely see incidentally advising ultrasound for many of the indications which come in the routine practices. And if you get a mass, then what we do, how we proceed, and that would be the topic for my next 20 minutes. I'll start with saying these focal liver lesions are diverse and can range widely. Typically are clinically silent. As I said, they are basically incidentalomas, and they are detected incidentally while undergoing evaluation for unrelated symptom, maybe abdominal pain, maybe bloating, or just discomfort in the abdomen, for which we routinely advise in ultrasound. So the understanding the clinical circumstances surrounding the presence of liver lesion aids in a better diagnosis. So my aim today will be, as a physician, to approach these liver masses on ultrasound. The better work would have been done by the radiologist, but being a physician, we should be excuse me? Yeah. Let's talk for the case one. One first clinical scenario where a female patient of 40 years of age visits to her physician office for a non-specific abdominal pain and nausea. Physical examination is clinically not relevant, but the abdominal ultrasound was ordered, and this is an ultrasound image. You can see a hyperechoic lesion which is persistently enhancing throughout the imaging phases. I think most of you will agree we do encounters cavernous hemangiomas routinely in the normal ultrasound, which is usually benign. I'll discuss individually once. I'll just talk about some of the interesting cases which may increase your interest, because this is one which we see in our medicine OPD. Another patient, it's a 25-year-old Hispanic female undergoing workup for liver function test. As my previous speaker talked about the asymptomatic and elevated transaminases, definitely we would like to order an ultrasound. But here, once an ultrasound was ordered, there was multiple liver lesion on abdominal ultrasound, and there is a hypoechoic lesion on the ultrasound. This was also followed up by a CT and an MRI. Yeah. Here they show a hypoechoic lesion with slight pinpoint in the between. So this was more confirmatory on CT and MRI, but fibronodular hyperplasia is another common entity, which is again a benign issue. A female presenting, excuse me, Can you help with this? Moving too fast. Another patient presenting with, I've missed one of the slides. Yeah. So any patient presenting with, yeah, there is no, what do you want to tell? Slides are so difficult to move. So there is a patient presenting with chronic abdominal pain. Patient was on OCPs, otherwise healthy, no significant medical history. An isodense to hypoechoic dense lesion was found on ultrasound. And this was a CT, this patient, because I'll be more focusing on the ultrasound, but because these patients had a confirmatory CT and an MRI, which showed adenoma, hepatic adenoma on the, confirming the adenoma, which was seen on a CT scan, on an ultrasound. And another case, a common case which we see in our routine OPD clinic with abdominal pain and a palpable mass and a round clear margin, a cystic lesion of a hydrated cyst. So these are some of the routine cases which we'll discuss in the next slides. So as per the categorization of liver lesions, they can be benign, the hepatocellular, biliary, which both can be benign and malignant. Some of the lesion like hydratitis and abscesses, which I have covered one or two, just to show the clinical scenario. So radiology plays an important and varied role, including the screening, diagnosis and treatment of liver lesions. Ultrasound plays an increasingly important role in diagnosis of liver lesion. And the utilization of contrast enhanced ultrasound has quite increased the amount of information you can get only from the ultrasound itself. MRI and CT can be helpful whenever there is a confusion or doubt or suspicion on the ultrasound. For a malignant lesion, you may go for a higher investigation. So when we talk of liver mass on ultrasound, the characterization is important. What is it? If it is there, and the focused examination is required. A bit about the methodology. Based on the appearance on the grayscale imaging, the vascularity is more important. The basic grayscale ultrasound help us to differentiate between the cystic and solid masses. The vascular information can be provided by the conventional Doppler, and CT and MRI can be for a definitive characterization. So in certain cases, we have to inject a microbubble contrast agent to enhance the Doppler signal. And the basic liver lesion, what the characterization requires a vascularity and enhancement on the arterial and the portal venous phases. This is one of the example of a hepatocellular carcinoma, a hypoechoic lesion on an ultrasound on a grayscale, and using the contrast enhanced ultrasound, they show a enhancement on a CUS scan. So the echogenicity rather than size determines the lesion, and the first technique, the previously which were used because of the Kupffer cell uptake of the clearance of this microbubble persistence led to the diagnosis. The use of better techniques using the perfluorocarbon contrast have actually both in the arterial and the portal venous phase improves the diagnostic aid. So just to understand it, enhancement of benign lesion, the focal nodular hyperplasia, that was the second case. The hemangioma, that was the first case. They equal or exceeds the liver enhancement in the portal venous phase. This is the certain algorithm for the liver mass diagnosis. These are benign lesion. Their morphology during the arterial and the portal phase. If we see, there is an enhancement in the adenoma, in the hemangioma. The difference among the hemangioma and nodular hyperplasia remaining that in the hemangioma there is a centripetal progression of enhancement and there is a complete or partial fill-in. In fibronodular hyperplasia, though they may present with a centrifugal hypervascular enhancement, but there is a scar, central hypoic scar. Adenoma, they have a diffuse hypervascular enhancement, And metastasis, we'll talk about the metastasis and the malignancies which show a portal venous phase washout. They are the best, though I have covered this. This is basically the domain of the radiologist, but as a physician, we should be aware of the scanning or the reports, what we are reading. So, the washout during the portal phase should raise a suspicion for a hepatocellular carcinoma. So, they are usually hypervascular in visualization, but when there is a contrast enhanced ultrasound, during the washout, there is during the portal phase, it should raise suspicion for a malignant lesion. You should go for a confirmatory higher scanning, or there should be another suspicious image in an ultrasound should be an hypoechoic halo. This around an echogenic or an isoechoic liver mass is an ominous sonographic sign necessitating definitive diagnosis. A hypoic and solid liver mass is likely to be significant and also requires a definitive diagnosis. Multiple solid masses may suggest metastatic or multifocal malignancies, and though hemangioma can be one of the exceptions. Clinical history of malignancies, chronic liver disease or hepatitis, and symptoms to the liver are requisite information for interpretation of focal liver lesion. So it's a teamwork. We require a team of surgeon, hepatologist, interventional radiologist, and a pathologist. So talking about the lesion, I'll just go through them. They are one of the most commonly occurring in females. The small, multiple, asymptomatic, typical or atypical hemangiomas can be seen. They are homogeneous, they are hyperechoic, giant lesions can be heterogeneous, and they can be the USG is quite sensitive. You can just on visualization, you did not go for higher investigation. If there are atypical, higher in size, larger in size, you can go for 3 to 6 months. Again, repeat ultrasound. In a patient where there is a known malignancy, increased risk of hepatoma, abnormal LFT, or clinical symptoms relate to the liver or an atypical sonographic patterns, then you can go for a contrast enhanced sonography or a CT scan or an MRI. Routinely, hemangioma may not require much of the intervention or investigation further on. They are typical. The first slide shows a typical multiple cavernous hemangioma, hyperechoic single lesion of cavernous angiomas, and the others may have an atypical presentation. And there is the characterization on enhancement. They have a peripheral enhancement, and the enhancement is toward the centripetal, towards the core. Another second case which we saw was the focal nodular hyperplasia, which is the second most common benign lesion. Another very common in females during the childbearing age group. They also present with as hypoechoic to linear, there is a lesion, and there is in the center there is a linear or a stellate area which may be hyperechoic, or we can say it is a scar. So on an Doppler ultrasound, because they are a very hypervascular structure, they present with a spoke wheel vascularity. The two lesions can be differentiated using a sulfur scaphoid scanning. This is ultrasonographic picture of a focal nodular hyperplasia, and this is a hypervascularity shown on a color Doppler, and this a spoke wheel pattern which can be seen in the contrast enhanced ultrasound. The assessment, usually the diagnosis, the patient can be discharged. The diagnosis, if it is certain. If it is uncertain, the use of contrast enhanced or biopsy may be required, where they may show a map-like pattern by the glycine synthetase specific to FNH. There's chances of converting into malignancy. A third structure, which was a solitary presentation, mostly seen in the middle-aged female on oral contraceptives. They may be asymptomatic or present with abdominal pain, but they may the sudden onset pain in the liver because of the bleeding, because of the rupture, because of the infection can be the presentation of adenoma. These are basically patients on OCPs or anabolic steroids, less common in pregnancies. They usually present on an ultrasound as solitary and large, non-specific, hypo, hyper, or a mixed picture. With a hemorrhage, a fluid component may be evident, and a color Doppler may show a perilesional sinusoid. So this is the lesion which can be seen on an ultrasound. We can differentiate with the contrast enhanced can actually be very helpful in differentiating. This is correct, which shows a centripetal filling and a non-homogeneity as compared to the focal nodular hyperplasia. And the treatment in the females, obviously you can still have a lifestyle changes. In the male, you can go for resection because, as I said, the larger size can go for rupture. They can go for rupture. They can have hemorrhage, and the hemangioma is classically a hyperechoic lesion with central scarring of a focal nodular hyperplasia, and the adenoma can have a varied presentation. A lesser common, a minimum word for a rare tumor of hemangioendothelioma seen in a pediatric age group having a hypo and a hypoechoic structure, and they may show us on a color Doppler artery shunting dilated hepatic vasculature can be seen in a Doppler. And another one is a mesenchymal hematoma, which is seen typically in the pediatric population, and they have been showing a multiple cystic-like patterns. They are basically mixed multiseptate cystic tumors, and especially seen in the pediatric age group. And this is the color Doppler picture along with the face scan of this. A word about, because I've tried to cover most, I'm just trying to show the picture and the image. So this again a very rare hepatic lipoma, which are usually asymptomatic. Sometimes CT may be required to know about the diagnosis. So this can be confirmed. Another common lesion, though it is not, we'll not classify them as liver mass, but yes, there is a very organized fluid-filled structure, a common hydatid cyst, again more commonly seen in the women of 50 years of age. Ultrasound can be helpful in distinguish between the simple and the other cystic lesions. Sometimes if there is, because the uptake is minimal on, there is no uptake on contrast in CT and T1 images, and this makes the diagnosis easier. That was a hydatid cyst on the first image. The CT scan showing the meniscus sign, the inverse meniscus sign, and the Pubble sign, which we teach all undergraduate students for the hydatid cyst. They have a various patterns where they can be helpful to differentiate between the various patterns of the cyst. Where when we are talking about a cyst, there could be the abscess. You should be very well aware about the rounding, clear margins, multiple pyogenic liver abscess, the infective lesion, the large solitary irregular margins, and hypoechoic lesion on an ultrasound for amoebic liver lesions. A word about the malignant hepatocellular carcinomas. They are more predominant in males with the predisposing factors being the alcoholic and cirrhosis and hepatitis B and C, presenting during the advanced stage with the characteristic features of end-stage liver disease. Here, if you see a hypoechoic lesion with enhancement on contrast scanning and a washout during the portal phase, mainly favors a malignant transformation. Young age, a tumor at 20 to 40 years of age may not be associated with a cirrhotic liver, though it usually occurs in a non-cirrhotic liver. They may show a fibrolamellar hepatocellular carcinoma in a 23-year-old woman, where a large heterogeneous echogenic lesion in liver can be seen, and there is a strand in the center. Though they are non-specific features on the ultrasound. Metastasis, which is much more common than the primary malignancy, as sir was talking about the primary and the secondary malignancy. Metastasis, which are much more common primary sites being the GI tract with variable survival may be required. They may present as a multiple solid lesion of varying size and a hypoic halo surrounding a liver mass. So that was what I said before. Any hypoic lesion with a surrounding halo should be confirmed for a malignant mass. So this around the periphery of the liver mass on sonography is an ominous sign and should be associated with malignancy. So various appearances can be seen with the hypoic, with calcified, diffuse and cystic, should be suspicious for metastasis. You can confirm with the CT or MRI. A word about lymphoma, which is a very rare secondary involvement. Multiple hypoechoic hepatic masses can be seen. If you can see, this another young girl presenting with a hypoic lesion, low attenuation nodular lesion, and this can be seen in the spleen, in the right kidney and the hepatic lobes. Clinical examination may also be relevant in this case to look for the various lymph nodes and the organomegaly. Another primary adult tumor in the children which present with mixed echogenicity, hyperechoic related to the liver, is a hepatoblastoma. And this is the image of hyperechoic lobular margin. So, liver lesions are common and proper diagnosis is important. A combination of medical history as well as appropriate imaging is essential. Most lesions are benign, but in certain situations must be addressed or treated. Thank you.
Thank you, madam, for enlightening us on a common topic. It's always a dilemma when we suspect whether it is a primary or secondary or
Yes.
benign or malignant. Can anybody can you differentiate secondary and primary from the ultrasound itself?
Like there are, it's, I should say it's not primarily one stance you can say it's a primary or secondary. But yes, the most of the lesion, the primary, when we talk about malignant liver lesions, the primary what we were seeing, the hepatocellular carcinoma, the fibrolamellar carcinoma, they may have a typical pattern of presentation. There's a history. That's why I said the clinical history should also be relevant. HCC, there is moreover predisposing liver lesion like chronic liver disease, hepatitis B, C positive patient, alcoholic cirrhotic patient. They have landed up and developed into, if in this follow-up patient developing irregular mass, hypoic lesion, and then when they went for a contrast enhanced ultrasound scan where there was showing the enhancement and portal washout, that may be suggestive for a primary hepatocellular malignancy. Metastasis, there should be a primary lesion elsewhere in the body which may have a suggestive clinical history and examination. Isolated ultrasound should not be used as a way of diagnosing primary or second or any malignancy to per se. There should always be a, like we always teach in an undergraduate, it's a history taking, it's a good examination and the relevant radiological investigations which should pave the way. And with as the advancement with the contrast enhanced scans, the CT scans and the MRI, the diagnosis and definitely the pathology, the histopathology, we can reach to the conclusive diagnosis, because loosely saying that this is malignant, it produces a lots of psychosocial and effect on the patient and the family itself.
Now any question from the audience?
Another thing, madam, if you are seeing any liver disease,
Yeah.
always suspect for adult onset PKD, ADPKD, because multiple liver cysts may be associated with multiple cysts.
Yes, sir,
What
definitely.
is your say on final aspiration cytology
Yeah.
on any suspected mass, liver mass, but not be more towards, for example, more towards malignancy? What is the role of FNAC?
Definitely we need to,
Is it advisable or not advisable?
if there is any suspicion in a solid mass, you are able to rule out abscess from a solid mass. The presence of the fluid, if we are still unable and you are still suspicious or a highly vascular lesion, you can go for a scan and then you can get an FNAC or FNAB if required. But the lesions which are like amoebic liver abscess can be very well seen by
That may
ultrasound.
lead to seedling like that.
We need to do the biopsies. There is no malignant diagnosis can be made without good biopsy specimen.
Thank you, madam. We'll go for the next topic.
Thank you.
So moving to the next speaker, we'll now invite Dr. Dibya. She will be talking on non-malignant hematological emergencies, the clinical presentation, diagnostic evaluation, and treatment strategy. So Dr. Dibya, please. So I would request you to finish in 18 minutes so that we can keep it for 2 minutes for question answer or discussion.
A very good evening to all of you. So finally the technical glitch is over. So I think I must thank the organizing team, the scientific committee, Dr. Anuj Maheshwari, Dr. Virmani sir, and Dr. Jayant Panda for giving me this opportunity. But the topic of discussion today is another an out-of-box topic, the non-malignant hematological emergency. It's a very vast topic and can't be covered in 20 minutes, but I have tried to summarize the topic in a few of the slides, but please excuse me for the length of discussion, for the length of lecture today. So maybe it is non-malignant or malignant, but it may be life-threatening, and it usually results from the disorders of blood cells and the coagulation system. This we all know. It can affect any age group, but mostly it happens in the patients who are having some underlying blood diseases like thalassemia, hemophilia, or immune thrombocytopenia or sickle cell disease. If they are not recognized timely, on time, or diagnosed on time and could not be treated on time, they can lead to severe, serious complications and mortality as well. So the topic of today's discussion and the objectives of today's discussion is to review the common types of non-malignant hematological emergencies, their clinical presentations, how to diagnose or evaluate them, and to a brief of the management of all types of non-malignant hematological emergencies. These are the subgroups. We can divide these emergencies into red blood cells emergency, into white blood cell, platelet emergencies, and coagulation emergencies. And I'll try to cover one by one everyone in brief. So first one is the red blood cell emergency. The common one is acute hemolytic anemia. And we all know that there is a decrease in hemoglobin level. Basically, it is due to the destruction of red blood cells. And it can be caused by certain other reasons like severe infections, like so many drugs or autoimmune disorders, or maybe transfusion reactions or some inherited defects also. It can present as the signs and symptoms of anemia, maybe fatigue, pallor, dyspnea, jaundice may be there, dark urine may be there, and splenomegaly or hemoglobinuria. The slides are not moving? Okay. Okay, fine. I'm really sorry. I could not see the there. Yeah. Okay. So how to diagnose acute hemolytic anemia? First of all, for any of the non-malignant hematological disorders, we have to do the CBC, and the very characteristic of hemolytic anemia is low hemoglobin level, low hematocrit, low red blood cell count, high retic count, and high lactate dehydrogenase. These are the typical findings we can find in any of the hemolytic anemia. And if we can do peripheral blood smear, they show cystocytes, spherocytes, and some other abnormal blood cells. We can get that and IIT also done, where we can find the specific antibodies or complement cells against these. And haptoglobin, a protein, may be there if we can detect it or if we can get it done. So the brief management of acute hemolytic anemia always depends upon the severity of the condition, and it always depends upon the cause of the condition. So first of all, we have to identify the trigger cause and remove the trigger of hemolysis.
hemolysis, and supportive care definitely plays an important role in the form of fluid resuscitation, oxygen therapy, transfusion of compatible red blood cells if it is needed in that particular patient. And sometimes patient may need specific therapies like corticosteroids, immunoglobulins, splenectomy may be needed, or maybe rituximab for immune-mediated hemolysis. Plasma exchange may be needed in some of the patients. The second of red blood cell emergency, sickle cell crisis, and it is a complication of sickle cell disease, and it is a very specific disorder which causes abnormal hemoglobin S, this we all know, which forms sickle-shaped red blood cells. It occurs when sickle cell obstruct the blood vessels and it causes tissue ischemia and inflammation as well. It can manifest either as vaso-occlusive crisis, it's a painful crisis, or acute chest syndrome, maybe as a splenic sequestration crisis, aplastic crisis, or a stroke. So to diagnose sickle cell crisis, very specific in CBC, shows low hemoglobin, low hematocrit, high retic count, and high white blood cell count in this specific type of emergency. And peripheral blood smear shows sickle cells and target cells, we know, and hemoglobin electrophoresis, if can be done, it confirms the presence of HBS and other hemoglobin abnormalities. Imaging studies can be done if there is any organ involvement in that particular patient. Again, the general principle of the treatment are same: to maintain the hydration, to reduce the blood viscosity. If the pain and inflammation is there, analgesic drugs may have to be given. Oxygen is to be given to correct hypoxia and prevent further sickling. If infection is there, broad spectrum antibiotics to be given. Transfusion is definitely echoing. Voice is echoing. Slides are not moving, sorry. I'm really sorry. So transfusion may be given to improve oxygen delivery and reduce sickle cell burden. Sometimes hydroxyurea may be needed to increase fetal hemoglobin. So the third emergency is paroxysmal nocturnal hemoglobinuria, and it is a rare disorder where there is a deficiency of protein called CD55DAF on the surface of blood cells, and this makes blood cells susceptible to complement mediated lysis, which lead to intravascular hemolysis and bone marrow failure. It can present as episodic hemoglobinuria, dark urine, anemia, fatigue, abdominal pain sometimes dyspnea, headache, or maybe thrombotic events may be there. So to diagnose paroxysmal nocturnal hemoglobinuria, again we do CBC and we can find high LDH, and the same thing like low hemoglobin, low hematocrit, low blood cell count, and high retic count. Urine analysis can show hemoglobinuria and hemosideruria. Flow cytometry is the gold standard to diagnose paroxysmal nocturnal hemoglobinuria. It detects absence of conduction of CD55DAF on red blood cells, white blood cells, and platelets. It's the gold standard test. Bone marrow biopsy, if can be done, it shows hypocellular or aplastic marrow in some of the cases. So to treat this emergency, supportive care is the mainstay of the treatment in the form of iron supplementation, folic acid supplementation, transfusion of packaged red blood cells if it is needed. Anticoagulation is definitely required to prevent and treat thrombosis in the form of warfarin and heparin. Sometimes eculizumab, a monoclonal antibody which inhibits complement activation, may be needed to reduce hemolysis, transfusion requirements, and thrombotic events. Bone marrow transplantation is a rare thing which may be needed in some of the patient as only curative option whenever the patient is refractory to other kind of treatment. So white blood cell emergencies we can come across is neutropenic fever is one of the kind. It is a condition when blood cell neutrophilic count reduces below 500 cells per microliter, and the patient develops a fever of 38 degree or more, and it is usually a complication of chemotherapy or other type of immunosuppressive therapies, and it causes bone marrow suppression. So it's a definitely medical emergency which can lead to severe bacterial or fungal infections that can be life-threatening also. CBCs shows in these patients low ANC and other cytopenias. Blood cultures may be positive, may be done to find out the causative organism so that which can guide the treatment as well. Other cultures can also be performed like urine, sputum, stool, wound cultures, depending upon whatever is the source in that patient. And imaging studies are to be done when there is a chance of or indication of any organ involvement. Though the treatment of neutropenic fever is definitely empiric antibiotic, broad spectrum antibiotics are to be given to cover gram-positive and gram-negative bacteria, and they should be started within an hour to prevent the further complications and mortality. And de-escalation and modification of antibiotics is needed depending upon the culture results, the clinical response, and the duration of neutropenia. Antifungal therapy is needed when the fever persists for more than 4 to 7 days of antibiotic, or the patient is having risk factors for fungal infection. Sometimes GCSF is needed to stimulate the production of neutrophils and reduce the duration of neutropenia. Supportive care is always a mandatory thing, such as fluid and electrolyte management, pain control if needed, and nutritional support. Another entity is hypereosinophilic syndrome. It's a very rare disorder that causes persistent and marked eosinophilia and organ damage as well. It can be classified into primary idiopathic, which is idiopathic or clonal, and secondary, which is reactive to infections, allergies, or malignancies. Sometimes it may be of familial or genetic type also. It can affect organs like skin, lung, heart, gastrointestinal tract, nervous system, and blood also. To diagnose it, CBC again done, which shows high eosinophilic count and other cytopenias. Peripheral smear shows eosinophils and abnormal morphology or increased basophils or mast cells. Bone marrow biopsy, here there is a specific which shows eosinophilic infiltration or clonal abnormalities. Molecular tests sometimes may be needed, such as FIPILI, PD-GEFRA, fusion gene, or other mutations which are associated. An organ-specific test may be needed if we suspect any organ involvement. The hypereosinophilic syndrome may be treated according to general principle, where corticosteroids is the first line therapy for most of the patient, which reduces eosinophil count as well as inflammation. Imatinib may be needed. It's effective for patients especially with the FIPILI, PDGFR fusion gene or other mutations. And some other cytotoxic agents like hydroxyurea, interferon alpha, or cladribine or some other specific therapies may be needed for refractory patient or those who are intolerant to corticosteroids or imatinib. Monoclonal antibodies may be needed. Organ-specific therapy may be needed in few of the patients. So the platelet emergencies we all may come across some or other time of our clinical practice, like immune thrombocytopenia. It's an autoimmune disorder that causes the production of antibodies against platelet, which leads to the destruction and the reduced number of platelets as well. This again can be classified into primary, which is idiopathic, secondary, which is associated with most of the times with infections, maybe drug induced, maybe because of malignancies or other autoimmune disease. It can present with, we all know, with bleeding manifestations such as petechiae, purpura, epistaxis, sometimes gingival bleeding, hematuria, or menorrhagia as well. So to diagnose immune thrombocytopenia, CBC with platelet count is done, which shows isolated thrombocytopenia less than 100, and peripheral blood smear always shows normal size platelets with no clumps or schistocytes. Bone marrow aspiration is done, which shows normal or increased megakaryocytes, which is not required for diagnosis unless there are other cytopenias or there is suspicion of malignancy. Antiplatelet antibody test is a specific test which detects antibodies against platelet antigens, but it is not routinely performed. Another test to exclude organ involvement. To treat immune thrombocytopenia, we have to observe the patient. If the patient is stable and the platelet count is more than 30, then there is no specific treatment needed. But the first line therapy for more severe cases is where the platelet count is less than 30 or significant bleeding is there. Corticosteroid is the first line therapy, or IVIG or anti-D immunoglobulin can be given. The second line therapy for the patients who are refractory to first line therapy maybe rituximab, maybe thrombopoietin receptor against, or splenectomy may be done in some of the patients. In some patients where emergency therapy is needed, where life-threatening bleeding is there, platelet transfusion may be given or IVIG, and high-dose corticosteroids may be needed. The second entity is thrombotic thrombocytopenic purpura, which is also known as Moscovici disease. It's again a rare disorder which causes deficiency or dysfunction of a protein called ADA-MTS13, which normally cleaves one Willebrand fracture into smaller fragments, which leads to the accumulation of large VWF multimers that binds to platelets and form microthrombi, which is the main culprit of the things going on in these patients. These patients can be identified with the classic pentad of fever, thrombocytopenia, hemolytic anemia, neurological symptoms, and renal impairment. And the same condition can be acquired also, which may be because of pregnancy, maybe infection, maybe SLE. Some drugs are also culprit, organ and bone marrow transplant sometimes, and sometimes malignancy may be the cause of disease. So to diagnose, to simplify the diagnosis, if there are three major sign symptoms who are simultaneously present in any of the patient, which can be indicating thrombotic thrombocytopenia diagnosis. Thrombocytopenia, if this is there, the presence of schistocytes more than 1% of the total red blood cells, or value of lactate dehydrogenase, if it is extremely high, it can we can diagnose the patient as thrombotic thrombocytopenic purpura. Otherwise, CBC is to be done, which shows specific features, shows severe thrombocytopenia, or ADAMTS13 activity and inhibitor assays can be done. Coagulation test can be done, which shows normal PT, activated APTT is normal, fibrinogen is also normal, which distinguishes it from TTP and which distinguishes it from DIC, which doesn't show the normal PT and APTT levels. So renal function test may show in elevated BUN and creatinine, and which always indicates renal impairment in such patients. Neurological tests can be performed in some patients if there are indications of neurological involvement. So to treat TTP, plasma exchange is the mainstay of treatment, which involves removing the patient's plasma and replacing it with fresh FFP or cryosupplemental plasma. Corticosteroids can be given to suppress the immune system and reduce the production of ADAMTS13 inhibitor. Rituximab is a monoclonal antibody that targets CD20 on beta cell, and it can be used as a second-line therapy in those patients who are refractory or in some patients who have relapsed. And other therapy may be needed sometimes, like splenectomy, immunosuppressive agents, or recombinant ADAMTS13 in patients who are unresponsive to the first-line or second-line therapy. The last platelet emergency is heparin-induced thrombocytopenia, which is an immune-mediated adverse reaction to heparin, and it causes formation of antibodies against heparin platelet factor 4. And these antibodies, they activate platelets, they cause aggregation and consumption, leading to paradoxical thrombosis as well as thrombocytopenia. It can present with a drop in platelet count by more than 50% or less than 150 into 10 per liter within 5 to 14 days after heparin exposure, and arterial or venous thrombotic events may be there. So to treat heparin-induced thrombocytopenia, discontinuation of heparin is the first and the foremost thing. And non-heparin anticoagulation is definitely needed to treat thrombosis, and direct thrombin inhibitor like argatroban or bivalirudin can be used, or factor 10A inhibitors like fondaparinux or rivaroxaban or warfarin can be used. Platelet transfusion may be needed in some of the patients to correct severe thrombocytopenia, and plasmapheresis may be needed in severe cases and life-threatening cases. So the third last is coagulation. Yeah. Yeah, I have already asked for excuse for a lengthy presentation. I will just name the coagulation emergencies. This is DIC, which is very common, and we all may have seen some of the cases. It is a syndrome that causes widespread activation of coagulation system, leading to simultaneous thrombosis and bleeding. It can be diagnosed, the typical test to identify DIC is coagulation test, which shows prolonged PT, APTD and thrombin time, low fibrinogen, high D-dimer and fibrin degradation product, and other CBC can be done to find out some specific things. To treat DIC, the general principle is to treat the underlying cause. Supportive care is the mainstay of treatment. Anticoagulation may be given to prevent and treat thrombosis. Heparin-like or low molecular weight heparin can be given. Sometimes antifibrinolytic agents are required to prevent or treat bleeding, such as tranexamic acid or aminocapric acid. Coagulation emergencies में second is hemophilia, is again a genetic disorder. It can be identified by CBC and coagulation test, which shows normal PT and TT, prolonged APTT, and it corrects with mixing body, low factor 8 or 9 activity level. Some genetic testing can be also done to diagnose hemophilia, and to treat it, factor replacement therapy is really needed. Sometimes antifibrinolytic agents are also needed to enhance the clot stability. Desmopressin, emicizumab are the other things to treat hemophilia where the disease is severe. Third is von Willebrand's disease. It's again a genetic disorder. It can be diagnosed by CBC, doing CBC and coagulation testing. In coagulation testing, it shows normal PT, TT, prolonged APTT in some of the cases. Genetic test may be done to identify the type and subtype. Yeah. So treat, these are the specific treatments to treat von Willebrand's disease. So this comes to an end of this, this very lengthy presentation. So to conclude, I can say that in hematology, there are various clinical conditions, both benign and malignant, which may need a prompt diagnostic assessment. A rapid prognostic stratification is needed in order to immediate therapeutic correction, and the knowledge of most hematological emergency is crucial in our daily practice for timely detection, further management, and to avoid any kind of adverse outcome. Thank you so much for patient listening.
So thank you, Dr. Debya. You are very clear, precise, and very convincing also. You tried to cover up the entire benign hematology in a form of emergency. You know, every benign hematology chapter can have some emergency. I won't go to the certain contentious issue which you raised, but you are more or less bang on point. I will raise rather more common point, which is more of the physicians are interested in dengue fever. How do you consider the platelet count? How low is the actual critical level? Is a medical can be considered as a medical emergency for physicians, and how to tackle dengue fever with the falling platelet count?
Falling platelet count.
Because that's the more common, these guys, they manage.
Basic supportive therapy is the basic thing, and we have to find out the cause. The cause inhibition factor is also has to removed. Supportive therapy is the mainstay of treatment. Platelet transfusion is only needed in very severe cases, or where the bleeding is there, excessive bleeding is there, or patient is having platelet count less than 20,000 or even less than 10,000.
So in dengue fever, if the platelet count is less than 20,000, does it really help? Has it been any randomized trial shown that it prevents the bleeding or etc.?
No.
Because there's a lot, just a minute. Because in the epidemic of the dengue fever, there's a lot of noise and buzz around the state, even around the country, platelet, and people rush from blood bank to blood bank. How often it helps their patient? And is it really, whatever the study have shown that it can be detrimental also? Has any randomized study shown that it really benefits in terms of reducing the morbidity and mortality in terms of the bleeding into intracranial spaces or any internal things?
No. It's absolutely a myth that platelet
so
transfusion is...
Any counter comment from the audience, those who are in favor of transfusing the platelet and they have evidence? Yes, sir, please.
is very important to first assess the patient, not only depend on the total count, but also see the situation of the patient. What is his hemodynamic status? And then decide whether to give platelets or not. So just believing only 20,000 is not the right way.
And sometimes the count is also fallacious, the report is also fallacious. Many a times in most of the our hospitals, the counts are being done on counting is done. So manual counting is always suggested to repeat the platelet count by manually, and don't believe on counter reports.
Got your point. You have already spoken like a true hematologist. Yes, Dr. Manmohan.
Sir, actually dengue, most important disease is dengue, sir. For example, rapid fall of platelet count, and people are telling that platelet, running after platelet only. But for all the practical purposes, dengue is not the disease of platelets. It is the disease of packed cell volume. If there is rise in the rapid rise in the packed cell volume and rapid decline in the platelet volume, then only you can think of that. But it is disease of capillary leakage which gives rise to different effusions like peritoneal effusion, pleural effusion. So if you are more than 20% rise, there is capillary leakage, and that is dengue hemorrhagic fever. Not bleeding is the dengue hemorrhagic fever. If it is associated with high hematocrit value, then it is total dengue hemorrhagic fever. Otherwise, it is known as dengue fever with hemorrhage. And as regards to platelet count, it should not be infused. It is less than 20,000 is not, book says it is 10,000. Or bleeding with any platelet count. If there is bleeding, any platelet, because there may be some platelet dysfunction. There are two indications. One is less than 10,000 or bleeding with any platelet count. You can give platelet because of think of platelet dysfunction.
So look, these are the, probably you are referring to the guideline of the WHO or Government of India or some regulatory bodies because of the few experts like us. They sit and they give a proposal and government approves. If you look at the pathophysiology of thrombocytopenia and dengue, same antibodies against the dengue, they cross-react to the platelet and the platelet is eliminated. The way the low platelet count happens in ITP, the platelet transfusion is contraindicated. You have told in the medical emergency, yes, you give the IVIG or methylprednisolone, block the FC receptor. If you then give the platelet, it will be retained in the body. Same scenario happens in dengue fever. And there are many studies have shown that platelet administration has rather increased the pulmonary complications and edema also. And I will tell you the last week, so one of our colleagues had a severe dengue. The platelet count was, Professor Jayant Panda was treating, the platelet count was sitting below 20,000 also. I was giving spuriously 5,000 higher just to give a confidence. We give every day single donor platelet. And the platelet count was still sitting on 20,000 less than that. The moment day 8 or day 9 has started, as the antibody started clearing the dengue, the platelet count jumped to even more than 1 lakh. So platelet count, though we transfuse when it's less than 10,000, 20,000, with bleeding or without bleeding, that gives probably a psychological satisfaction to the clinicians, to the patients, which may be helpful. But I am afraid if you have any randomized study to tell that with the platelet administration that really decreases in the morbidity, mortality complications, we have to search for the literature for that. If you have any literature is known to you, any randomized trial, we are happy to know for that.
Because sir, what happens in dengue, there is cytokine tsunami.
Okay, so thank you very much. We'll end this session here. That's the end, and thank you very much for the organizing committee for giving me this wonderful opportunity. On behalf of my co-chairperson, myself, thanks to the management team for giving this wonderful opportunity.
Thank you, chairpersons. Thank you.
Thank you, chairpersons. There are some changes in the next session. So I'll announce the changes. For the chairpersons, Dr. Ashok Malik. Dr. Ashok Malik is there? Please. Dr. Ajay Verma. Dr. Ajay Verma is there? Dr. M.R. Patnaik. Dr. Shiva Prasad Dalai. Shiva Prasad Dalai. Dr. M.R. Patnaik. Dr. Ajay Verma. Chairpersons, please. Now there are 3 speakers. That is the change. First speaker is Dr. Anuj Maheshwari, who will be talking on MASLD. Second speaker is Dr. Parthasarthi Karmakar, And third speaker will be Dr. B.M. Makkar. So please note the changes. First is Dr. Anuj Maheshwari, then Dr. P.S. Karmakar, and then Dr. B.M. Makkar.
Thank you, sir. Doctors, your presentation left us in awe of your expertise and dedication. And I request the chairpersons and the speakers of session 1 to kindly collect their mementos from the left side of the stage. And I also request the speaker to please stick to the time. Thank you so much.
Thank you, chairpersons, and thank you. I think.
Yes, sir, yes, sir.
Where is the talk? I have given you my PPT. मेरे पास है. Can I put it here again? If you lost that. Slide is coming.
By the time the stage is ready, I request the chairpersons and the faculties to receive the mementos at this end. Anubha ma'am, Divya ma'am, Manoshar, Manavendroda, please come, please come.
Should I start or wait? Should I start?
Yes, sir, yes, sir. Most welcome. You can start.
Thank you. Thank you, Chairperson, for allowing me for this talk. Unfortunately, the speaker, what was designed for this talk and what was designated this talk is not really being able to make it. He is sick for some reason. That's why I am taking his session. So, first of all, there is a disclaimer. This is a sponsored talk, and that's why it's happening is more important. So once we talk about the NAFLD and MASLD, this is the non-alcoholic fatty liver disease is now known as a MASLD. This is metabolic solution for the metabolic dysfunction we are looking for, and that is actually termed as the metabolic dysfunction associated steatotic liver disease. It's not matching here. It is okay. I will leave that. I will speak here only. Both are the separate. So once it is for the new nomenclature, that is metabolic dysfunction associated steatotic liver disease, is released in June 2023 at EASL conference, and many other organizations has also accepted this new nomenclature. This steatotic liver disease is broad spectrum of disease which is consisting of various stages of metabolic disorder, in which the first one comes to the metabolic dysfunction which are associated with the deposition of fat in the liver. Followed by, we can see the similar kind of the situation also may occur in the alcoholic induced or alcohol associated liver diseases, but once it is not associated with alcohol consumption, then usually we calling it non-alcoholic fatty liver disease. And once it is with the specific etiology which is causing the deposition of the fat in the liver, may it be because of certain drugs, may it be because of the liver injury caused by certain drugs or monogenic diseases, and sometimes there may be certain miscellaneous reasons for the same, that is called as steatotic liver disease. So which type of the patient will be considered for this very particular nomenclature, that is the metabolic dysfunction associated steatotic liver disease? This includes the fatty deposition of the liver with one of the 5 cardiometabolic risk factors. What are those risk factors? One is the elevated triglyceride, another is the low level of the HDL cholesterol, then patient is having the type 2 diabetes or pre-diabetes, and obesity, high blood pressure. So these are the 5 cardiovascular, cardiometabolic risk factors. If any one of them is associated with the deposition of the fat in the liver, that is called as steatotic liver disease, is called as MASLD. So let's have a case scenario of the MASLD to make our understanding better. This is a patient of a 49-year-old male patient, visited outdoor of the routine checkup. BMI is 25.8. Alcohol consumption is less than 20 gram in a day, which is considered as non-alcoholic. Comorbid conditions are the known case for the type 2 diabetes for last 6 years. Currently taking the medication atorvastatin 20 milligram and dapagliflozin 10 milligram combined with the metformin. Patient was advised for the laboratory tests for the routine checkup, which are the CBC, lipid profile, sugar profile, and liver enzymes, AST/ALT. Now what is the lab test says? In the lipid profile, we can see there HDL cholesterol is 38, which is lesser than what is required, and triglyceride, which is high than what is required, is 210. Total cholesterol is very well in the range 175. LDL cholesterol is also in the specific recommended range, that is a 97. If we talk about the sugar profile or diabetes profile, we can see that HbA1c 6.2, all the postprandial plasma glucose and fasting plasma glucose, both are ranging in the pre-diabetes, and HbA1c also ranging in the pre-diabetes. Liver enzymes are mildly raised, platelet count is 149. Now further follow-up based on the lab report, patient was advised to go for the abdominal ultrasonography and FIB-4 index, which was in an online calculator to evaluate the NAFLD. Results were that moderate fatty liver disease could be seen in the abdominal ultrasonography, and FIB-4 index has given the 2.11, which was based on the age, liver enzymes, and platelet count. Let's come over to the, will this patient be considered as a MASLD? Whenever a patient with type 2 diabetes, it is having an association with the fatty liver disease, this is a patient of the MASLD. And if it is having the factors or cardiovascular risk factors which are really making him more prone to develop the cardiovascular adverse outcome like high triglyceride and low HDL. So as per the latest recommendation, this patient has steatotic liver disease or fatty liver disease with at least one cardiometabolic risk factor, and it will be considered as a metabolic dysfunction associated steatotic liver disease. Now come over to the management of this MASLD. MASLD is a part of the multisystemic disorder where liver is victim but other organs are also affected. You can say that, you can see it here in this slide, that MASLD is impacting multiple organs of the body, including the kidney, including the endocrine system, is also making a person prone to cancer, infections, and many a times we can see that obstructive sleep apnea is also a result of obesity and metabolic alcoholic steatotic liver disease. And cardiovascular adverse outcome is of course the most important adverse outcome. So NAFLD prevalence, if we talk about that, 25% across the world and 38.6% in India, 58.2% in patients with metabolic disorders, and 35.4% in pediatric age group. So it is associated with higher cardiovascular outcome. If we look over the pathophysiology, it is associated with the inflammation, adipose tissue deposition, what we call at the fatty liver deposition, and all these things are also associated with high insulin resistance, which is associated with the RAS activation, that is the renin-angiotensin and aldosterone system. Oxidative stress is increased as a result of that, and it is actually responsible for vascular inflammation, lipid deposition inside the blood vessel, causing the process of the atherosclerosis more faster, and vascular remodeling takes place, which also is associated with the vascular endothelial injury, and hypercoagulative is the adverse end outcome, which is responsible for the coronary artery disease many of the time in such patients. MASLD is associated with more cardiovascular events and mortality. Prevalence of the MASLD is more common than NAFLD, because whenever we were defining NAFLD, it was simply a deposition of the fat without consumption of the alcohol. But now when we talk about the MASLD, it is associated with one or more cardiovascular risk factor, and also it is giving rise to the cardiovascular events and mortality as a result of its occurrence. The prevalence of the cardiovascular events, what we can see in the NAFLD versus MASLD, NAFLD was leading and finding only the 9% of the risk of cardiovascular events, while 43% MASLD is giving an indication that it can be giving a prediction of the cardiovascular event. As far as the fatal cardiovascular events are concerned, NAFLD was predicting only 3.4% of the cardiovascular event, while the MASLD is predicting a 14.3% cardiovascular event. Cumulative cause mortality is again found to be more than 2.5 times of the prediction which has been done by the NAFLD, what is actually we are getting, while MASLD and its new definition. Type 2 diabetes accelerates the progression of the fibrosis in non-alcoholic fatty liver disease. And this has been studied widely, in which over the period of 12 years, it has been concluded 73% higher risk of the fibrosis was seen with the progression in type 2 diabetes patients. So type 2 diabetes patients are obviously on the higher risk of the fibrosis of liver, as well as NAFLD is being converted into the NASH. In type 2 diabetes, progression of NAFLD to cirrhosis and related mortality is also higher. If we compare no diabetes with the type 2 diabetes, we can see that NAFLD is converting to the NASH in 10 to 20%. On the other hand, it is converting to the NAFLD to the NASH in 40% type 2 diabetes patient. So obviously the patient, those who are having the type 2 diabetes, they are on the 2 times on the higher risk of getting NAFLD patient being fibrosed to end up with the NASH and cirrhosis. Let's talk about the recommendation for the diagnostic approach. What does the recommendation say? In this MASLD patient, what has been discussed, patient was asymptomatic, he was not having any problem, but all major guidelines says that screening of the patient with the cardiometabolic risk factors, like those who are carrying the disease of the type 2 diabetes, obesity, metabolic syndrome, high triglyceride, low HDL and high blood pressure, they should be screened for MASLD. And screening method should be abdominal ultrasonography, PIP4 index, transient elastography, and all methods are strongly recommended by guidelines. So if we talk about the PIP4 index to evaluate the advanced fibrosis, this is a most promising method which has its benefits of wide spectrum availability. Only 4 parameters are required to calculate, and you can very easily do it calculation on the web portal. Quickest way to evaluate probability of the fibrosis, and higher positive and negative predictive values are there, and of course the cost is very minimal. On the limitations, on the other hand, are not confirmative assessment. It is needs further evaluation through VCT or liver biopsy is required to reach to some conclusion whether a patient is having the MASLD or not. So how will we doing the confirmation? Obviously the liver biopsy is a very difficult process and cumbersome for a patient to go. That's why vibration controlled transient elastography is a better method in which we can reach to the conclusion whether the patient is carrying the MASLD or not. High triglyceride is now considered as a cardiovascular risk factor for fatty liver. Has to be confirmed by imaging or biopsy does the patient meet any criteria, that cardiometabolic criteria, and if any of those cardiometabolic 5 criteria, which has been discussed earlier also, that either a patient is having type 2 diabetes, or the patient having hypertriglyceridemia, or there is a low HDL, or patient is having obesity and high blood pressure, then it would be coming into the definition of MASLD. Triglyceride is strongly associated with NAFLD among markers of the hyperlipidemia and type 2 diabetes. In this study, which has been done at total 256 evaluation patients, in the present triglyceride had the largest X2 and the smallest p-value, which indicated that triglycerides were more closely associated with the NAFLD than VG and blood glucose and HbA1c. So triglyceride to HDL ratio has been considered a surrogate marker for the non-alcoholic fatty liver disease. It is independently associated with non-alcoholic fatty liver disease in apparently healthy individuals and may be used as a surrogate marker. So let's talk about if we can confirm, and if we have reached to the conclusion that MASLD is there, then what to do. Obviously the patient is already taking the atorvastatin, so we are addressing the HDL and LDL issues already. But how can we really address the hypertriglyceridemia issue? And why should we really be addressed this? Residual CVD risk, which is there despite taking the statin, despite taking the full dose of the statin, that is responsible for a lot of cardiovascular adverse outcome because of the hypertriglyceridemia and of course because of the low HDL level, which has been proven in the HBS study and CARS study both. Higher triglyceride is associated with higher cardiovascular risk in diabetes patients. Every 50 milligram per deciliter increase in triglyceride level has been associated with increase in cardiovascular death, cardiovascular risks like MI and stroke 3.2%, and increase in cardiovascular death was 5.8% with the hazard ratio statistically significant 1.058. So another study in which we could see that remnant cholesterol and triglyceride, which was not LDL cholesterol, associated with incident cardiovascular disease. The same study has also reached to the conclusion triglyceride, non-HDL cholesterol and remnant cholesterol and even atherogenic dyslipidemia, which is having the high triglyceride more than 150 milligram per deciliter and low HDL cholesterol less than 40 milligram per deciliter in men or less than 50 milligram in women, were associated with major advanced cardiovascular end outcomes. A case presentation of the MASLD in which we discussed the same case which has been discussed, lab test results were these. In such situation, the patient which has responded to the treatment well with saroglitazar 4 milligram, so he was continued with the same treatment. Tablet atorvastatin was continued 20 milligram once a day. Dapagliflozin continued 10 milligram. Metformin continued with that 1 gram because it was sufficient to control the diabetes and keeping the patient into the pre-diabetes range. And when it continued after a 4 months, patient came back, we could see that patient further improved as the previous value. On the other hand, we could see that lipid profile have been found to be improved from HDL-C 38 to 40, triglyceride reduced from 200 to 210 to 175, and liver enzymes has also come down to the range of normalcy. So tablet saroglitazar 4 milligram once a day, which has been only approved medication for the NAFLD, have been found to be working well in the metabolic steatotic liver disease. Treating hypertriglyceridemia, now question again, when should we treat the hypertriglyceridemia? Should every patient of the hypertriglyceridemia be treated with the saroglitazar or any other medication? What should be the, if yes, then what should be the method of treatment? Triglyceride cutoff value as per the recommendations of the guideline says that ATP3 classification of the serum triglyceride is less than 150 is considered normal, 150 to 199 is considered borderline high. If it is between 200 to 499 is high and more than 500 is very high. Now question arises, when to treat? Primary aim of the therapy is to reach LDL goal, intensify weight management, increase physical activity. If triglycerides are still more than 200 milligram per deciliter after LDL goal is reached, set the secondary goal for the non-HDL cholesterol, which is the total HDL, which is less than 30 milligram per deciliter, higher than LDL goal. So now the question arises, if you are making the triglyceride up to the optimum level, obviously you are getting in the safe zone, but if not, then you need to target the HDL as well as LDL too, and of course the LDL is already in the range, so our target should be the HDL rise after the triglyceride lowering. If triglyceride is more than 200 but less than 499 after LDL goal is reached, intensify therapy with the LDL lowering drug, like add triglyceride lowering drug to further lowering of the ratio of triglyceride with VLDL. If triglyceride is more than 500, then first we should lower the triglyceride to prevent the cardiovascular event as well as to prevent the pancreatitis. And it is also to be associated with the very low fat diet, weight management, physical activity and triglyceride lowering agent. Now, critical importance of the high triglyceride reduction, which has been endorsed by the European Society of Cardiology, says that statin treatment is recommended as the first drug choice to reduce the TVD risk in high-risk individuals with hypertriglyceridemia. So, statin treatment is mandatory. There is no confusion that we should start the statin treatment up to the maximum acceptable dose wherever the patient can accept without any difficulty. In high-risk patient with triglyceride level between 1.5 to 5.6 millimole per liter, or we can say 135 to 499 milligram per deciliter, despite statin treatment, N3-2-far polyunsaturated fatty acids are considered with a statin as a supplementation therapy. In primary prevention patients who are at LDL cholesterol goal with triglyceride levels more than 2.3 millimole per liter or more than 200 milligram per deciliter for our Indian measurements or Indian methods of the lab measurement, fenofibrate or bezafibrate may be considered in combination with statin. But in high-risk patients who are at LDL cholesterol goal with triglyceride level more than 200, fenofibrate or bezafibrate may be considered in combination with statin. Now the question arises, these critical importance of the high triglyceride reduction has also been endorsed by the American Association of the Clinical Endocrinology in 2022 and which has also been strongly recommended. RSSDI 2022 has also given the consensus statement in decision of pathway of triglyceride reduction. They also said, RSSDI 2022 said that stepwise management strategy for Indian patient with diabetic dyslipidemia is required, and they recommended to stratifying the risk for atherosclerotic cardiovascular disease dividing between less than 40 years of age or more than 40 years of the age and calculating the atherosclerotic cardiovascular disease rate. They have also recommended to set lipids goal as per the atherosclerotic cardiovascular disease risk and recommended to initiate and escalate the lipid lowering drugs based on the established goal. And for the triglyceride correction, recommended the first medication statin followed by the fibrates and saroglitazar and finally the omega-3 fatty acid as per the RSSDI 2022 recommendation. So treating the hypertriglyceridemia, what is the pharmacological option with us? We are having the high triglyceride in type 2 diabetes patient. Obviously, all these pharmacological options are not really working. That's why we are desperate to find the solution. Which of these drugs are acting on an insulin resistance, the root cause of the type 2 diabetes? Obviously, metformin is supposed to work on the root cause of the type 2 diabetes, that is the insulin resistance. But many of the times we can see still the patients are living with diabetic dyslipidemia. They are finding themselves in this adverse cardiovascular outcome prone situation. So clinical development of the saroglitazar has seen that saroglitazar was rationally designed to have the higher specificity for PPAR alpha to optimize beneficial effect on lipid control and minimize adverse effect as compared to the PPAR gamma activity. Effect of a dual PPAR alpha and gamma agonist on insulin sensitivity in patients of type 2 diabetes with hypertriglyceridemia, we could see in randomized double-blind placebo-controlled trial that insulin sensitivity and glucose metabolism both have been improved after the 4-month use of the saroglitazar. Study results were encouraging for insulin resistance, may it be for the HOMA-IR, HOMA-beta, may it be for the HbA1c, insulin sensitivity and fasting plasma glucose. There has been a surrogate integrated review analysis which has given an idea that surrogate in diabetic dyslipidemia and non-alcoholic fatty liver disease is integrated analysis of the real world evidence has shown that surrogate effectively and safely reduces not only the triglyceride from non-HDL but also the small density LDL, HbA1c and liver enzymes too. 52-week safety and efficacy of the surrogate in Indian diabetic dyslipidemia, atherogenic diabetic dyslipidemia patient has also find it beneficial till the 52 weeks long period. The clinical scenario could be seen even from the Mexico study was also favorable to use the surrogate as compared to the fenofibrate. So summarizing the talk, MASLD, which is the metabolic dysfunction associated steatotic liver disease, is redefined from the NAFLD. And the NAFLD, which was only having the non-alcoholic fatty liver disease, now have been added with one cardiovascular risk factor. Association of at least one cardiometabolic risk factors may it be obesity, type 2 diabetes, hypertension, high TG, low HDL with liver fatty deposition is considered as MASLD. Screening and diagnostic tests like ultrasonography, PIP4 index and VCTE are strongly recommended. Lifestyle modification and weight reduction are the mainstay of the therapy. First line management should be with that, and then we can consider the use of the drug like saroglitazar, which has already been approved for the medication to treat the non-alcoholic fatty liver disease, even in patients with metabolic disorders in India, those who are really having the MASLD as per the approved definition. Thank you very much for your kind listening.
Thank you, sir, for an excellent overview about the metabolic treatment disorder, especially hypertriglyceridemia and liver diseases. So, any questions or comments from the audience? One or two questions.
Sir, where do you place this saroglitazar in the hierarchy of treatment for MAFLD? Where do you place it?
Pardon?
Where do you place this drug, saroglitazar, in the hierarchy of treatment, whatever drugs that are available, where do you exactly place it?
Yes. First, we should definitely, if we are talking about the dyslipidemia or NAFLD treatment, obviously the statin therapy is must whenever we are talking about the dyslipidemia. But once we are talking about the non-alcoholic fatty liver disease, then it is a treatment in, this is a treatment in total. And in total or comprehensive treatment is required, and comprehensive treatment not only includes the correction of the triglyceride level, that also includes the correction of the glycemia level, diabetes level, LDL level, as well as any other risk factor if it is continuing. Like even smoking is also one of the very important risk factor, and that cessation is also very much needed. So whenever we talk all these things, it's not a one drug solution for NAFLD or MASLD. We should have all these things together, but the statin is must to continue. Saroglitazar can be used as a add-on to the statin, but as well as the diabetes treatment in whatever way. Better SGLT2 inhibitors and GLP-1 receptor agonists are the more preferred therapy for the diabetes treatment if we are really working for the NAFLD. There are certain data that DPP-4 inhibitors also works good in the MASLD and NAFLD. If these things are there, then obviously the saroglitazar could be a natural choice to add on if patient is not controlled, and it should always be preferred over the fenofibrate. Yeah, pioglitazone has also been found to be very much effective for the NAFLD. There has been a lot of studies in which pioglitazone has been recommended for the NAFLD, but whenever we talk about the MASLD, MASLD is also including the treatment of the diabetes. So treatment of the risk factors which are occurring with the diabetes. So pioglitazone could be a choice, but once you are using the pioglitazone, you cannot use the saroglitazone. Difference between the saroglitazar and pioglitazone is that pioglitazone only acting on the PPAR gamma, while the saroglitazar is acting on the PPAR alpha as well as PPAR gamma. So once it is acting on the PPAR gamma only, then it is controlling the diabetes only. But once it is acting on the PPAR alpha and gamma, then obviously the diabetes management may be little modest, but the correction of the dyslipidemia, correction of the NAFLD, correction of the triglyceride would be in a very stronger way.
Sir, I want to make a quick comment about this. So you have very well highlighted the importance of triglycerides in the and in the causality of NAFLD, because we did a study with TG/SDL ratios in people with diabetes, and we were surprised that the TG/SDL ratio was 4.5 in our study as compared to 0.9 or 1.2. That is what is suggested as the cutoff for the TG/SDL ratio. So treating triglycerides, I think, is very, very important and very pertinent, and you have very well brought out this thing. Thank you, sir.
Yeah, most of the people agrees that treating the hypertriglyceride is very, very important. The only difference of opinion is what should be the cutoff, whether we should treat it at 200 or we should treat it at 500. So this thing is to be resolved. Majority of the endocrinologists think that 500 should be the cutoff. But between the 200 and 500, we are having a lot of adverse cardiovascular adverse outcome, which are encouraging to use it before reaching to the 500.
Sir, thank you for such a nice presentation. You have clearly mentioned about when to start. Sir, I have a question: when to stop, when to discontinue, when needed, like
when to stop saroglitazar?
Yes.
Yeah. Okay. Saroglitazar is a very benign drug. It's not really required to stop. If you are using this for the correction of the NAFLD, correction of the diabetes, and correction of the hypertriglyceridemia, you can continue it throughout your life. No need to stop until unless you find any difficulty of using, some intolerance is occurring to some patient. As of now, no such adverse event has been noticed which says that it should not be used in certain patients. Although only in the patient, those who are using the pioglitazone, saroglitazar is not recommended to be used. It should not be used with the pioglitazone. I have already told it that GLP-1 receptor agonist, not only the semaglutide, any GLP-1 receptor agonist is having very good role for the NAFLD as well as MASLD. Because once we talk about the only NAFLD, it is working there only. Then once it is added up with the metabolic risk factors, obviously that becomes the first choice of that. If you are treating your patient diabetes with the GLP-1 receptor agonist, may it be semaglutide, may it be any other liraglutide or whatever, you are doing the best possible treatment for avoiding the NAFLD and fat deposition kind of the situation. But still, yes. What is the role of? Obviously, it has its role in the NAFLD, but always it is considered in association with the overall treatment. Comprehensive treatment is required. Whenever we are talking about any such therapy, it should always be used with the basic therapies. Obviously, if we are treating the diabetes with the metformin only, then probably the patient may not be that much protected for the fibrosis of the liver if we are using with the semaglutide or any other GLP-1 receptor agonist. Dapagliflozin is also, or any other SGLT2 inhibitor is also equally effective in bringing down the fibrosis risk.
Thank you, sir, for your very excellent deliberation. So one very simple question. So do you think that because of the hype of MASLD, saroglitazar is going to be misused in recent future?
No, actually, there are the two things. One is that saroglitazar is very benign drug, and even if you are using it in your patient, then is not going to harm your patient. And we have used it for last 10 years. I remember when I presented the 2 years data of the saroglitazar in ACE, one very renowned physician of the world came to that paper and came to that poster and asked me Dr. Maheshwari, if you will say the same thing after 5 years, I will be accepting your version, what you are saying. But now it is 10 years, and 10 years we have not find any major adverse effects which is occurring because of the use of the sarbatazar. So it is safe drug, no, there is no chance of the misuse, and on top of that it is so costly, no one can dare even to misuse, because as of now it is 36 rupees, one tablet cannot be used to each and everyone unless it is really desired or required.
Thank you, sir, for your nice talk and for answering the queries. So may I invite the next speaker, Dr. Parthasarthi Karmakar, to speak on the pulmonary function test and its interpretation in different settings.
Good afternoon, respected chairpersons and the learned gathering present over here. So before coming to my topic, I like to express my heartfelt gratitude to all the team members of organizing committee, in particular Dr. Anuj Maheshwari, Dr. Birmani, and our Dr. Jayant Panda. So with this, I like to talk upon pulmonary function test and its interpretation in different clinical scenario. So I will touch upon this briefly. I will go through briefly with this, with these points to cover the topic, that is our pulmonary function test. So may I go through this? May I go through this common pulmonary function test volume loop, that is flow volume loop for the PGTs. Probably there are some PGTs. Can you tell me what it tells about this thing? The first upper panel, the light is not functioning probably. Light is not functioning. Okay, on the upper panel, is it normal or pathological? Any PGT, please feel free to interact. Then the second one on the upper panel, the middle one, the PFT shows some scalloping on the descending loop. Then the third panel, that shows miniature of the normal loop. Yes? Anyone? Yeah. Then the lower panel, the left one, the expiratory flow is almost normal, the inspiratory flow is really flattened. And the last one, both the expiratory flow and the inspiratory flow, both are flattened. So I will come to that, what are the answers. Before that, I will go for short discussion with that. So pulmonary function test, it is clinically useful. It is clinically being used since 1846 when Hutchison first described vital capacity. And pulmonary function tests are really functional status and diffusion capacities of the lung is being detected through set of tests, spirometry, diffusion study, and body plethysmography. And spirometry, among all these three, spirometry, diffusion study, and body plethysmography, spirometry is the simplest, most commonly performed, and most clinically useful test for assessing pulmonary function. Now coming to spirometry, it is a method you all know, that is measuring the total volume of air the patient can expel from the lungs after maximal inhalation. Now, how it looks like. So that is the machine which is being utilized over here, and here it is in our institute. Another machine is being used, and that is the mouth being fit in the within the oral cavity, and that is tightly fit, and the curvature is being, that loop is being taken over the computer. So here in that computer, the loop is being shown. So there are other different types of, it's not functioning properly. There are other different types of handheld spirometers. Now the indications of PFT when we do go for PFT. One is breathlessness associated with wheeze or cough, and that is asthma, COPD or ILD. And preoperative assessment, sometimes it is necessary to assess the function of the lung before abdominal CTVS, that is cardiothoracic surgery, lung dissections, and some connective tissue disorders, neuromuscular disorders, and response to therapy. So contraindications, you have to know what are the contraindications. Definitely the ischemic heart disorder in the form of MI within 1 month, unstable angina, stage 3 hypertension, and recent operations done upon eye, abdomen, and thoracic surgery, pneumothorax, as well as active hemoptysis. Now, what are the don'ts in PFT? That is very important, and I have shown you in time slot, 30 minutes, 1 hour, 2 hours, and 4 hours. No heavy exercise within 30 minutes, no smoking within 1 hour, no large meal within 2 hours, no alcohol within 4 hours, and there should not be any tight clothing, and no breathing medication should be there as far as bronchodilator. So just the physiology refresher. We all know, we have come through this in our early part of MBBS course, and just the physiology refresher, and I will go through, there are so many fragmentations of the PFT, but I will go through only 3-4 data which are very essential for assessing the PFT. What are those? One is tidal volume, you all know. Then comes the most important part so far the PFT is concerned, that is your forced vital capacity, FVC, forced vital capacity, that is maximum inhalation after maximum exhalation after maximum inhalation. Then very important another part, that is your forced vital FEV1, that is from after maximum inhalation up to, that is in 1 second, how much patient can exhale, and that is the most part of the FVC is being covered within that 1 second. Then comes your total lung capacity. That is sometimes necessary if you are in dilemma whether you are dealing with a case of obstructive or restrictive sort of disorder. Now basic parameters that out of all those, there are so many parameters, out of all those only basic parameters that we are really in need of, that is FVC, forced vital capacity, then coming to FEV1, forced expiratory volume in 1 second, and FEV1 by FVC ratio, and then the total lung capacity and reversibility after drugs, whether it is there or not. So only these, specifically FVC, FEV1 and FEV1 by FVC is the most important parameters to assess majority of lung function tests. So what is normal? So far you all the time try to compare your patient's data with the predicted value, and predicted value, I will talk upon that in my later slides. Whatever predicted value has been shown by the computer, your normal value is, there is a wide range between 80% to 120%. So out of that predicted value, if your patient's data varies between 80% to 120%, it is within normal limit. And FEV1 by FVC, all the time more than 0.7 in normal person. So that is the normal curvature, how it looks like. So far the flow volume curve is concerned. Now this is the volume, that is your volume time curve. You see that within 1 second, what I said, that within 1 second almost 4 liters out of 5 FVC is covered within 1 second. Then the less 4 liters are being expired in the rest 5 seconds. So FEV1 is very important, and FEV1 and FVC ratio, if it is more than 0.7, it's normal. Below 0.7, it is always suggestive of obstructive disease. So be aware of FVC, FEV1 and ratio of FEV1 by FVC. Now the spirometry obstructive disease, what I was talking about. So I am directly going, it is so disturbing, I am directly going to the value. So here one example I have shown, but what you have to think that what is the value of FEV1 by FVC? If it is 0.7 and the forced vital capacity is almost normal, around 80%, or in some patients maybe little bit below normal. So FVC almost nearing normal value, but FV1 by FVC less than 0.7, you are dealing with obstructive disease. Now coming to restrictive disease, just the opposite of obstructive. Just the opposite, that is FV1 by FVC more than 0.7. So factor ratio of FEV1 by FVC more than 0.7, but FVC, that is forced vital capacity, less than 80%. That means the upper value is normal and the lower value FVC is less than 80%. Just opposite to that of obstructive value, the obstructive sort of pattern of pulmonary function test is your restrictive one. So when you get the restrictive sort of pulmonary function test, there are pulmonary causes, extrapulmonary causes. Among the pulmonary causes, fibrosing lung disease, you all know, ILD, then pneumoconiosis, pneumothorax, and some of the pulmonary, your pulmonary tumors. But extrapulmonary causes, you have to think about some neuromuscular disorders and as well as some kyphoscoliosis. These are the causes of extrapulmonary disease. Now FV1 by FVC 0.7 mixed, there could be some, you may come across some patient where you will see in your PFT that there are some obstructive as well as some sort of restrictive sort of pattern. And how will you consider? You will get FVC and FEV1 both low. FEV1 by FVC ratio below 0.7, that is indicative of obstructive, and FVC less than 80%. So both low, both 0.7 and the FVC less than 80% is always suggestive of mixed disorder, that is your obstructive restrictive sort of pulmonary disorder. So I am showing here the curve. So sometimes whenever you are coming across obstructive restrictive sort of pulmonary disorder, you have to go for some other tests like DLCO and all these things to come to a conclusion what you are dealing with. Now how you do approach so far your pulmonary assessment is concerned. First of all, I told you that predicted data will be given by your computer. Whenever you will show that patient's age, sex, race and ethnicity, that will show the predicted value of that very particular patient so far his age, sex and ethnicity and height is concerned. So these are the things needed for getting the predicted value of this very particular patient. Now, you have done the test, whether that is acceptable or not. Because pulmonary test, function test is always, you need 100% cooperation from the patient. You have to make him or her understand what you want. Has to blow during expiration as fast as heard as possible. So he has to put his speed to its maximum extent as well as the maximum amount of air to be exhaled. So that is the acceptability is to be ensured. How it is ensured? So I am coming to that. How will you know that yes, you have done that cumbersome job in a proper way? So you have to be, there should be free from artifacts, that is the cough, then the free from leaks between the lips and the mouth, then the machine's adapter, then the good start and good effort. All these things are necessary. And how will you judge that from the look that yes, it is an acceptable look? So if you go through this, the previous one, you on the left side upper panel, you can see the curve is very smooth. It has reached its peak within 1 second, and then it is it is reaching the plateau. And on the left side, the upper panel, it is showing again within 1 second it is reached the down, then the downsloping of the exhalation is quite, that downslope is quite smooth. There is no wavy character. But on the lower panel, you can see there are wavy, and due to cough, the exhalation has been interrupted. So lower panel is not acceptable, but the upper panel is accepted. Now coming to after acceptance, you have to whether it has got reproducibility or not. What do you mean by reproducibility? If you ask the patient to go for that thing again, that will be matching with the acceptable curve. And that is being judged if you go for 3 maneuvers, you have to go for 3 maneuvers. Out of that 2 maneuvers best within variations of 0.15 liter, then it is reproducible. So any pulmonary function test, you have to go through the loop and you have to see whether it is acceptable by, as I have shown in my previous letter, and whether it is reproducible. So after that, you will go for judgment whether patient is having obstructive or restrictive or mixed type of disorder. Very early within 1 second, and that is the normal panel. The second panel, you can see the downslope of the expiratory flow. Upper panel, the downslope is showing concavity and it is scalloped. So if you see that sort of curve in the expiratory loop, it is suggestive, but the inspiratory loop, the lower one, is not at all affected. It is suggestive of obstructive. Then coming to the third panel on the upper row, that is showing that the miniature form of the normal loop. Whenever you are getting miniature form, the inside loop is almost the miniature of the outside loop, that is the normal loop. It is all the time in favor of restrictive sort of disease. And then I am coming to the lower panel, the left side. You can see the expiratory loop is almost normal, like that of the upper left panel, upper left curve. After getting that, the preliminary pulmonary function test loop, you have to go for obstructive pattern or restrictive pattern. So I told you whatever varying from 80% to 120% wide range of predicted value, it is normal. So not to go for the FEV1 FVC as it is more than 0.7, that means it is restricted. No, calculate the other two important data. Now here, if you see the FVC and FEV1, both are reduced, red color, both are reduced. FEV1 by FVC is increased, 84. So FVC, forced vital capacity is low, FEV1 is low, but FEV1 FVC 84, that is 0.8, that is more than 0.7. So banking upon that FVC is low and the ratio is more than 0.7, that is 0.8, that means you are dealing with a case of restrictive pattern of disease. That is restrictive pattern. So sometimes, 1 minute more, sir. Sometimes we have to go for, apart from the pulmonary function test, sometimes if you are in dilemma, you may have to go for DLCO. What is DLCO? Diffusion lung capacity with carbon monoxide. So that's a separate tissue taking 0.3% carbon monoxide and 13% of helium. Patient, that gas mixture, patient is asked to take a rapid deep inhalation. Hold it for 10 seconds, then exhale it. And we go for how much carbon monoxide has been utilized. And depending upon that, in restrictive disease, if you have dilemma, if it shows low value, then intrinsic diseases. If it shows there is no low value, then the extrapulmonary causes of restrictive disease like your obesity, neuromuscular disease, and chest wall deformities in the form of kyphoscoliosis you have to think of. Similarly, if you are dealing with an obstructive disease, so far the pulmonary function test is concerned, if you are getting low value of DLCO, it is emphysema, you are getting normal value in asthma. Sometimes you are not getting restrictive or obstructive pattern in PFT, but you are getting DLCO low. In that cases, you don't think about the pulmonary, any parenchymal disease, but think about the pulmonary vascular disease. So far the summary is concerned, PFTs are valuable tests for evaluating symptoms of dyspnea. If you interpret it properly, along with the clinical data and clinical scenario, you will be able to cleanse the diagnosis if there is any dilemma. Approach this interpretation systematically, and PFTs provide a pattern of physiology of lung function, not the diagnosis. You have to, whether it's a restrictive pattern, obstructive pattern, or mixed pattern, you have to, ultimately, you have to come to a conclusion through clinical scenario of that very particular patient. Thank you for your patient hearing. It's very difficult to maintain your flow.
Thank you, sir, for your...
This one is not functioning, that is sometimes functioning, sometimes laptop is functioning, sometimes that one not functioning.
Thank you, sir, for your lucid presentation. Any questions from the audience?
Sir, indication in, can we do PFT in pregnancy patients?
Yeah, there are some contraindications. In pregnancy, better not to go for that. In contraindication, there is pregnancy, there is hemoptysis, myocardial infarction, or unstable angina. These are the contraindications for PFT.
So, thank you, sir.
Thank you.
Thank you, sir, once again. So, for the next topic, may I invite Dr. B.M. Makkar, sir. He will be speaking upon the topic vitamin D and insulin resistance in type 2 diabetes mellitus. RID insulin resistance study, a research initiative of ACP India chapter. Please.
Good afternoon, friends. At the outset, I would like to thank Dr. Anuj Maheshwari, Governor ACP, and also, of course, Team ACP, IM ACP India conference for this great opportunity, and also giving me opportunity to be part of this important ACP study called RID-IR study, or real world study on looking at the impact of vitamin D on insulin resistance. Can I have my presentation here? Hello? Either? So this study is looking at the impact of vitamin D deficiency on insulin resistance among people with type 2 diabetes in India, and what I am presenting here is interim analysis from an ongoing real world study. This is the disclosure slide. This study has been provided academic grant from Alchem Laboratories Limited. We all know type 2 diabetes is a major healthcare challenge in India. Vitamin D seems to be a regulator of numerous events that are responsible for normal insulin sensitivity and beta cell function. And vitamin D deficiency has been shown to increase insulin resistance and risk of developing type 2 diabetes. Furthermore, insulin resistance has been linked to multiple disorders such as obesity, type 2 diabetes, its complications, metabolic syndrome, PCOS, and so many other diseases. Now, important thing is whatever data we have, over last 2 decades, there is no conclusive data showing a great link between, there is indication of link between insulin resistance and beta cell dysfunction with vitamin D deficiency, but there are conflicting reports also. So on the upper part of this slide, you will see a meta-analysis which looked at the serum and supplemental vitamin D levels and insulin resistance. This is a meta-analysis and systematic review and showed that vitamin D has shown significant effect on regulation of insulin resistance, and there is a significant inverse association between vitamin D levels and insulin resistance. On the other hand, the second meta-analysis and systematic review showed that there is no evidence that vitamin D supplementation has a beneficial effect on peripheral insulin sensitivity in people with or at risk of insulin resistance. So primary objective of this study is to understand the impact of treatment of vitamin D deficiency on glycemic control as well as insulin resistance in people with type 2 diabetes. Now, this study is planned as a prospective observational multi-center real-world study with a sample size of 400 patients. This study is being conducted across 35 sites across India, and all type 2 diabetes patients fulfilling the inclusion criteria are eligible to be enrolled in this study. Now, inclusion criteria are that person should be adult, male or female in the age group 18 to 60 years with a clinical diagnosis of type 2 diabetes and vitamin D insufficiency, anything between 0 to 30 nanograms per ml. A1C in the range of 6.5% to 9% and currently treatment naive as far as vitamin D treatment is concerned. Patients should be willing to take the vitamin D treatment for insufficiency, that is a soft gel of 60,000 units weekly for next 3 months, and follow up for the repeat vitamin D level, and should be willing to give informed consent. Exclusion criteria are people not fulfilling the inclusion criteria and not willing to give consent. In addition, people who are on insulin therapy, who have undergone bariatric surgery, or who have history of renal, liver or bone disease. All patients were initiated on vitamin D 60,000 units soft gel capsules once a week for 12 weeks, and vitamin D levels were measured again after 3 months therapy. The primary endpoint was mean change in the vitamin D levels, HbA1c levels and HOMA insulin resistance levels. Secondary endpoint was the mean change in body weight, body mass index, LDL cholesterol levels, blood pressure levels and serum creatinine levels. So what I am presenting here is the interim findings. These findings are from the data covered till 1st of September 2023. That is the beginning of this month. At baseline, we enrolled 406 patients, and we have follow-up data of 89 patients, which is included for this analysis. Now, if you look at the patient population, the type 2 diabetes, the average duration was around 5.6 years, with 54% of patients being male. Now, interesting thing if you see here again is that more than 50% people had duration more than 5 years. And another 30% had duration of diabetes more than 5 to 10 years. That means almost 80% of the patients had duration of 5 to 10 years, and the age group is less than 60 years of age. So we have very early onset of diabetes, type 2 diabetes in adults. This is the age distribution. So 50% of more than 50% of the patients were less than 50 years of age. And if you look at the body mass index, 2/3 of the people had obesity by Indian cutoffs. That means they had BMI of more than 25, and another 17% had BMI of more than 23. So almost 80% of the patients had obesity or overweight. This is the A1C levels. Almost 2/3 had A1C more than 7%, and only about 36% had A1C level of less than 7%. The average fasting sugar level were 132.8. The postprandial glucose average was 190, and average random glucose was 152. The LDL levels were 110 on an average. HOMA-IR average was 2.4. And the vitamin D level average was 20.7 nanograms per milliliter. So there was significantly low vitamin D levels in people with type 2 diabetes. Now, if you look at the overall distribution, 8.1% of the patients had severe deficiency, that is less than 10 nanograms per ml. 47.3% patients had less than 20 nanograms per ml, and another 45% patients had less than 30 nanograms per ml. Now, if we look at the distribution of insulin resistance, 40% of patients with low vitamin D levels had increase in HOMA-IR above 2 level. The HOMA-IR of 2.0 was considered as cutoff for defining increase in the insulin resistance in people with type 2 diabetes in this population. Less than 1 was seen in 30% of people, and 1 to 1.99 HOMA-IR was seen in another 31% of the people. But important thing to keep in mind is that 39% of the people with type 2 diabetes who has raised a HOMA-IR were on treatment for diabetes. So most of these people are on metformin also, that means the insulin sensitizer, still have an increased HOMA-IR despite being on treatment for diabetes management. There was no significant difference in the HOMA-IR score by severity of vitamin D deficiency. That means across the different segments of vitamin D levels, the HOMA-IR was similarly distributed, and there was no difference. Now, let us see the relationship of HOMA-IR with other parameters. So, if you look at this table, there was significant correlation, though the numbers, if you look at the absolute number of R factor, that is the coefficient of correlation, it was not very high, but it entered statistical significance if we look at the correlation with serum creatinine levels and fasting blood sugar level, and also significant correlation with BMI. The correlation with BMI was inverse correlation and achieved statistical significance. Now, this is the table which shows the vitamin D levels across the different levels of HOMA-IR, and again there was no difference in the relationship. There was no difference in the vitamin D levels in different segments of HOMA-IR. That means less than 1, 1 to 2, or 2 to more than 2. The vitamin D deficiency was persistently uniformly distributed there. And if you look at the different levels on the lower part of this slide, I will show you. here. So severe deficiency was also similar, deficiency and insufficiency. They were all equally distributed across the HOMA-IR levels. Now, this is the mean body mass index. Again, it was similar across HOMA-IR levels. The age groups, again, there was no difference, and there was no difference in the duration of diabetes also in people who with different HOMA-IR levels. If you look at the A1C levels, there was no statistically significant correlation between vitamin D deficiency and, the HOMA-IR level and the A1C or the serum creatinine levels. There was no significant correlation between the fasting glucose or postprandial glucose levels. Now let us see the important endpoints that we are looking at, that is the impact of vitamin D levels on HOMA-IR levels after 12 weeks of therapy. So the important thing is that there was significant improvement in the B12 vitamin D levels, that is to the tune of about 20 nanograms per ml after 12 weeks of supplementation with soft gel containing 60,000 units of vitamin D given weekly for 3 months. And after the if you look at the levels across levels of HOMA-IR, all the patients were able to restore normal blood levels for vitamin D. Important thing is, if you look at the change in HOMA-IR, the patients where there was increased HOMA-IR earlier, the 40% patients, after vitamin D supplementation, there was significant decrease in the HOMA-IR levels, while the patients who had HOMA-IR in the normal range, less than 2, there was no difference in the HOMA-IR levels. And that is expected. You don't expect normal HOMA-IR levels to change much after vitamin D supplementation, but those who have increased HOMA-IR, if it is improving insulin resistance, they are bound to come down. This is the drop in HOMA-IR at different levels of vitamin D deficiency. So if you look at whether it is less than 10 vitamin D or less between 10 and 20 or 20 to 30, the drop in HOMA-IR was significant if it was increased at the baseline. So with that, I come to the end of this presentation. The take-home message is that type 2 diabetes affects us Indians at a younger age. More than half of the type 2 diabetes patients have vitamin D insufficiency, and half of them at least have severe deficiency or deficiency. Treatment with soft gel capsules containing 60,000 units of vitamin D given once a week for 3 months raises the serum vitamin D levels significantly and brings them to the normal range. In this particular study, we used the 60,000 soft gels provided by Elchem, this study company which gave us the study grant also. Treatment with soft gel capsules containing 60,000 units of vitamin D given once weekly for 3 months can restore the normal vitamin D levels in people with type 2 diabetes who have vitamin D deficiency. In those with raised HOMA-IR, despite treatment with oral agents for diabetes management, vitamin D 60,000 units given once a month for 3 months can lead to significant improvement in HOMA-IR levels. Now, there are certain points to explore which are highlighted in this study. One is how long to give vitamin D to sustain normal vitamin D levels after you have achieved normalcy. What dose should be given to sustain normal vitamin D levels after you have achieved sufficiency for vitamin D, and for what dosing frequency should be done. So I think these are some of the things which need to be explored further after this study. With that, I conclude my presentation. Thank you very much for patient hearing. If there are any questions, I'll be happy to take that.
Thank you, sir. Any questions from the audience?
Sir, you have taken from 35 cities. You have recruited patients from 35 cities, I think.
From
35 cities, sites, 35 places.
35 sites, yes.
And total sample size was 400.
400. Actually, we thought of 40 sites, but you know, some sites don't initiate, so that is how the 35 sites are there. And total, we recruited 406 patients from 35 sites.
Sir, how have calculated the sample size?
So,
I think
you know, I am not the right person to give you calculation, but this was calculated for significance.
Because I think if you calculate the percentage of population, people with diabetes across the India, now it is around...
No. We are not doing a population. This is not a population-based study. This is a study done in people with type 2 diabetes in, you know, North India, where select centers who are already doing diabetes practices. So you can't take this as a representative sample for India.
Clinic-based study.
This is clinic-based study.
Clinic-based
Yes,
study.
yes.
Any other question? So we can wind up this session. Thank you, sir, for the lucid
Thank you.
presentation.
Thank you so much.
Thank you, doctors, for such wonderful deliberations. I request the speakers and the chairpersons to collect their mementos from the left side. Thank you so much.
Because Dr. Makkar will not be available during the inauguration, so we wanted to felicitate him because he had done a very strong contribution in RID-IR study which has been initiated by ACP. So please, sir, you come here. So would like to felicitate you and will request Dr. Ekyazar Khan to please come on the dais and felicitate Dr. Makkar with me.
A felicitation to Dr. B.M. Makkar, sir. Please give him a big round of applause. Momentum that we were together here on this stage. Gentlemen, please clap. Thank you so much. Thank you, sir. Moving to our next session, and the session is bench to bedside, and I'm delighted to invite the chairpersons on stage, Dr. J.B. Kanwar, Dr. S.N. Rautre, and Dr. K.N. Padihari. Please come up on stage, sir. Dr. J.B. Kanwar, Dr. S.N. Rautre, and Dr. K.N. Padihari. And I would like to bring to your kind notice that there is a slight change in the sequence of the speakers. First, we will have the session from Professor Dr. Swati Srivastava. The second speaker is Dr. Shekhar Chakrabarti, and the third speaker is Dr. Jyotirmaya Pal. Over to the chairpersons.
You start?
Yes, sir.
So, in this session, there are three speakers. There are Dr. Swati Srivastav. The second one is Dr. Shekhar Chakravarti. And third one is Dr. Jyotirmoy Pal. And I invite Dr. Swati Srivastav to deliver her talk. But I do not know what is the topic. I think the speaker will declare himself. Hepatitis B in pregnancy.
It's not being projected. Thank you very much, chairpersons. At the outset, I would like to thank the entire team ACP. I'll do that. Especially Dr. Anuj Maheshwari, Dr. Jayant Panda, Dr. Anil Virmani for charting out such an excellent program and giving us this opportunity to be here on this platform and discussing some important topics of medicine with the august audience. I'll be speaking on how, hepatitis B in pregnancy, how to proceed. So, hepatitis B virus infection still remains a major public health issue in the Asia-Pacific region. Despite the availability of very effective preventive measures in the form of vaccination of hepatitis B since long time back, still if we see epidemiologically, this is a major issue of concern. And if it occurs during pregnancy, then what happens? It presents a unique management issue for both the mother and the fetus. There are concerns about the management challenges, the follow-up to the children who are born to these hepatitis B positive mothers. Which patient to treat, when to start treatment, what treatment to use, when to stop treatment, all these are important things which I am going to discuss. And it should always be remembered that without any prophylaxis, suppose the lady does not get prophylaxis, the newborn does not get prophylaxis or antiviral treatment, the hepatitis B surface antigen and E antigen positive mothers have a 90% likelihood of vertical transmission. So a 90%, a whopping huge transmission to the newborn is what we end up with if we are not aware of this. Epidemiologically wise, we don't looked into this data, though a lot of work has been done. Still, the data, recent data, suggesting of a very large population is not there. In 2019, the modeled HBS antigen national prevalence of children under 5-year-old age was found to be 2.93%. and 0.52. So what we say, the national prevalence was 2.93 and in children it was 0.52. And the study in 1987, this is an older study which showed that pregnant females had an HBS positivity of about 3.7% in South India, and it was 1% in North India. So a more recent study though has somewhat better results in the form that now it is showing 0.25% in the South India and 1.1% in North India. Okay, sorry, this. Okay, just a minute. So this was the slide I was talking about, so I have to change through both of them. Okay. So these are the Asian Pacific Association for the Study of Liver guidelines of hepatitis B in pregnancy. This is a very important guidelines which is very helpful in how we manage, and it is the authors are Dr. Manoj Kumar, Dr. Shiv Sareen, very much our Indian authors who have detailed this very well as to how we should proceed. As we know, hepatitis B virus belongs to the Hepatnaviridae family. It's a small DNA virus with unusual features similar to retroviruses. If we go into the further details, we see that in our Asia-Pacific region, most of the burden of the HBV-related disease are resulting from the infections which are acquired in infancy. How this is acquired? Either perinatally or early childhood exposure to the hepatitis B virus.
So what we are concerned with, the mother to child transmission. The mother to child transmission is very important, which requires to be controlled. Why are we so worried? Because we see that infections which are acquired at an early age commonly become chronic. The rate of development of chronicity, if we see in adults, suppose we develop hepatitis B, then 95% are going to clear it on their own. Only the 5% of adults go into the chronic stage. But if an infant in the first year of life develops hepatitis B, there is an 80 to 90% chance of developing chronic hepatitis B. Infants children between 1 to 5 years of age, 30 to 50% of chance of developing hepatitis B. So we have a huge population we will develop if these are transmitted perinatally. As they grow up, our epidemiologically really becomes haywire because of this group of children who have attained this virus, who have got this virus in infancy, where it could have been easily controlled. Now, because HBV virus in infancy or in early childhood often leads to chronic infection, it's important to take adequate measures to control this prevention. The two important risk factors which we have to remember are the which are responsible for increased transmission are high maternal hepatitis B viral load. So if the mother's hepatitis B viral load is high, or very high chances of the newborn developing hepatitis B, and a high viral replication, that is by the hepatitis B E antigen. So HBE antigen, if it is again positive, indicating a high viral replication, a high occurrence of transmission. So our goal is to prevent this transmission and hence prevent the people living with hepatitis B and having a better outcome. What does the WHO target? The WHO has a global health sector strategy on this viral hepatitis, and their targets were a 90% reduction and a 90% coverage of hepatitis B vaccine birth dose, the dose which should be given at birth. Even if 90% coverage occurs, that is very important. And the target also includes a 90% coverage of all doses of hepatitis B vaccine. Now, the transmission, as we know, the transmission can occur perinatally. It can be a horizontal transmission, it can be a sexual transmission, and a parenteral transmission. If we look, this is the serological pattern. All of us know this very well. At the beginning, we have the HBsAg positive, which is the first to come. Then the IgM anti-HBC comes up. And then this is gradually over the years, as these fall, there is convalescence, and then we have the IgG anti-HBC which is there, and the HBE somewhere comes in the middle, which is responsible for the infectivity for that patient, and as the HBE remains positive, the patient remains infective. So acute hepatitis is characterized by the appearance of all these markers which we just saw, including HBsAg and IgM anti-HBC. They disappear during the convalescence. Now, if this HBsAg remains positive for more than 6 months, we say that it is a carrier state. And if it causes an elevation of the AST, ALT, then we say the patient is suffering from chronic hepatitis more than 6 months. As we just mentioned, in newborns who are infected, chronic hepatitis occurs in 90%. In children, that is 1 to 5 years, and the chronic hepatitis comes to 29 to 40%. In adults, so children we include up to even 14 years of age, and in adults, 5 to 10% only develop, the chronic hepatitis B. The immune status also is very important. So this is a very important, chart which is very important and informative chart, that what is the risk of perinatal hepatitis B transmission? If a person is positive for HBsAg and HBe antigen both, and does not have any post-exposure prophylaxis, if the vaccination or immunization, which I will talk about later on, is not given, that child transmission will occur to the tune of 70 to 90% of the infants. Almost all the two-thirds or all the infants will be transmitted. And if the mother is positive only for HBsAg, less than 10% of the infants still will be affected. So that's also a huge number. If you see this table which is there, if the mother is HBe positive along with HBsAg positive, without prophylaxis, 70 to 90% transmission. If we give the HBIg and the hepatitis B vaccine, it comes down to 5 to 10%. Such a drastic reduction control which can be done so easily. If the mother is HB negative without prophylaxis, 10 to 40% occurrence of transmission, and which goes down to less than 5 if the immunoprophylaxis is given. So this shows that the immunoprophylaxis is very, very important, and identification of these patients are very important. Again, the role of maternal HBV DNA is very important. If there is a high level of DNA, the transmission is more. If there is a low DNA, then the transmission is lesser. So what happens now? See, we have a lot of different subgroups of patients. When we talk about a mother with HBs antigen positive, it can be so many scenarios. It can be that someone has already a known case of chronic hepatitis B and she wishes to become a mother. It can be that a person has chronic hepatitis B and she is on antiviral therapy and now she gets pregnant. It can be that it is a lady who develops who has HBs antigen positive, she wishes to become a mother, so there again becomes a different scenario. It could be that she has got HBs infection now during pregnancy. So what happens if she develops infection during pregnancy? What we see that, as we know that pregnancy has an immunomodulatory phase. So there's a weak T cell response and the SPH antigen loss and clearance, the seroconversion from positive to negative is slower. That is all. It is slower because the hepatitis B related, the CD8 plus T cells which play an important role, they are somehow lesser effective under the influence of the hormones estrogen, progesterone and HCG. So all these act and they cause a reduced clearance of the virus. So the course may be a little prolonged. However, if we see, usually the course is unchanged. It's similar to what a non-pregnant female may have. Again, now when we talk about the mother-to-child transmission, the transmission can occur in 3 ways. It can be prenatal, that is in utero. It can be during the process of delivery, that is intrapartum or natal. And it can be postpartum, that is after the delivery. Most of them occur perinatally. And when we see about in utero, that is relatively lesser. So what do the guidelines say? The guidelines say that MTCT, that is a mother-to-child transmission, occurs mainly during labor and delivery. The rate and timing is not well known of intrauterine transmission that requires more studies. Again, if we talk about the intrauterine transmission, not very common. Usually the transplacental viral infection does not occur. But it can occur if the lady has got a hepatitis B infection in the 3rd trimester, or she has a very high viral load and she has a HBe positive, or she has a threatened preterm labor. The HBV goes to the placenta and then goes on to infect the fetus. At delivery, the neonate is exposed vertically through so many processes which are going on. Exposure is rampant at that time. That is the maximal which can occur. Afterward, does breastfeeding cause? No, it usually does not cause transmission. But if there are cracked nipples and cracked scarification is there during breastfeeding of the breast, then probably that can be. But other parenteral exposures may be there. So they may be responsible for transmission. Another important point. Now suppose the mother has given birth to the HBs positive mother has given birth to the child, and we give the newborn we are giving vaccination. Does the vaccination have the same impact as any other child who is getting vaccination? Probably there is some difference. Probably it has been found in some studies that there is a somewhat blunted immune response. And a Taiwanese study found that probably if they increase the dose from 10 microgram, which is usual, to 20, there would be better immunogenicity, because they found that at the age of 5 to 10, at the age of 15 years, they did not have evidence of anti-HBs which should have been. Now, What will happen once an hepatitis B person becomes pregnant? So as I just told, pregnancy is an altered immune state. So to tolerate, there's a reduction in maternal immunity because to tolerate the semi-foreign body of the fetus, and there is an increase in adrenal corticosteroids also. But usually we see that the liver disease, there is no worsening of the liver disease. And majority of women, they do not worsen, the liver disease does not worsen. There is occasional, there are reports of hepatic exacerbations or fulminant failures. How hepatitis B virus infection impacts the pregnant woman? Now, till now we were seeing that what happens to the mother if she develops hepatitis B or she's positive. But now if she has hepatitis during pregnancy, does it affect its outcome? Yes, there can be higher chance of miscarriage, gestational diabetes, pregnancy-induced hypertension, preterm birth, intrahepatic cholestasis of pregnancy, and cesarean delivery can be there. But still, the data from available studies are not strong enough to associate these complications. Cesarean delivery, there is no indication of a cesarean delivery just to prevent the hepatitis B transmission. That is not there as per the guidelines, should not be done, unless there are some other indications. Again, what can happen if we have this chronic hepatitis B infection in a mother during pregnancy and postpartum? Now, postpartum, after delivery, what can we expect? So, because there is some immune reconstitution which is there, we can expect the hepatic flares to occur. So, there can be mild hepatic flares of AST, ALT elevation may occur, but usually they do not require therapy. Some, if severe, may require result in liver failure. Again, women who are hepatitis E, HBe antigen positive have a higher chances of developing these flares. Now, coming to the management. The clinical course, as I just mentioned, usually is not different if one develops an hepatitis B or one is having already chronic hepatitis B, then usually the clinical course may not be very different, and management is usually supportive with monitoring. Supportive and monitoring both have to be taken into consideration. Under the rare circumstance, if fulminant hepatitis occurs, the decision would be, just a few more slides. With the considerations, we may have to consider other decisions of early fetal delivery or liver transplantation. Although nucleoside analogs treatment would theoretically reduce the chances of ALT flares due to reactivation, it should not, whether it should be given routinely would depend on a lot of scenarios, which we will just see. What are the antivirals, what are the therapies that we have in our armamentarium? We have telbuvidine, which is class B, lamivudine, entecavir, adifovir, interferon alpha 2B, pegylated interferon alpha 2A, all class C. We also have tenofovir, which is class B, which is not in this table. It is also class B and very useful, which is a recent one, and we use that mostly. What do we understand by class B? Class B means in animal studies, they have not been found to have any teratogenicity, but not tried in humans as yet. Class C, found to be teratogenic in animal studies and not studied in humans. So, what are the drugs that we have? Telbuvidine and tenofovir. These are the two main drugs which we have in class B category. Others are class C, we should try to avoid. Lamivudine, adifovir, entecavir, we should try to avoid. But lamivudine and telbuvidine may lead to emergence of drug-resistant strains. Hence, tenofovir, TDF, tenofovir dobesilate, is one of the drugs which is the first choice in pregnant females. If the patient is on antiviral therapy before pregnancy and she's planning, she has a pregnancy indication and she's on entecavir or adinofir, we should change it to tenofovir. Now, what to do to prevent the mother-to-child transmission? All newborns should receive their first dose. All newborns should receive their first dose as soon as they are born of hepatitis B vaccine, preferably within 24 hours, and then they should complete their entire course of 0-1-6 months. Hepatitis B IG prophylaxis should be given where required, especially of use in hepatitis E positive, HBe positive, antigen positive women. Can we go in for obstetric procedures if the mother is HBsAg positive? That depends again, that has to be discussed. If the viral load is high, then we have to discuss with the patient about the risk of transmission, and that has to be done. Cesarean is not performed solely for the indication of reducing the vertical transmission. So concluding, unvaccinated infants infected through mother-to-child transmission are at a 95% risk of developing serum hepatitis B positive chronic hepatitis B. Treatment with nucleoside analogs is recommended in the third trimester of pregnancy to prevent this risk, and close monitoring of hepatitis B viral DNA and ELT flares during pregnancy postpartum are adequate for and also immunoprophylaxis are vital. Thank you very much for your patient hearing.
So there is no scope of discussion, floor discussion. Thank you, madam. We'll go to the second topic.
Yeah.
This speaker is Dr. Shekhar Chakravarti, and topic is acute dyspnea, etiology, evaluation, management. It's a very practical point. Almost every day we see such cases. Dr. Chakravarti, please.
Good afternoon to all of you. It's my good afternoon to all of you, respected chairpersons. It's my privilege to present my talk in front of the august guardians. I have been interested in talk on a very practical aspect, which is acute dyspnea, which we encounter in our day-to-day clinical practice. Most of the thing which I'll discuss in front of you will be our common problems, and I have got no disclosure. To start with, there is a difference between a respiratory distress and dyspnea. The American Thoracic Society has defined in 2018 that the subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. So any sort of discomfort and sensation, abnormal sensation, which we define as dyspnea, and this experience derived from the interactions among multiple physiological, psychological, social and environmental factors, and may induce secondary physiological and behavioral abnormalities. Now these are the different aspects which we often have the patient have the different sort of perceptions in the form of unsatisfied inspiration, some chest tightness, sensation of the feeling breathlessness, cannot get enough air hunger or incomplete respiration. So this is the American Thoracic Society which has defined, and ultimately in 2018 there is a modification. So basically this is a sort of altered sensation and a perception of a patient which is developing from different mechanisms at there. The most important is whether the patient is having an hypoxia or hypercapnia or any sort of acidemia that principally involves the central chemoreceptors or the peripheral chemoreceptors, and that leads to air hunger, and that ultimately stimulates the brainstem and sensory cortex. When there is an increased airway resistance or any lung compliance abnormality, will basically involve the mechanoreceptors of the airways and the lungs. That leads to chest tightness. Ultimately, the brainstem and sensory cortex is involved. When there is a metaboreceptors in the muscle, for example, if the patient has got an anemia or any sort of psychological abnormalities, these metaboreceptors are involved, and that also involving the brainstem and sensory cortex, ultimately involving the brainstem and the motor cortex and leading to some sort of problem in the respiratory muscles, and work of breathing is increased. These sorts of problem ultimately leads to dyspnea. So therefore, the chemoreceptors, mechanoreceptors and metaboreceptors involving the sensory and the motor cortex, leading to the peripheral symptoms and ventilatory muscles and dyspnea. So there are the different qualities of the respiratory dyspnea we often come across. One sort of thing, the patient has got an increased work of breathing, or there is an increased effort during respiration. Another important issue is the patient complains of the tightness of the chest. And another issue is the air hunger. When we usually come across in the patients complaining of the work of breathing, this is arise from the cortical motor command. Tightness, it is due to stimulation of the airway receptors. Hunger of air, it is the imbalance between the ventilation that increases. So usually this is a chart which shows the differential diagnosis of the dyspnea. We can divide the three important issues. One is the cardiac, another is cardiopulmonary, and a combination of the cardiopulmonary as well as the others are very important. For example, the anemia, deconditioning, psychological, metabolic abnormalities, and gastrointestinal reflux disease or aspiration pneumonitis. These are some common problems which we encounter in our clinical practice. Among the pulmonary are also very important, and you will find that the acute dyspnea is sometimes present as an immediate. When we have got an immediate dyspnea, we should think about the pneumothorax, pulmonary embolism, or a foreign body impaction. When it develops within 1 to 2 hours, usually the asthma or any left ventricular failure is usually the common etiology. When the patient presents over the hours and the days, pneumonia and acute bronchitis is the presentation. Or acute dyspnea may present with the hyperventilation in the form of either acidosis like acute renal failure or the diabetic ketoacidosis. There might be poisoning in the form of salicylate, methyl alcohol, ethylene glycol, or any hyperventilation syndrome. So these are the common dyspnea associated symptoms. Patient may present with a stridor. We should think of the tracheal tumor in the foreign body, might have the chest pain like acute pulmonary embolism, myocardial infarction, pericardial effusion or tamponade, or in very severe cases aortic dissection. There might be pleuritic chest pain, and the patient may present with the sputum in the form of bronchiectasis or bronchitis, might be hemoptysis, and some bulbar symptoms in the form of neurological involvement in case of motor neuron disease and myasthenia gravis. So there will be the different varieties of the acute dyspnea like paroxysmal nocturnal dyspnea, orthopnea, trepopnea, platypnea, and dyspnea due to exercise. So these are the different etiologies of the dyspnea, where we get an increased ventilatory demand in the form of increased physiologic dead space, or there might be some metabolic problems, or the neurohumoral abnormalities, or the patient has impaired mechanical response in the form of either airway obstruction or a decreased shell compliance, decreased parenchymal elasticity, or some of the inspiratory muscle weakness. So therefore, these dyspnea causes can be divided, some respiratory causes, cardiovascular causes, as well as dyspnea with the normal cardiorespiratory functions. These are the usual respiratory causes. These are the usual cardiovascular causes, and these are sometimes might be anemia and the obesity. And sometimes you'll see that the obese patient comes to your chamber with a dyspnea. There is no sort of respiratory problem, and the investigations are normal. This is probably due to the impaired ventricular pump function and the high cardiac output. So how to assess a patient with a dyspnea? When a patient comes, you must assess with the history, work effort, acute dyspnea, and whether the patient has got a chronic dyspnea, some associated symptoms, whether the patient has got a positional dyspnea or not. The characteristic history should include whether the persistence in the day and year, and whether there is any variability of the dyspnea. That is very important. What are the triggering factors, and what are the associated symptoms and relationship with the position? These are the different persistence of the during day and year in the form of variability, whether the dyspnea is intermittent, persistent, nocturnal, seasonal, or occupational. So, if there is an intermittent dyspnea, then you should think of a reversible causes like congestive cardiac failure, acute bronchospasm, pulmonary embolism, pleural effusion. When the persistent dyspnea, there is usually irreversible causes, COPD and pulmonary embolism, chronic and diaphragmatic dysfunction, and so on. The characteristic history, these are the nocturnal dyspnea the patient presents with. These are the disease which any clinician should think of about asthma, congestive heart failure, gastroesophageal reflux disease, which is very common, often missed by the clinicians, and sleep apnea syndrome, this is very important, and nasal obstruction. So how to examine? Usually the general symptom appearance of the patient is very important. You should think of whether the patient has got an increased work of breathing in the form of supraclavicular retractions or using of the exercise muscles, and tripod position signifies a very critical situation where there is an increased airway resistance of the stiff lung or chest wall. The patient, you should examine for respiratory rate, pulsus paradoxus, anemia, cyanosis, clubbing, pedal edema, and the joint swelling. You should examine the symmetry of the chest movements, percussion and auscultation, and you should consider the disorder of the airway, interstitial edema or fibrosis. Elevated right heart pressure, left ventricular dysfunction, valvular disease, paradoxical movement of the abdomen, tender hepatomegaly, as well as tense ascites are to be examined. These are the some, after having the clinical examination, you should look for certain important like scales in the form of modified Borg scale, visual analog scale, and very important modified medical research council scale. These are very important. Borg in 1982 has propounded this scale in a form of Harmal expression of the degree of dyspnea in a non-linear and numerical way. It is very easy to apply with exercise, and you can appropriate comparison in the persons and the groups. These are the modified Borg scale, and this is the dyspnea of the modified medical research council, which has got a 4 scores. In fact, this grade of dyspnea, which has been included in the gold guideline of the chronic disease, though it can be applicable in the acute dyspnea as well. So, when a patient of the dyspnea comes, how you approach? In fact, you start to assess the severity, then immediate interventions, further history, and additional treatment. In fact, when the patient comes to an emergency with acute dyspnea, you should act very immediately before evaluation is complete. So, if necessary, you intubate the patient you should consider the protection of the airway, circulation and breathing, and also you can put the CPAP, NABs, nebulization, chest tube and others, you can put into the emergency if it is required. Then assessing the severity, so you look for the vitals, pulse oximetry and position, whether the patient is in supine is researing or in a tripod position, which is very worrisome, and speech, retractions of the exercise muscles, altered loss of sensation and diaphoresis. So the patient presents with a respiratory distress, immediate intervention, you try to intubate if necessary for this patient. If you cannot protect the airway for any means, you must protect the airway first and then treat the presumed etiology, educated guess based on the brief history and known history of whether patient has got an asthma or not. You go for chest examination and possible chest X-ray. And then respiratory distress, another evaluation is gather more data as the patient stabilized, then refine your treatment. So physical examination, you look for the respiratory rate, signs of the respiratory distress and auscultate. And also you look for, but beware that all wheezes which we see in the patients are not asthma, because there is the other like pulmonary edema, foreign body, pulmonary infection, embolism, anaphylaxis and many other causes of the wheeze. So how to investigate? Approach is that you go for a pulmonary function test, particularly the arterial blood gashes. In fact, you must consider that the ABG cannot differentiate the etiology, it just indicates the status of the patient. Imaging methods like conventional radiography, TP scintigraphy, and from scoping examining, and neuroimaging, laryngoscopic examination, polysomnography, and psychological investigations. So when you get a patient after having examination, go for the chest X-ray, see whether the patient has got a low cardiac output failure, output and myocardial ischemia. You go for ECG and echo. If you suspect as a high cardiac output, go for the hematocrit and thyroid function. If you have suspect the respiratory pump or the gas exchange abnormality, go for the pulmonary function test. And if the diagnosis is still uncertain, then you obtain the cardiopulmonary exercise test. Go for the chest X-ray. Chest X-ray provides a lot of information to prominent pulmonary vasculature and central pulmonary arteries, enlarge the cardiac silo, as well as the pleural effusion, and go for the CT if necessary. So cardiopulmonary exercise test is distinguish the cardiovascular from the respiratory etiology of the dyspnea. If the patient achieves the predicted maximum ventilation, increase in dead space, or hypoxemia or develops bronchospasm, the respiratory system is involved. If the patient has gotten a heart rate more than 85% of the predicted maximum is achieved, and the BP becomes either excessive high or low during exercise, pulse oximetry falls, and if there is an ischemic changes in the ECG, go for the cardiovascular system involved. So this is a picture of the pneumothorax. Other ancillary testing in the form of metabolic panel, in the metabolic acidosis, CBC, ABG, D-dimer, and cardiac etiology in the form of cardiac markers. In fact, it does study published in 2011, it shows that the shortness of the breathing has been studied, where it has shown that arterial blood gas does not differentiate between a cardiac, pulmonary, and non-pulmonary. It just signifies what is the severity and what is the metabolic status. How to manage? Manage, you should see that whether the patient has got saturation is less than 90%. Put the patient on the oxygen immediately. If there is heart failure and pulmonary edema, start with the diuretics. Pneumothorax, put the chest drain. Pulmonary embolism, anticoagulation. Asthma attacks, short-acting bronchodilators, particularly the nebulizing form. COPD exacerbations, bronchodilators, antibiotics, and steroids. Foreign body aspiration, go for bronchoscopy. Pneumonia, antibiotics, ARDS, and pneumothorax, like pleural drainage. These are very important. So treatment of the dyspnea starts with oxygen treatment, heliox pharmacological management, pulmonary rehabilitation, and some non-pharmacological approaches. This study has significantly shown that those patients receiving oxygen, particularly at night or home, any dyspnea, if the patient has got a baseline hypoxemia, those patients only are getting benefit with the oxygen supplemental therapy. Helium, hyroxia, then exercise, it has been shown in acute observations, and also the opioids have been the most widely used to reduce as a pharmacological treatment. It has shown that the opiate morphine appears very effective in lower doses in cancer dyspnea. Nebulized form of furosemide can be used, but currently there is insufficient data. Furosemide can greatly alleviate the sensation of acute dyspnea, and these are the different categories of the drugs which are very ineffective. And asthma, you know, the management is mostly ipratropium and methylxanthines, magnesium. Antibiotics are not helpful, no role of the fluids, and there might be beta agonist in asthma exacerbations. Asthma steroids has got a role. You may require the first dose in emergency department. Severe asthma exacerbations are very important, and ketamine is required for intubation sometimes. Conventional high tidal volume and rate results hyperinflation. Other therapies are there for congestive heart failure, nitrates, furosemide, morphine, and AC inhibitors, and CPAP and BiPAP, and NIVs, and COPD exacerbations like asthma, oxygen therapy, ipratropium, antibiotics has got a role in contradiction to asthma, and upper airway obstruction, there might be stridor. This is a angioedema and foreign body infections or trauma. There might be, this is one of the cause of angioedema. Well, see, it might be drug-related, hereditary and idiopathic. The way you can differentiate a drug-related and idiopathic, and these are the treatment of hereditary and AC-induced, and this is a foreign body infection, and is there, and pulmonary rehabilitation is required for these patients, and non-pharmacological like chest wall vibration, non-invasive ventilation, acupuncture, yoga has got a role. So to conclude, many patients with the dyspnea will require intervention based on minimal information. You must consider that all wheezes are not asthma. Beta agonists are the cornerstones of the acute asthma management, and always consider the foreign bodies in the differential diagnosis of the asthma. Thank you very much.
We have got 1 minute time. If anybody has got any doubt, or if you want to add something, you can add also. Because nobody is telling, I want to tell one point, that is always think of the possibility of a double trouble. Double trouble in the sense, suppose a patient is bronchial asthma having from childhood, but he reaches up to age of 50 or 60. At that time, if he comes with acute dyspnea, don't simply pass away that it is bronchial asthma. And another attack of bronchial asthma. Exclude the possibility of a coexisting cardiovascular disease. So that is double trouble. Second, if the patient has bronchial asthma, may develop pneumothorax also. That is another type of double problem. Or COPD patient may also develop pneumothorax also. So simply just not pass away that this is this, because he is suffering for so many years. That is why it may be this. So always exclude the possibility of some coexisting disease which might be contributing to his dyspnea. Thank you, Dr. Chakravarti. Thank you for your presentation and discussion. It is an interesting topic for all of you. All of you have heard it. Thank you.
Thank you.
Now I will request Professor Dr. Jyotirmay Pal, who will be speaking on approach to aphasia.
Slides.
Jyotirmay Pal. Full slide.
Good afternoon, chairpersons, all the delegates. I am really obliged to be invited in the prestigious program of annual conference of ACP India chapter. The topic allotted by Dr. Birmani is the approach to aphasia. This is a hardcore neurology topic, more useful for the students who are about to give the exams, and also definitely helpful for the general practitioners, because aphasia very commonly we encounter the stroke with or speech disorder in our common clinical practice. So how we will approach, there is a two part, one is the speech, one is the language. Language means your understanding, communication, understanding and expression. Three together is the language and the speech. So first I tell something, that is communicated, you understand what I have told, that is the understanding, then I express my response. So these three together is called language and speech. So language is basically the planning, that is the what answer I will give, that is planned by the cortex. That is called the language. When it is executed, that part is basically speech. So aphasia means disorder in the language. So we will discuss about how we will approach to basically the disorder of the language functions. So what are the steps of the understanding? First we receive the language either in the form of auditory or visual stimulus. Suppose you have shown some newspaper, something is there, some response is there, some question paper is there, and the examiner asks your response. So either visual or auditory language is received, then it is recognized in the form of symbol, then it is recognized in the form of words. So then we express our thoughts or our answer. So these are the three steps of understanding. So response basically also three steps. One is I told the language, that is the planning, how we will express my thoughts, that is called language. Second is the phonation, that is produced by the vibration of the vocal cord. So my answer, my planning is done from the cortex, cerebral cortex, and the vocal cord start movement. So vibration is there, so phonation is produced. Then the sound produced in the vocal cord is modified by the vocal tract. What is the vocal tract? There is the larynx, nasal cavity, lips, tongue, all together cause the vocal tract. So it is modified by the vocal tracts, that is called articulation. So there is a three component, one is the language, one is the phonation, one is the articulation. So language is a basically function of the cerebral cortex. First component is the reception by either in the form of auditory or in the visual stimulus, then interpretation, what is the stimulus, and then the retention, recall, and I will recall whether I have similar thing I have received in the past, then visualization of the symbol, and then the motor act. This is the planning. So there is a two input for the language function. One is the auditory, one is the visual. Suppose I am an examiner, I asked what is your name, so it is the auditory. Or I have shown a paper where it is written what is your name. So I have read the question, then I have given the answer. So in this way, two stimulus we have received, and we can plan the answer, and that will be executed by your vocal cord and vocal tract. So language defect is called basically the aphasia. This is the basically defect in the communication and motor planning. And speech disorder is a two-part. One is the dysarthria, one is the dyspnea. If there is a defect in the vocal cord or vibration of the vocal cord, that causes the dyspnea. When the sound produced by the vocal cord is not properly articulated by the vocal tract, that part is called the dysarthria. Suppose I have a bulbar palsy, a supravalvar palsy, so the dysfunction of the different lip, palate, tongue, so there will be dysarthria. So there is a three level of disorder. One is the dysphagia or aphasia, dysarthria, and dyspnea. So aphasia means defect or loss of power of expression by speech, writing, gesture, or defect in or loss of ability to comprehend spoken or written language or to interrupt in gesture. And dysarthria means defect in the articulation, dyspnea means defect in the vocal cord. So there are the three level of defect. So language comprehension also has a three level. One is the cortical reception. So there may be defect in the cortical reception. Suppose there is a lesion in the occipital lobe. So visual reception will be defective. Then recognition and visualization. Suppose some cat is in front of you. So you have to recognize that it is a cat from your old memory. Then recognition of symbol in from the word. That means then you will plan that I will say that one cat is in front of me. That means whatever I have received as a symbol, that will be translated in the form of word. That planning is done by the cerebral cortex. So, and there is a three level of motor speech. One is the emotional level, one is the automatic level, and is the propositional level. Emotional level means, suppose sometimes a comatose patient or stuporous patient can say, that is the emotional level. Second is the automatic level. Sometimes you have seen the some stuporous patient go on repeatedly telling is the name of his grandson or some name of some Sri Krishna, 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 Govinda, Govinda, Govinda. This is the automatic level. Some well-learned sound may be repeated in a stuporous patient. That is the automatic level. And the recent evolution is the propositional level. That means whatever I ask, what answer you give in the proper way, that is the temporal lobe or in the visual part. So from there they come to the Wernicke's area. This is the Wernicke's area. Okay. and this is the C-separate perisylvian area that is responsible for the speech. So here whether auditory or visual stimulus that is merged here, there is a Wernicke's area. So Wernicke's area receive responsible for the comprehension. Then the response is transmitted by the arcuate fiber to the Broca's area. Broca's area lies in the inferior frontal gyrus in the posterior part. So this is arcuate fiber is transmitted to this Broca's area. Broca's area is basically motor association area. That means it do the planning of your answer. So what I have asked, what is your name? So this is received by the auditory cortex, then go to the Wernicke's area, then by the arcuate fiber it reaches to the Broca's area. Broca's area now plan my name is XYZ. So then they will send stimulus to the motor area, motor cortex area, where there is the area for the different cranial nerve nuclei. Because when I will give the answer, there should be vibration of the vocal cord. That means 10th cranial nerve should be stimulated. There should be 7th cranial nerve. There should be 12th cranial nerve, because the lip, tongue, palate, all the muscles, there should be movement. So this area will be stimulated of the motor cortex, motor parietal cortex. Then appropriate stimulus will be sent to the through the corticobulbar fiber to the different different cranial nuclei of the bulb, and from the bulb appropriate muscle will be stimulated, and there will be the vibration and articulation. This is the anatomy of the language centers. So before approaching, you should know the handedness, cultural background, language spoken, vocabulary, intellectual capability, mental stressors, inattention, agitation, depression, emotional problem, and hearing problem. So these are the issues that you should take into account when you are dealing a patient with aphasia. So when you will do the clinical examination of the language, there is the 6 components. First, you examine for the spontaneous speech, then the comprehension, then the naming, then the writing, there is a repetition, there is a reading. It is a big chapter. It is not possible to finish by 11 minutes. So just I will give some brief idea how we will examine the each and component. Because spontaneous speech, this is basically the function of the Broca's area. So basically we examine the propositional speech, and defect in the Broca's area causes the non-fluent aphasia. Okay, but the automatic and emotional speech is least affected. It is the propositional speech that is mostly affected in the lesion in the Broca's area. So there is a non-fluent aphasia. But if there is a partial defect of the Broca's area, there may not be non-fluent aphasia. Rather than there may be something like monophasia, paraphasia, phenomic or verbal paraphasia or neologism. What are these? Monophasia means there is a repeated utter of a single word. Paraphasia means substitution with the wrong word or letter or sentence. Suppose you are asked, my name is Dr. Jyotirmoy Pal, you will substitute one word, doctor, you will substitute. Or phenomic paraphasia means you will substitute a letter. In case of numbness, you will tell it is the thumbness. That means N is replaced by the T. Or verbal paraphasia means ring, suppose ring, one entire word is replaced, ring is replaced by the watch. Or neologism, suppose you have uttered some new word which is not in the world, some new word you have invented, that is called neologism. So these are the component when you should observe when you are examining the spontaneous speech. Comprehension, whether you can follow the verbal command. Suppose I ask you show your teeth. So you can show properly. That means your comprehension is okay. But if it is defective, you have to differentiate from 2 disorders. One is the deafness, whether you can hear properly, or from the apraxia. Suppose I asked you close your eye. Okay, this is the learned activity. So close your eyes. But if you have the apraxia, even if you understand, you cannot close your eyes. So to differentiate between the apraxia and comprehension, you have to ask a question where the answer is yes or no. Suppose you ask the patient, you are graduate or non-graduate. He can say yes or no. In that way, you can bypass the issue of apraxia. Next we are coming the naming. That means you show some object, and usually in 1 minute a normal person can name it 12 items. That means you have shown the 12 items and ask the patient what is the name. So naming is basically become defective in case of dementia. And in case of naming, suppose if naming is defected, what you can do in partial lesion of the cerebral cortex, if you cannot do, you give a list. Suppose you have shown a pen, patient cannot tell the name of this pen. So you give a list, you keep a list, mobile, pen, pencil, apple. Just patient will point, this is the correct answer. This also can be done if there is a partial lesion of the cortex and you examine for the naming. Repetition, this is a good screening test for aphasia, because repetition, this test should be done in all patients if you suspect the patient have defect in the repetition, because repetition become defective if there is a lesion in the arcuate fiber. Suppose if you do not ask the defectives, only there is a lesion in the arcuate fiber, patient comprehension is okay, patient's fluency is okay. So if you go on asking standard question, patient will understand and give a proper answer. So you cannot understand whether there is a defect in the arcuate fiber. So you ask the patient for the repetition. You tell a word pen, you tell the patient, you ask for the 10 times. Because in that case, only you can detect the patient has a defect in the repetitions. Writing, this is the external area, that is the posterior part of the middle frontal gyrus. There is the area for the writing, and writing is become defective if there is a lesion in the posterior part of middle frontal cortex. But Broca's area is the posterior part of the inferior frontal gyrus. So even if fluency is there may be defect in the external area, that means the writing. So patient's writing may be defective, but fluency may be preserved. Or patient's fluency is defective, but writing capacity may be preserved. Because two area is something different. One is the middle, one is the inferior frontal gyrus. So for the writing, just you give the dictation or you give some written statement. You just read and copy. So in this two way, you can examine for the writing capability or whether the external area is defective or not defective. Written, this is the function of the angular and perisylvian area, because suppose you have given some written statement and you ask the patient read aloud. You read and copy. So this patient whether can read properly, that you can examine, because then the stimuli will be received by the occipital cortex and it will pass on to the angular gyrus. Angular gyrus is responsible for the reading. Or if you ask the patient read aloud and write, that means in that case the stimulus from the occipital cortex will go to the angular gyrus, from the angular gyrus will go to the external area. In this way you can examine the reading and writing capability of this patient. So based on this knowledge we can classify the aphasia. How we can classify? Common classify is the either receptive, that is the Wernicke's aphasia, or expressive or motor aphasia, whether fluent aphasia or non-fluent aphasia, or whether central aphasia or paracentral aphasia. This is the common classification. Let us see. So Boston's classification is basically we can do the Broca's aphasia, Wernicke's aphasia, global aphasia, conduction aphasia, anomic aphasia, translocation aphasia, transcortical aphasia, subcortical aphasia. So till now we understand what is the anatomy of the language, what is the difference between dysarthria, dyspnea and aphasia, what is the anatomy of the language function, and how we can examine, that the 6 component of examination of language. By this examination we can detect what is the area of involvement, and from this knowledge now we can classify what is the type of aphasia. So Broca's aphasia already I discussed, basically lesion in the frontal posterior part of the frontal lobe, that is the Broca's area. Here there is a non-fluent aphasia. What is the non-fluent aphasia? Fluency means in 1 minute whether you can utter 110 to 150 words or more than 7 words in a sentence. That is called fluency. If this is lost, that means it is a non-fluent speech. and there will be short sentence, poor grammar, words, but ability to understand or writing will be preserved, and repetition or reading aloud will be impaired. Okay, and emotional and automatic speech will be preserved, and these are the, in mild case there may be circumlocution, there may be neologism, there may be paraphasia. This is the character of the Broca's aphasia. In a summary, that means it is a non-fluent aphasia, but comprehension is preserved, but repetition is lost. Then we are coming to the Wernicke's aphasia. Wernicke's aphasia basically, it is a lesion in the Wernicke's area. There is a unable to understand. There is a word deafness, or if patient is unable to read. If there is a peri-Wernicke's area, there is angular gyrus, there will be there is a word blindness. That means patient will be unable to read, but there will be fluency will be maintained. That means patient will go on speaking something, and what he is telling, he himself cannot understand. So that is called the Wernicke's aphasia. Now we are in the global aphasia. If there is a poor comprehension, poor repetition, and non-fluent speech, together we can see the global aphasia. There is a large lesion. So entire the C-separate sylvian area is impaired, starting from the frontal, temporal, and parietal. If entire area is defective, that is called the global aphasia. Conduction aphasia, if there is an impairment in the conduction between the Wernicke's and Broca's area, there will be poor repetition, because the arcuate fiber is responsible for the repetitions. Coming very quickly, what is the transcortical aphasia and subcortical aphasia? Transcortical aphasia means perisylvian area is preserved. There is a Broca's and the conduction area, arcuate fiber, and Wernicke's area preserved, but disconnected from the rest of the brain. So as the arcuate fiber is preserved, repetition is well preserved. So here it is also divided into two components. One is the transcortical motor and transcortical sensory. Transcortical motor means that is area in front of the Broca's area. That means the supplementary motor area or prefrontal cortex. That is the area in front of the Broca's area is impaired. There is a lesion. So there will be non-fluent speech, but comprehension is preserved, but repetition is intact, because arcuate fiber is normal. Another is the transcortical sensory aphasia. Here, lesion in the more in the posterior sensory area behind the sylvian area. So in that area, that is more close to Wernicke's area. So here, speech fluency is preserved, but comprehension is impaired, but repetition is preserved. So in transcortical and subcortical aphasia, very important is the repetition is preserved. That is the more important. So we are coming to the last component. There is a subcortical aphasia. Here basically lesion in the subcortical area. That means the caudate, putamen, globus pallidus, thalamus. In this area there is a lesion. Again here, this area can be component into two components. One is the anterior syndrome, one is the posterior syndrome. Anterior syndrome means lesion in the caudate nucleus, because it comes in front. Here there will be discharge takes more like a Broca's lesion. Here only the repetition will be intact, but more similarity with like a Broca's aphasia. That means the discharge speech, long length is preserved, but comprehension is preserved. And posterior syndrome, it is a more like a Wernicke's aphasia, but repetition is preserved. That is the lesion in the thalamus. So this is the common classification of the different speech disorder. I am not going into this lesion. Only last slide, if there is a language disorder in the non-dominant hemisphere, because at the beginning I told you have to identify the handedness. If there is a non-dominant hemisphere lesion is there, the speech, this motor and sensory aphasia will not happen, but there will be more defect in automatic and emotional speech that I described in the beginning. So you have to handedness is very important, and you have to differentiate whether the lesion in the dominant hemisphere or non-dominant hemisphere. So I am not coming to this area. So overall, the understanding of the speech and language can help you in identifying the anatomical site of the lesion. So speech, when you are getting the neurological patient, particularly the stroke or any other disorder, if there is a speech disorder, try to understand the type of speech disorder. That will help you to understand the type of lesion and also help you to understand the etiology of the lesion. Thank you.
Thank you, sir, for your lucid talk. Very difficult topic, very difficult to make others understand also. Thank you. Any question? One question is allowed.
Thank you, Dr. Pal.
Thank you.
And I think there is no other question, and we close this session.
Thank you, sir. Thank you, doctors, for such wonderful deliberations. And I request the chairpersons and the speaker of this session to kindly collect their mementos from the left side of the stage. Thank you. So now's the time for the next session, that is medical dilemmas. And I'm delighted to invite the chairpersons on stage, Dr. Atanu Kundu, Dr. I repeat, Dr. Atanu Kundu, Dr. Soumya Sen Gupta, and Dr. Amit Kumar. I invite the Governor ACP, Dr. Anuj Maheshwari sir, as the chairperson on stage, and the scientific chairperson, Dr. Jayant Panda sir, and Dr. Anil K. Virmani sir, the scientific chairperson.
वहाँ से हो जाएगा, यहाँ आना पड़ेगा।
Camera laga. Now I turn the time over to the chairpersons for proceeding further. Thank you.
So next is a very precious session, and we were really expecting this session in the physical presence of our past chairman of Board of Governors, Professor Elisa HOE, and somehow she couldn't make her traveling, so she will be addressing us on the online and virtual session. So this session will be on infectious diseases, pearls and pitfalls. Dr. Elisa Choi is supposed to have the oration also, which will be done after the inauguration ceremony. She will also be speaking in inauguration ceremony, but this is the scientific session which was supposed to be tomorrow morning in her physical presence, but this time we are doing it today because tomorrow morning would be very difficult to get it from US because that would be the midnight in the United States. So we requested Dr. Elisa to do it today only, and I am grateful that she accepted our request. Over to Professor Elisa Choi. We can't hear Dr. Elisa. Just wait, some audio problem is there. We are just handling it.
Unmute. Muted the call.
Sound was there. What did you do? Hello? Yes, yes. Yes, we can hear you. Dr. Elisa, please, now we can hear you. Please start your work. Deliberation.
are common, the skin, infected hardware, or a localized source of infection. The question often comes up, is this a contaminant or is it real? And as I'm going to point out, for Staph aureus, you always want to assume it is real if it is in the urine because of the association with the bacteremia and for the potential for metastatic complications. Now, this is a very busy slide, but I wanted to make sure that you take away a couple points. One of which is that for complications of Staph aureus, some of the risk factors for those complications include if you are unable to find a source of infection, and also if it is MRSA. Now, some of the manifestations of complications of Staph aureus include metastatic infections, such as what our patient had with vertebral osteomyelitis and other localized abscesses, but also endovascular infection like endocarditis and infections with prosthetic devices. Now, one thing I really want to make sure you take away as a pearl, if there is in fact Staph aureus bacteremia, whether it arises from a urine source or elsewhere, is particularly if it is not resistant, in other words, methicillin-sensitive Staph aureus, it is crucial that you utilize narrow-spectrum anti-staphylococcal penicillin. And I'll go into reasons for this future, but the point being that you want the most potent treatment and the narrowest spectrum once it is confirmed what the susceptibilities are. And the height of the management really needs to focus on evaluating for the source of the infection and the extent of the infection and removing any focus of infection. Now, my second case is this 74-year-old who has shortness of breath and is found to be in CHF. There is some pyuria on the urine. There is an indwelling catheter, and the full urinalysis shows a low-grade hematuria, pyuria, bacteriuria, and yeast. So which of the following statements is true? And since we don't have audience response, I'll give a pause for a few seconds and give it some thought as to which you think may be the correct answer. And in fact, none of the above are the correct answer. So what are we dealing with here? We actually have asymptomatic bacteriuria, and the definition is that there is bacteriuria in the urine, but there are no symptoms at all of a UTI. And there are numerous risk factors which this patient had, including having an indwelling bladder catheter device. It is more common in women than in men, excuse me. Now, the question comes up about how to manage and the pearls to try to extract from this condition. What do we do with this? Are there benefits to treating? Are there benefits to screening? And is this associated with any adverse outcomes? And if we intervene when there's asymptomatic bacteria, will that affect the outcomes? So the question now is, how do we manage this? And what we have found with the evidence is that it is possible there can be a symptomatic UTI that occurs after asymptomatic bacteriuria, but often ASB is transient. And so for the purposes of how to manage, treating ASB does not affect recurrence, does not decrease incidence of future symptomatic UTIs, and it does not improve survival. And in fact, the Infectious Disease Society of America has practice guidelines that were recently updated, and they recommend that if there is no symptoms but bacteria in the urine, you do not treat, except in two isolated scenarios that I've highlighted here. Particularly in pregnancy, treatment is indicated. And if there will be an endoscopic urologic procedure that could introduce mucosal trauma, but even then the treatment should be targeted and very limited. So all other scenarios, these are the scenarios where you should treat. All other scenarios, you do not treat asymptomatic bacteriuria. And that's very, very important as we talk later about increasing antimicrobial resistance. Now, a side topic related is something called funguria or candiduria. This is defined as having fungal organisms in the urine, which are typically Candida species. And question often comes up, is it colonizing versus actual infection? The cases of these are typically without symptoms, but if there are symptoms, there may be typical urinary tract infection symptoms like frequency of the urine and dysuria. Risk factors for having fungus in the urine can include continuing to have a urinary catheter or urinary tract drainage device, previous antibiotics, and diabetes also predisposes, as well as having some sort of abnormal GU tract issues or having underlying malignancy. Now, the Infectious Disease Society of America also produced a guideline for asymptomatic urine that has Candida. And in this case, much like asymptomatic bacteria, most situations it is not recommended to treat except if the patients are high risk, which most typically are neutropenic patients or those who will undergo urologic procedures. And similarly, again, the treatment, if they are undergoing urologic procedures, will be very limited in duration and scope. So to summarize, that most of these cases of fungus in the urine, data does not support treating, particularly in asymptomatic cases. And in one situation, though, related to renal transplant patients, it was not entirely convincing that antifungal treatment had greater clearance of Candida versus the removal of the bladder, so a bladder catheter. So as of currently, it is not a high-level recommendation to treat, even in renal transplant patients. The data does support treating fungus in the urine if the patient is symptomatic and has risk of disseminated infection, including if they are high-risk patients like neutropenic patients. Now, a quick summary. This is a busy slide, and I won't go through every single bullet point, but I did highlight for you to just take a look at what are the ways to treat Candida cystitis or Candida infection of the GU tract. And depending on the organism and the likelihood of resistance to fluconazole, there are different ways to treat. But I wanted to especially emphasize how important it is to treat this by removing any indwelling bladder catheter. Now, I wanted to also take a step back and talk about different definitions for what we're talking about. As the previous slides noted, just because there's bacteria in the urine or white cells in the urine, that does not mean it is a urinary tract infection. And when we talk about cystitis, what we are talking about is the lower tract or the bladder. When we say pyelonephritis, we are talking about the upper tract or the kidneys. So now let's move forward a little bit and talk about uncomplicated versus complicated. Cystitis. This is bladder and lower tract. So when we talk about uncomplicated UTIs or cystitis, that is specifically related to healthy, non-pregnant young women. So everybody else, and that includes any males with UTIs, but anyone else who is not a young, healthy, non-pregnant woman, if they have a UTI, they have a complicated UTI. Some of the risk factors I've previously alluded to, but again, women more than men are at higher risk. Sexual activity predisposes to having a cystitis infection, use of spermicides, and certainly previous history of UTIs predisposes as a risk factor. For older age individuals, in men, prostate abnormalities, including prostate enlargement, can be a risk factor, as well as for women who are menopausal, estrogen deficiency. And also, if there's anything that anatomically obstructs the bladder, or if there's any urethral or bladder instrumentation, that can also predispose. Now, the pathogenesis with this infographic, I wanted to simply highlight the anatomy and may explain why it is more common in women. This is a sagittal cross-section, and what you see here is the anorectal canal, and what you see up here is the uterus, and what you see here is the bladder. And what you will see is if there is too close proximity between the anorectal canal and the bladder, there can be contamination of many of the gastrointestinal organisms that colonize the anorectal canal into the bladder. So thus, we often, for practical purposes, tell our patients, make sure you wipe from front to back to avoid that. Let me talk briefly about the cystitis epidemiology, and why I'm focusing on this particular infection is the burden on our healthcare system is enormous. Billions of dollars of direct cost and millions of visits in the office and the emergency department. And if you see here in this graph, what's interesting is despite over the past several decades, pyelonephritis at the bottom, not necessarily increasing so much in terms of its incidence and prevalence, there is a continued increase and thus burden on the healthcare system of cystitis and lower tract UTIs. Now, just a couple years ago, the American College of Physicians actually put out a wonderful position paper, which I encourage you all to review, which talks about the appropriate short course use of antibiotics in very commonly seen infections. So let me talk about what we just started to describe, which was uncomplicated UTI or lower tract cystitis. Some of the microbiology and the diagnosis and treatment I've summarized in this slide, but to note that predominantly the organism of primary importance in this particular infection is E. coli. And diagnosis is a number of these clinical symptoms, including some of these urinary findings, but I will highlight that although it is classically thought of as being nitrite positive on urinalysis, please be aware that depending on the organism, you may not see a nitrite positive. So that is not necessarily an pathognomonic, and you can have UTIs without that. Now, I'm going to emphasize these are the treatments, but please note the durations and really try to avoid over-treating because, as I'll talk later in my talk, antibiotic resistance is really become an epidemic. And please also note that fluoroquinolones, which are very broad spectrum, are actually not the favored or preferred treatment. And from a practical standpoint in the United States, I will say, although fosfomycin 1 dose is on the list of treatment recommendations, it is extremely expensive and from my standpoint, thus not preferred. So let me quickly summarize the practice guidelines for urinary tract, lower tract cystitis. In women who have uncomplicated bacterial cystitis, short course antibiotic is what is recommended, either with nitrofurantoin, trimethoprim sulfamethoxazole, or as a much less favored alternative, fosfomycin. Now, moving on, as we talked about previously, the definitions, we're going to talk now about pyelonephritis or upper tract infection. And similar to urinary tract infection, they may have similar symptoms, but they often will have systemic symptoms and also some symptoms of nausea, vomiting, or CVA tenderness. Please note, another pearl though, for treating pyelonephritis, you should always obtain a urine culture and a susceptibility before using antibiotics because of the potential for increased toxicity of the infection and also the heightened importance of having the correct antibiotic because pyelonephritis can become more systemic. And note here the different treatment options, and primarily note that the durations are longer. And also note, though, in this particular trial or series of trials, a shorter course of quinolones was not inferior to a longer 10-day course. Now, let me start with another case for my next topic. So this is a 30-year-old who has fever and productive cough for 10 days, and otherwise the vitals are just notable for a low-grade temperature, but the chest exam shows that there are some abnormalities. There's a leukopenia and anemia, and the chest x-ray shows no acute abnormality. So which of the following options is correct? And again, I'll give a few seconds pause so you have a chance to review the different options. And so the answer actually is none of the above statements are correct. So why is that? Well, let's first talk about community-acquired pneumonia. And community-acquired pneumonia is actually defined as having a demonstrable infiltrate by chest x-ray. Now, this was an older version of an IDSA guideline in 2007. And I will acknowledge that in an updated guideline recently, they softened that language. So they did say that in their meta-analysis, when they came up with the guideline for community-acquired pneumonia, they did focus on studies that used radiographic criteria. That being said, the reason I point out this particular important pearl of the necessity of a demonstrable infiltrate on chest x-ray is certainly in the United States, I'm seeing an awful lot of pneumonia diagnoses where a chest x-ray has never even been done. So my pearl to all of you is you really cannot make that diagnosis unless you've actually had something noted on infiltrate. And so in terms of other further testing, I'll point out here, sputum cultures does not need to be done in every patient that you diagnose with CAP. These are certain scenarios, however, where you will want to get a sputum culture, and particularly if there is failure of outpatient therapy. Blood cultures, similarly, are not needed in CAP except in these certain situations, and particularly if there are other risk factors for more severe disease like asplenia or other host factors. So what's a summary of how we manage community-acquired pneumonia? From the practice guideline, you want to prescribe for community-acquired pneumonia, but for at least 5 days. But please note that you don't automatically need to have a long course of therapy. 5 days may suffice, particularly if the patient is showing clinical improvement and has become clinically stabilized without fever or other continued symptoms. And one point I have to emphasize, and I'll come back to this at the end of my talk, is that nearly 2/3 of patients receive longer than needed antibiotics as defined by our guidelines. And so that will become an issue in terms of risk for antibiotic-associated adverse effects. A quick summary on this slide of the different microbiology of community-acquired pneumonia, and note that there are some differences in the hospitalized non-ICU patients, particularly with aspiration and Legionella, and thus in the ICU you will see some more iatrogenic type organisms as well. Now, this slide that I lifted right from the guidelines is fairly busy, but I wanted to mostly alert your attention to the different ways to treat if they have no comorbidities for MRSA or Pseudomonas. And then below this line, if they do have those comorbidities, the main takeaway is monotherapy, except with a respiratory fluoroquinolone, is not appropriate or adequate treatment. Now I need to segue into bronchitis. And I will say this about bronchitis. Acute bronchitis is self-limited, and cough, which sometimes is viewed as of only short duration, may actually be of longer duration and can also be both productive or non-productive. You do want to think about acute bronchitis, though, differently than chronic bronchitis, which is associated with COPD exacerbations. And fever is not usually present in acute bronchitis, and also there are very mild, if any, constitutional symptoms. The main point, though, to take away is it is almost always viral in etiology. There are more rare bacterial causes, including atypical organisms outlined here, but really important, Pearl, start to think about other non-infectious diagnoses that could be contributing to a quote-unquote bronchitis of a cough without systemic symptoms. And those may include things like postnasal drip, laryngopharyngeal reflux, and possibly acid reflux. So I wanted to also, again, emphasize pearls from the guidelines that came out from the ACP in terms of managing acute respiratory tract infections. You do not initiate antibiotic therapy in patients with acute uncomplicated bronchitis unless you suspect pneumonia. And as we just talked about, you make a diagnosis of pneumonia with a clinical plus radiographic infiltrate. And I can't stress this last point enough. Acute bronchitis leads to more inappropriate antibiotic prescribing than any other acute respiratory tract infection syndrome. So just a few summaries then now of acute uncomplicated bronchitis. Consider concomitant diagnoses, and remember that management is not with antibiotics unless there is a pneumonia. And finally, I will say that you do want to get a chest x-ray for bronchitis if there are some abnormal vital signs, or if the lung exam is abnormal, and particularly in elderly patients if there may be altered mental status. And finally, just emphasizing for the third time that antibiotics is not supported by the medical literature in the absence of pneumonia. Now, in my final portion of my talk, I'm going to shift gears and talk about more prudent antibiotic prescribing as a duty and a responsibility of us as internal medicine physicians. So this study, which is a bit old now, but the takeaway messages are still just as relevant as they were when the study came out, is a prospective observational study by Hecker et al., which was in hospitalized non-ICU patients, and they looked over a 2-week period of time at antimicrobial prescribing. And the summary here is that nearly a third of the total number of days of antibiotic prescribing were unnecessary. That is an extraordinary burden of unnecessary antibiotic prescribing. And some of the reasons included treating antibiotics for non-infectious or non-bacterial syndromes, treating contamination or colonization rather than real infection, or treating much longer than necessary. So we as physicians are really entrusted to first do no harm. So we can cause harm, significant harm, with unnecessary antibiotics. And some of the side effects may include C. diff colitis, or even subsequent bacteremia with multi-drug resistant bacteria, particularly if too broad antibiotics for inappropriate indications for antibiotics are used. Now, we often in the US like to blame these type of things on surgeons or non-internal medicine specialists, but I will say from this particular study that was absolutely not true. And in fact, we as internal medicine physicians were the larger proportion of those who committed these antibiotic misuse. And this is also a very expensive issue. All of those days of unnecessary antimicrobial use led to more than $14,000 of unnecessary expense. And that is a vast underestimation because that is only direct expense. That doesn't take into account all of the other indirect expense of possible hospitalizations that are prolonged. Now, this slide has very, very small print, but I wanted to mostly just summarize from that study what were the scenarios associated with unnecessary antimicrobial prescribing. We talked a bit about asymptomatic bacteriuria or funguria or pyuria. That was one of the scenarios. Another scenario was treating non-infectious respiratory tract symptoms. And in this case, or in some of the cases seen in the study, things like CHF with clear documentation of CHF still having antibiotic use on board. Or in the case of a swollen and red arm or leg that was subsequently diagnosed to be a DVT, antibiotics were still used. Or finally, miscellaneous situations like, for example, having a fever and clearly having it become a transfusion reaction, but antibiotics still being taken and continued despite defervescence. So just to summarize another study that was a multi-hospital cohort study, these are some of the reasons and categories for overuse of antibiotics. And I wanted to specifically also spotlight the third situation because we didn't address it quite as much as unnecessary use or excessive antibiotic duration. Using fluoroquinolones in situations that don't need such broad-spectrum antibiotics also contributes to antibiotic overuse. So antibiotic prescribing appropriately means the right antibiotic at the right dose for the right duration for a specific condition. And in the US, there's millions of people who become infected with bacteria that are resistant to antibiotics, and hundreds of thousands of people die each year from these infections. These are all preventable illnesses. And a quick word about antimicrobial resistance, or AMR, in India. So United States is certainly right up there, and India is, as well as other countries are, topping the list of those with highest antibiotic consumption and therefore the highest amount of antimicrobial resistance. And in fact, this particular statistic that I pulled from this source was very stunning to me, that antimicrobial resistance is such a big global public health threat that it causes more than 1 million deaths worldwide, and worldwide actually nearly 5 million deaths, that in 2019 was more than that of both either HIV or malaria. So that is stunning. So let me close out the final section here with a case study. And this is one of my patients, 72-year-old who had 2 days of dysuria and had a pan-sensitive E. coli. And this was not done by me, but in an urgent care, patient received 3 days of Cipro. And hopefully by now that treatment will make you realize that perhaps may not have been the right treatment. The symptoms improved, but 6 months later with recurrent symptoms, a urine culture was obtained, and this is what it showed. And if it isn't clear because the print is small, just know everything is an R, meaning resistance. And I would even venture to say that the cefoxitin, which says it's sensitive, I would be highly suspicious that that is in fact not correct and that this is an inducible extended spectrum beta-lactamase. So basically, this patient had virtually no options for treatment. And so what are some of the consequences? The increased resistance that we just saw in the previous slide, but also certainly in the US, a Z-Pak or azithromycin is often commonly prescribed almost carelessly, often for acute uncomplicated bronchitis. And this FDA alert was issued, which noted that there was some fatal arrhythmias that could be introduced by azithromycin for those particularly at risk of cardiovascular disease. So potentially introducing side effects that could lead to mortality is another consequence. Now, we are still in the COVID pandemic, and I certainly wish all of you there in India staying safe and healthy from COVID-19. I wanted to speak about a new pandemic where there's normal white cell count, a normal urinalysis, the chest x-ray is normal, and the fever may not even be present. What is this epidemic? So as might be gathered, this is a bit of a humorous, facetious slide, but I call this levaquin deficiency syndrome. And this was first coined when I was a resident, where it seemed like anybody would simply just get a levofloxacin prescription, whether or not they had any indication for infection. And so what's the cure for this very significant and problematic epidemic of levaquin deficiency syndrome? Well, let me share with you an FDA update, and I wanted to spotlight this for all of you as a pitfall you want to avoid, that fluoroquinolones not only give an increased risk of tendon rupture and tendonitis, but those who have myasthenia gravis, it can actually lead to exacerbation of their condition, and also there is a potential for irreversible peripheral neuropathy. Here's an additional cure for levaquin deficiency syndrome. The mental health side effects of levofloxacin or broad-spectrum fluoroquinolones can lead to disorientation, agitation, memory impairment, and delirium. Now, in terms of antibiotic prescribing epidemiology, from the CDC data, almost 30% are unnecessary. And as we pointed out, it is not just a national threat, it is an international threat that antibiotic resistance poses. So we, as internal medicine physicians, whether or not we are infectious disease specialists, play an absolutely crucial role in antibiotic appropriate prescribing. And what has happened now is, because of the antibiotic resistance, we now have the rise of superbugs, which really have almost nothing available to treat them. And the antibiotic overuse has been significantly contributed to by many of these online medical services or urgent care centers, where they often aren't making the right diagnosis, but they are just giving a Z-Pak a day to keep the doctor away. And in the event of that, will lead to more antibiotic resistance. So in summary, what I wanted to leave you all with is certainly some pearls of what you need to do to make the right diagnosis in Staph aureus bacteria in the urine, in UTIs, in pyelonephritis, in bronchitis and pneumonia. But we as internal medicine physicians, regardless of our subspecialty or focus, need to make sure that we avoid pitfalls, make the right diagnosis, use the right antibiotic for the right duration, and that prudent antimicrobial use is critical to make sure that this epidemic, this pandemic of antibiotic resistance does not overcome us. So with that, I wanted to thank you so much for your attention. And if there are time constraints, I will be happy to take questions afterwards, and I will be with you for the rest of the meeting.
Dr. Vamani, Dr. Jayant Panda, who is the chairman of the organizing committee, is sitting with me. He is professor here in Cuttack Medical College. So before I ask to Dr. Jayant Panda, I would request Dr. Vamani to summarize the session. And before us, Dr. Muruganathan is also sitting with me. So all of us are listening you, and we all enjoyed your wonderful lecture.
I wanted to just thank Dr. Vamani and Dr. Panda, and my warm greetings to Dr. Muruganathan as well. Thank you so much.
Thank you, Dr. Alisa, for a wonderful talk. You have covered the entire subject, but more importantly, you have rightly stressed on the so-called pandemic of misuse of antibiotics. And there is no doubt that a judicious use of antibiotics is very important to know when not to give. And it's very important to know when to give, for how long to give, at what dosage to give. These things are very important to prevent the so-called superbug or antimicrobial resistance. And I'm very happy that you have stressed this point so nicely and emphasized on this, because the misuse of antibiotics is very high. It was also seen during the COVID era. We have misused antibiotics left and right. We have misused steroids left and right. And it's time to go back and retrospect on the mistakes and learn from the mistakes that we have committed. Thank you. Any questions are there from the audience? Or Dr. Panda would like to make a comment?
I think everything has been shared. Just in a single line, I will conclude. Infectious disease is still a big burden for India. In a developing country, day in and day out, we are fighting with infections. Please get a chair. Yeah. Sir, please come.
Elisa, can you hear me? Hi, Dr. Muruganathan.
Hello, Dr. Muruganathan. So nice to hear from you and so nice to see you, sir.
We are really missing you. I mean, you know,
I am missing you all, and my only positive from all of this is that Boston will be hosting ACP's meeting next year, so I look forward to warmly welcoming you in person then.
Yeah, now first let me give you a virtual hug and then start my questions. Huh?
Yes.
Yeah. Okay. Your talk was excellent, and especially I like that liver flow deficiency syndrome is really good. But we have a different deficiency here, not like in your country. We have different deficiency. And what is the role of any vaccine you roll here in this acquired pneumonia, community acquired pneumonia? Vaccination.
Dr. Muruganathan, I wanted to make sure I heard the question correctly. What is the role of vaccination to prevent community-acquired pneumonia?
Yeah.
Yes, thank you. Wonderful question. So I have talks that I give just on vaccinations, and obviously I did not focus on that in this talk, but I absolutely agree that's a wonderful question. So we have, and this may also be the case in India as well, but we have vaccinations against organisms that typically cause community-acquired pneumonia, and as was indicated in my slide, pneumococcus or streptococcus pneumonia is one of the biggest etiologic agents of community-acquired pneumonia. We have very good vaccinations against them, and in a different talk that I give, I often talk about how underutilized some of these vaccinations are, particularly pneumococcal vaccines. Let's also not forget one can get pneumonia from viruses, influenza. So right now, I'm doing a lot of counseling with my patients to be vaccinated against viral pathogens that cause community-acquired pneumonia, influenza. In the U.S. here, we just had approval of RSV vaccine, respiratory syncytial virus vaccine, and that is just kind of getting out of the starting gate. And then, of course, we are still in COVID-19 pandemic. COVID-19, as everybody knows by now, causes significant lung and pulmonary complications, including multifocal pneumonia. So I will say, in anticipation of me joining all of you in person, I also got my updated COVID-19 vaccine. So what we can do for the vaccines, and again, thank you, Dr. Muruganathan, for the perfectly timed question. Prevention is key. Prevention is better than treatment. Whenever possible. So counsel your patients. And here is where internal medicine physicians can make such a big impact, because often as infectious disease specialists, we're not the ones doing the promoting of the vaccines until after the patient may have already been infected. So when you see your patients, talk about the vaccines, influenza, pneumococcal vaccine, COVID-19 vaccine. If patients need Haemophilus influenza or Hib vaccine, and certainly COVID-19 vaccines. So thank you. That is a wonderful, wonderful point.
Yeah, that's why I want to raise that point, because prevention is better and that vaccination role is important. And especially in your country, you have pneumococcal 20, PCV 20, but unfortunately we don't have. We still use PCV 13. Sooner I think we'll get 20 also.
Yes, and I hope that PCV 20 does make it to India soon, but even still, it is still a very effective vaccine, Prevnar 13, and we in the US, we do both Prevnar 13 and or Prevnar 20, depending on which one is available. But if Prevnar 20 is not available, we often have patients get vaccinated with the pneumococcal polysaccharide vaccine, which is a 23-valent. And so between all of these different options, we can make significant impact on the incidence of pneumococcal-derived community-acquired pneumonia. And so absolutely agree, prevention is always better whenever possible. So thank you, sir.
Thank you, Dr. Elisha Choi. And we know that infection is a big challenge in the developing countries like India and us. And fighting infections, maybe for a urinary tract, maybe for a respiratory tract, maybe for a skin and soft tissue, for an elderly patient and immunocompromised patient, it's life-saving if we timely intervene and properly fight. And Dr. Elisha has rightly shown us what should be the approach and how we should monitor the infections and how rationally you can manage that. So give a big hand to Dr. Elisha. With this, I can close this session and we'll have the oration later. I'm handing it over to Dr. Birmani.
Thank you, Elisha. We'll wait for your oration after the inauguration is over. In the meantime, we'll go to the next speaker. The next speaker is Dr. R.R. Singh from Jhansi. Dr. R.R. Singh, are you there, sir? Yeah.
यहाँ से नहीं होगा ये So heart failure is the most prevalent cardiovascular disease globally and carries almost 50% mortality at the rate of 5 years. Heart failure affects around 64 million patients worldwide, and 20% of the men and women over 40 they are at risk of heart failure. Traditionally, left ventricular ejection fraction, and we call it like EF or ejection fraction, has been a cornerstone for the classification and the prognosis of the patients with heart failure. So, left ventricular ejection fraction of less than 40 was defined as the reduced ejection fraction, and LVEF more than 50% as a preserved ejection fraction. Since my talk is concerned basically on the preserved heart, ejection fraction, so I will be talking more about it and least or know about the reduced ejection fraction. Heart failure, as we know that it is the end stage of the most of the heart diseases that has emerged as a major global public heart problem. And the estimated prevalence of the heart failure in India is around 1%. And the estimated mortality is 0.1 to 0.16 million individuals per year. As per guidelines of the heart failure registry, 65% of the heart failure patients with reduced ejection fraction in hospital mortality was 6.7%, and in 90 days mortality was 14.2%, and so that was very much high. So as per of the guideline directed by the medical therapies, 47.5 47% people they received the treatment for it. These are the common causes like arrhythmias, myocardial infarction, hypertension, anemia, atherosclerosis, infection and obesity, and alcohol and tobacco overuse or use which causes heart failure. Looking at the terminology which is very important before going say in hospital stay of the patients from hospital admission to discharge, we should know what is stroke volume, and it is the amount of the blood which is pumped out by the left ventricle per beat, and the value for a normal healthy individual is around 75 milliliter. And diastolic volume, this is the volume which is ejected by the left ventricle, which remains in the left ventricle at the end of the diastole, and it is around 125 ml. And systolic volume, which is the amount remaining after the systole, and this is around 55 ml. So ejection fraction is the fraction of the blood which is ejected by the left ventricle relative to its end diastolic volume. So EF is equal to SV upon EDV, which is multiplied by 100%, and the normal range that way it comes around 66%. When we classify this ejection fraction, so less than 40% is the reduced ejection fraction and more than 50% is the preserved ejection fraction. That is commonly followed by this classification is very important for the management of the heart failure. In heart failure, the symptoms which we get in the patient, they are commonly fatigue, weakness, shortness of the breath, cough, wheezing, anorexia, loss of appetite, nausea, vomiting, and on signs we find pulmonary edema, pleural effusion, tachycardia, narrow pressure pulse, cardiomegaly or peripheral edema. Looking at the pathophysiology, for the left ventricular failure, there is ischemic heart disease, myocarditis or valvular heart disease, and for right ventricular failure, it is cor pulmonale, right-sided valvular diseases or right-sided myocardial diseases and pulmonary hypertension. So right ventricular failure leads to compensatory hypertrophy and dilatation, and in this stage of compensatory mechanism there is a congestive heart failure also. Sign and symptoms, they evaluate, and this is the history and the physical examination which tells us about its certainty whether it is a reduced ejection fraction or a preserved ejection fraction. Talking of the management of the heart failure, which is more concerned in this slide, in this talk, when the patient is admitted, patient's education is very important, and non-pharmacological management along with the pharmacological management, both are to be taken care of, and in certain scenario implantation of the devices may be there. So cornerstone of the heart failure management, it differs for the reduced ejection fraction and for the preserved ejection fraction. In non-pharmacological management, in ICU setting, the bed rest, consumable small amounts of the frequent meals, moderate sodium restriction, that is 2 to 4 gram per day, and avoid alcohol intake. Pharmacological management includes ARNI, AC inhibitors, aldosterone antagonist, angiotensin receptor blockers, sodium glucose transport, that's SGLT2 inhibitors, diuretics, inotropics, beta blockers, calcium blockers, vasodilators, and digitalists like glycosides. So for the preserved ejection fraction, we can treat patients with beta blockers, MRA, diuretics, or drug as per comorbidities which are required, and the vaccine has got also role. While for the reduced, I would like to mention ivermectin, digoxin, hydrolazine like drugs, and for the low blood pressure, say inotropic drugs like dopamine and dovitramine are to be used. Since the mortality is too much for the reduced ejection fraction, but not for the preserved ejection fraction, so heart failure latest guidelines, whether it is ACC or AHA guidelines, they recommend for renin-angiotensin system inhibition along with ACE inhibitors or ARB or ARNI. So these are the three cornerstones for the management: ACE inhibitors, ARB, and ARNIs. It depends on the ejection fraction. ESC guidelines also recommend these 4 drugs like beta blockers, ARNIs, MRA and SGLT2 inhibitors. What are the negative predictors? Once the patient is admitted in the hospital, if the age is more than 60, it is a negative predictor. Male sex, then left bundle branch block, severe adverse remodeling at the diagnosis, ischemic etiology and no hypertension. If BP is low at the time of admission, then these patients, they have the worst prognosis. While the positive predictors, they are the younger age, female sex, no left bundle branch block, there is ischemic etiology, but the hypertension is there or blood pressure is established. It's normal, 130 to 130 by 80, and optimal use of beta blockers is there. So heart failure, which we know that it's very frequent, 64 million people are globally involved for this disease, and it's very progressive. Out of 10, 9 they have very serious illness, and it's a deadly disease. 5 years mortality for the heart failure that exceeds more than the prostatic cancer, and the treatment is also very costly. Most of the people, they are hospitalized in the ICU. Looking at the global end, mean age of patient is 53, while in our India it is the mean age 53 years, and for the global it is 73 years. In hospital mortality is 3.8%, while in India in hospital mortality is around 30%, that is 10 times than the global when we compare with the US and the other countries, Europe. And post-discharge mortality, that is after 6 months, it is 8.6%, while in India it is 26.3%. So the scenario is very bad for the patients that are affected at the, and the people, those who are affected at the younger age, have a very high mortality, either in the hospital or after discharge. Trivandrum, there is a famous Trivandrum heart failure registry that also says that only 1/4 of the patients were prescribed on GDMT at the time of hospital discharge, and they were treated either by beta blockers or ACE or ARVs or AMRA or GDMT or combination of the drugs. Let's discuss few of the scenario. A patient is 59 years, he is having LVF 48%, NYHA class 2, EGFR is 45 and BP is normal, heart rate is normal. Current treatment, he is getting ramipril, carbidiol and spironolactone. Should all patients currently be on ACE or ARV inhibitors, or we should wait till they become stable? So heart failure history also says that if you delay the treatment, then the prognosis is very poor, and there's the chances of the sudden cardiac death are there. So for the stability, these patients are immediately to be hospitalized and should to be managed. And ARNI should be started as early as possible. Don't wait till the deterioration occurs. Case 2, 61 years person, old male with LVEF 54%. So that is a preserved ejection fraction, NYHA class 2, blood pressure is 100/70, heart rate 70, EGFR 61. In patient with borderline systolic blood pressure, will the use of ARNI be beneficial? Yes, it reduces the risk of overall mortality for the reduced ejection fraction, patients with low BP also. Looking at the insight of the titration study, we find that 80% of the patients with systolic blood pressure less than 120, they achieved treatment successfully with graduate upgraded titration of the drug. So these are the current parameters. Case 3, in which consideration while titrating ARNI in CKD patients, we find that change of the renal function, which is associated with the drug treatment in heart failure as per national guidelines. Drugs, they improve when we compared with the enalapril, sacubitril versus valsartan combination. So 20% reduction in CV mortality was found in the heart failure after hospitalization with ARNI, and they were also having some reduced ejection fraction along with CKD. So in both the groups, the reduction was 21%. how to manage patient of hyperkalemia or those who are on sacubitril and valsartan combinations. Diet control should be there. We have to restrict low potassium diet, small doses of loop diuretics like furosemide or torsemide. Then potassium binding in the emergency situation like spironolactone, like drugs are to be used. And the old is gold, that is glucose plus insulin combination, infusion in the form of infusion are to be given for managing the hyperkalemia. And Petriomer will be a boon when it is launched. Right now it's not available in our country. Case 4 is there, then 62 years person with diabetes on metformin and glycoside. Ejection fraction 55%, HbA1c is 8.8, creatinine 1.1 and BP is stable, 145/90. What will be the management strategies? Do you initiate GDMT in this preserved ejection fraction? Or can value of anti-pro-BNP be considered a valuable tool for this patient? Response for the therapy. Since the patient is having comorbidities like CKD and other things, but the ejection fraction is maintained, so we can put on two kinds of drugs like diuretics along with SGLT2 inhibitors and ARNIs. So many drugs can be combined together when the blood pressure is stable. Heart failure with resistance hypertension going ahead. Do we feel the use of ARNI can be explored in resistance hypertension patients? Yes, it is very useful because this reduces the edema, this reduces the heart failure. So multiple functions can be obtained with the use of two drugs combination, that is sacubitril valsartan. Recently, for last say 1 or 2 years, this combination has come up and it has been quite effective. So finally telling to you people, these are the 4 fantastic pillars which we can use in the patients, those who are having preserved ejection fraction and are hospitalized. So from hospitalized to discharge, right, starting with the diuretics and oxygen support, we can use these 4 drugs like beta blockers in the form of metoprolol and carvedilol, then MRAs, then angiotensin receptor neprilysin inhibitors. I have just talked a lot about this combination, and SGLT2 inhibitors. So they do wonder in management once patient is hospitalized with heart failure. Thanking you very much. Thanking you, chairpersons. Thanking you, sir.
Thank you, Dr. R.R. Singh, for fantastic talk, and we really enjoyed it. Any question from the audience? Yes. Somebody can give the mic.
Okay, thank you for your nice talk.
Sir.
So what I want to point out, this last slide, you have shown the 4 pillars of heart failure treatment. So now, how to use all the 4 drugs?
Sir.
Whether, which one to be given fast, which one the second, you told 4 drugs, so which one the third, or should you give in at a time? So how do you give?
Sir, if the patient of heart failure he is having some tachycardia, and then we can start with the beta blockers only in the form of carvedilol or metoprolol. They can be given. If there is something like say pulmonary edema or CREPS, they are there, then the drugs that to be given are the ARNIs, because they reduce the edema part and they take care of the blood pressure also. And if the patient is having comorbidities like diabetes is there, hypertension is there, CKD is there, then we should add on this SGLT2 inhibitors. So that way we can choose, and it is a tailored treatment what to give. So initially people, they can be maintained only on the diuretics, but in later conditions, suppose there is comorbid conditions like COPD is there, then we have to add on the bronchodilators, we have to give oxygen therapy, so that becomes the other part. So it depends whether it is a right-sided failure and left-sided failure, that also differentiates. But certain drugs, these 4 along with these 4 drugs, other drugs, they are to be used as the digitalis and diuretics also.
No, what I want to tell you, because we physicians, we don't deal with very problematic cases. We do deal with stable cases. Okay? So stable cases of heart failure, now what the consensus is, updated consensus is that you have to use all the 4 drugs as soon as possible. Means within 2 to 4 weeks, you must use all the 4 drugs. Start with little of all 4 because all of are complementary action. So ARNI, low dose of ARNI, low dose of beta blockers, low dose of MRA, and low dose of these SGLT2 inhibitors. Of course, there is no low dose; it is a single. So now the latest consensus is you have to start all the 4 drugs within a very short time, not that just go on after training and go for months. So
And delay may be dangerous for the
so
patient.
that one can get
The current recommendations are very clear. Fortunately, SGLT2 inhibitors you give only in 1 dose, so nothing to worry. You start immediately and continue in the same dose. All the other 3, the ARNIs, the MRAs, and the third beta blockers have to be started in low dosages and then up titrated, and all have to be started simultaneously. Within 3 to 4 weeks, the patient should be on maximum tolerated guideline directed dosages. That is very important. And in fact, the dosage, all the 4 have to be started at pre-discharge level. Once the patient is stabilized in the hospital, before you discharge him, and the prescription, outgoing prescription on discharge should contain all the 4 drugs. SGLT2 in the normal dosage and rest all in low dosages. And then you upgrade within 1 to 2 weeks, and within 3 to 4 weeks you are at the top level.
Right.
That's the current recommendation.
Agreed.
Thank you.
And SGLT2 irrespective of the diabetic status. Irrespective of the diabetic.
Thank you. Any question? Any other? Yeah, please.
Thank you, Dr. Singh. I fully agree with Dr. Virmani that he has explained well about the 4 drugs, how to use, but the recommendation is first to use is beta blocker because it has got the highest mortality benefit. After that, all other 3 drugs we can start simultaneously, or maybe SGLT2, then ARNI and MRA, like that, but within 4 weeks, as Dr. Virmani has also mentioned, and they should be given in pre-discharge status. And regarding the 4 pillars, nowadays another pillar has come up, that is cardiac rehabilitation. This is supposed to be the 5th pillar in the management of heart failure, especially HPF.
Cardiac rehabilitation.
Cardiac rehabilitation.
I think whether to start ARNI first or beta blocker first has been a raging debate for a very long time. So that is why the current recommendation said don't think of which is 1, which is 2. Start all of them together in the low dosages. So there is no problem in starting once the patient is stabilized. That is very important. Thank you. I think we will close the session here.
Discuss this later. And during the dinner time, we can have a lot of time to discussion.
We'll go to the, thank you Dr. Hara Singh for a wonderful talk. We'll go to the next speaker is Dr. Narsingh Verma. Dr. Narsingh Verma, please. And he'll be talking on, of course, home monitoring of blood pressure, very important thing. Why, when, and whom. Over to you, sir.
Thank you, chairpersons and our scientific chairman, Dr. Virmani, for giving me this opportunity to talk about the topic which is very close to my heart, and almost everywhere I am getting the same topic. I will try to do justice in the allotted time. And regarding the measurement of blood pressure, one thing you all will agree that most of the physicians, cardiologists, nephrologists, neurologists can talk in length, hours together, about the management of hypertension, but without measuring it. They never bother how to measure it. They can talk hours together, which drug to be given, in which combination to be given, what not to be given, but regarding measurement, they are silent. So I will be talking about home monitoring, one aspect of blood pressure measurement. And so hypertension is a silent killer. I think everybody will agree. And over half of the death due to ischemic heart disease, stroke, and chronic kidney disease are attributed to high blood pressure. About 10% of all deaths in India are due to hypertension, such a great mortality by this hypertension. That is why it is called a silent killer, because it do not have any symptoms. And regarding measurement of blood pressure, it started in 17th century, and at that time you see how the blood pressure was being measured. That was the condition at that time, measuring blood pressure in the horse, that is shown here. But now we have very good monitors which can measure blood pressure very accurately without any problem. So today we have palpatory method, which is taught in the physiology, in medical curriculum, and auscultatory, oscillatory, office BP, and ambulatory blood pressure monitoring, home blood pressure monitoring, and automated office BP. So these are the methods which are prevalent today for the measurement of blood pressure. And one sentence is still, Dr. Norman Kaplan is not with us, but what he said is very correct even today. The measurement of blood pressure is the clinical procedure of greatest importance that is performed in the slopiest manner. What he said is correct even today. So this is the why different type of measurement of blood pressure, office measurement, home monitoring, ABPM, and our value depends upon what method we have applied. So for office BP, it is 140, 90 or less than that, and the daytime awake is less than 135 and less than 85, and when we are doing ABPM, the nighttime BP less than 120 and less than 70 is normal, and 24-hour average is less than 130 and 80. While we are doing ABPM and home BP, it is again different, 135, 85. So the value even differ what measurement we are taking, and that is why it is important to know. Benefits of automated or manual office blood pressure measurement is still, lot of physicians are confused that the mercury one is the best one. It is the gold standard, and still they are preferring the manual method of measurement of blood pressure. But no doubt we have lot of data which says that the automated one is better than the manual one. It has less errors because we have very good quality monitors. So blood pressure parameter is the most variable parameter. We know that blood pressure keep on varying, and this variance in blood pressure can be from beat to beat, minute to minute, hours to hours, and even in 24 hours. And not only that, from one measurement to another measurement, and in every clinic measurement it keeps on varying, and also it varies according to season. During summers, blood pressure goes down, and during winters, like the country India, where we have to aid a drug during October, November, and we have to withdraw the drug during the time of the April, May, June, July. So not only that, the blood pressure normally varies in response to various physiological parameters, and it is regarding the physical activity, it keep on varying. The experience, the emotions can vary it, and the posture can vary it, and the respiratory cycle, with each respiratory cycle during inspiration and expiration, the pressure varies, and in the time of day, it keep on varying. The food ingestion, salt intake, caffeine intake, use of nicotine, alcohol, etc. can have impact on blood pressure, and this will vary. Sleep deprivation will have impact, and seasonal variations are there, and the high altitude will definitely have impact on the blood pressure. Not only that, these are the conditions where blood pressure can vary, and this must be known that most of the physicians say that these automated ones are not good. If two readings are differing, it is more sensitive. And why the readings are different? because of these factors which are very, very important. According to them, the blood pressure keep on varying, and these are the conditions which you have listed upon, and you see how much variation can be there. It can be the tune of 30 to 40 millimeter of mercury. When I was taking such a lecture in one of the meeting, and I said that when I was taking lecture at KGMU, at that time in KGMU lecture theaters were very bad and there was nothing available. So we have to shout for our lectures, and during that time I did my ABPM and my blood pressure during my lecture. We have to shout because the fans were having a lot of noise, and we have to make our voice above the noise of the fan. And during that, my lecture, my blood pressure by ABPM was recorded as 180 by 110. I'm not hypertensive. This is just because of my overexertion. The blood pressure was more at that particular time. It is also called as episodic hypertension. It is not hypertension. So we must keep in mind that these conditions may be responsible for variable blood pressure. And some other conditions which are important for the variable of blood pressure, they are listed here just to save time. I'm not going to read all of them, just showing that these are the conditions which are responsible for the changing blood pressure, which can change. So we have to keep in mind that the automated one, having good quality monitors, they are very sensitive, and because of that sensitivity, the blood pressure readings may differ. This is not the fault of machine. It is because of the varying blood pressure at different conditions. This is episodic hypertension, and these are the conditions where the episodic hypertension can be there, and this episodic hypertension requires a different treatment. The treatment cannot be same. Here, most of the time, patients come to us and say that, doctor, I'm taking this medicine for blood pressure, please don't remove it. And that is simply anxiolytic. So they are having episodic hypertension. And the advantages of home blood pressure monitoring over the conventional BP monitoring are shown here. You can see performing the multiple measurements, which is possible by the home monitoring, these automated one, which is not possible by the monitoring which is done at the clinic. And cost is less, and the white coat effect can be easily diagnosed by home monitoring. Not only that, improving the patient compliance. Compliance improves because patient monitors blood pressure, and when it monitors, it keep on taking drugs, unlike to the when the monitoring is not done. And not only that, possibility of the storage of reading is also there. There are good monitors which can store large data, and we can have these data stored in the monitor itself. They do not require a diary. Not only that, the ABPM, another method of the out-of-office measurement of blood pressure, and here the ESC guideline has compared both of them, and you see that home monitoring is almost equal to the ABPM, except one thing, that nighttime change in blood pressure cannot be recorded very nicely. But when we are not able to perform ABPM, which is not possible for all patients, then we have to go for second option, that is home monitoring. So we can have the same quality data by home monitoring. Now, why home monitoring I have talked about. Then comes the how. For how, the first thing is the equipment. And why home monitoring was not so popular in my country. Today I cannot say that. The COVID has made these home monitoring very, very popular. And during COVID times, almost every Indian has purchased three things: glucometer, pulse oximeter, and the monitor for blood pressure. Most of them have purchased it. So the equipment is more important, and fully automated equipment is better one, and the documentation can also be done by that. And to have a good quality equipment is the first priority for the home monitoring. If the equipment quality is not good, then definitely data will suffer, and the patient may have complained that the monitoring is not correct. So to have the good quality monitor, the validated equipment must be purchased, and for that I have given two important sources by which you can find out that how a validated equipment can be shot, and you can find out whether the equipment which is being used is validated one or not. These are the two sites where every details are available regarding the validated equipment, and at present in India only two equipments are there which are validated one. I will not name them because that is not my job. You can find it out by these guidelines. Then the one monitor usually have all these qualities which I am mentioning here. The method used by these monitors is oscillometric method, and here the blood pressure range which can measure, the monitor can measure, is 30 to 260, and pulse, this range of pulse can be measured by the monitor, and the pressure, etc., accuracy, all these things I have written here. These are the qualities or necessities what a monitor must have. Then the approach to an accurate blood pressure measurement, first thing was equipment, which I talked about, and then the provider staff should be trained and regularly retrained. This training part is very important, and that requires time, and most of the physicians are lacking time. That is why the training part is not there. If training part is not there, obviously the result will not be good. And patient must be properly prepared and positioned before measurement of blood pressure, and that requires training and setting of the quiet room, chair and back support and arm support. All these things must be kept in line so that we can have the good data. Then comes the use of home blood pressure monitoring. Office BP measurement is associated with several disadvantages, and a study I have quoted here that the large variability in office BP reading have been reported both in clinical trials and in the primary care settings. And a study in which repeated BP measurements were made over a 2-week period under research study conditions found variation of as much as 30 millimeter mercury with no treatment changes. So that was the condition when the home BP monitoring was not popular. So this is how to measure your blood pressure at home. The preparation is important, then the position is important. I'm not going into detail about it because that is not my topic, but just giving a hint that everything is important. Preparation is important before measurement of blood pressure. The caffeine, etc. should not be taken. And the preparation in the form of the room temperature, the belt, etc., all these things, and the filled bladder must not be there. So these things are important. Then positioning of the patient is important, and then the measurement of blood pressure. Just to cut short because the time allotted is going very fast. So this is how the cuff is applied, and not only the application of cuff, the size of cuff is very important, and usually the physicians have a single size cuff, while 4 sizes of cuff are required. So the best thing is that you can say to your patient that please buy your cuff is different. It is not present in my clinic. Again, correct technique, again shown here. Most of these things already discussed so many times, so I think you must be knowing them. And after that, the readings, at least 2 readings should be taken, preferably 3 readings, and record them all. The interval between them can be 1 minute apart or a little more. Readings should be routinely taken in the morning, before medication, before breakfast, and in the night before going to bed. And the important thing is that the bladder should be empty. And the recommendation is to take 2 readings, more than 2 morning readings and 2 evening readings for at least 1 week, because every day of the week is different. The routine of the patient is not same Monday to Saturday, so it must be kept in mind. Recommendations for the use of home blood pressure monitoring are plenty. Most of the guidelines recommend them, and you go and see. Most of the guidelines they recommend, and BP measurement is best by the home monitoring. AHA recommendations are also favoring them, and they say that home monitoring or self-measured blood pressure is not a substitute for a regular visit to physician. That must be there, because only measuring blood pressure is not enough. Visit to physician is mandatory to show that data and reconfirm that readings are taken correctly. Advantages are plenty. Home monitoring allows increased number of readings, achieving more reproducible readings than office readings, and provide improved correlation with measures of target organ damage. So that again shows that importance of home monitoring. And another important thing is that to diagnose white coat hypertension, and not only white coat, to diagnose the mask hypertension. The various meta-analyses have shown that, I will end only 2 slides left, and that is regarding screening and diagnosis of hypertension. The guidelines support that what should be done when blood pressure is in that range. And the last slide regarding the treatment, I will end here. And to summarize, monitoring of BP is essential part of management, but is still overlooked. Office measurement is not enough. Home monitoring is the most simple, reliable, reproducible tool. Home monitoring is indicated and recommended by most of the guidelines. In recently concluded grand study, which is done in India, the first study being done in India regarding home monitoring, the data are available. Very soon you will find the papers on that. In that grand study, again, the Indian data are available regarding the home monitoring. It was done on 20 centers across India under the auspices of Indian Society of Hypertension. It improves compliance and adherence to treatment, and it predicts target organ damage better. Thank you very much for listening. Thank you.
Thank you, sir. As always, it has been the wonderful talk. Lot of questions are there about the blood pressure measurement, but we are running too late, so that's why I don't want that these questions should be asked now. Otherwise, I know that 15-20 minutes discussion would be there. So, would be having these questions during the dinner time?
Yeah, thank you. Thank you.
It was a very nice talk, Narsingh Verma. Home blood pressure monitoring is very, very useful for pregnancy, hypertension, children, as well as now we have got what is known as night view home blood pressure monitoring, as well as equal to home, ABPM. This takes 2 a.m., 3 a.m. and 4 a.m. So now new monitors have come. Even in India we get that monitor. So home BP monitor will replace ABPM sooner. So just to add those points. So it can be used during dialysis, pregnancy, children, and everybody should promote home blood pressure monitoring. So whenever you will give any presentation to anybody for the 60th wedding anniversary or birthday, give only home BP monitor to all the patients, all your friends and relatives, so that we can promote home blood pressure monitoring. Thank you.
Very correct, sir. Now we have good quality monitors which can be used even at atrial fibrillation, and they can also measure night-time blood pressure. Thank you. Thank you very much.
Thank you, sir, for that nice informative talk. So we are at the most awaited moment of starting our inauguration after one presentation, and I thank Dr. Narsingh Verma ji for making sure informative presentation in time. So we formally invite our chief guest of the day, Professor Ashok Mahapatra sir, who was the head of neurosurgery at AIIMS Delhi and director AIIMS Bhubaneswar, vice chancellor Shiksha Anusandhan University, and a management committee member now, who is not only a doctor, scientist, researcher, very good neurosurgeon, but also is a social man, has a lot of contribution in the social, spiritual front, and in COVID time he has done a big job in helping the government and the administration, guiding the way of treatment and therapy. Please give a big hand for Professor Ashok Mahapatra sir. We welcome him formally, and very soon in 15 minutes time maybe we'll be starting our inaugural program after preparing the hall. Both the hall will be connected, and inaugural will also be short because there is no long agenda. So I request Dr. Anuj to invite.
So next session is another very interesting topic, and in fact I should say that this is a talk of the town and talk of the time, both generic versus non-generic. We have had a lot of discussion in last 1 month. Lot of energy has been and lot of adrenaline has been released on this topic. So for this topic we are having a very learned speaker from King George Medical University, Professor A.K. Sachan, who is the head of department as well as professor and head of department pharmacology, and he is also the chairman of in the Institute of the Medical Sciences, which is running 2 medical colleges at Lucknow. With this small introduction, I will request Professor Sachan to join us on the dais. And many of you must have attended the Soul Curry program, which has been done few days before on the platform of American College of Physicians online program it was. Over to Professor Sachan.
Thank you, Dr. Anuj Maheshwari, for giving this opportunity to come here and present this very important topic. And practically speaking, this is the need of everyone, that we should understand the difference between generic, non-generic and various other models we will be discussing now. Just for the we would like to go for the history. The first modern pharmaceutical medicine was invented in 1804. Not very long, only 200 years back, there was the first medicine was invented by Frederick Straton, who was a German scientist, and he derived the first drug by the name of morphine, which is still in use. In Atharvaveda, this is the Veda, fourth Veda, where we talk about the medicines. And the Indian pillars of medicine are Charak and Sushrut. Charak is the traditional physician and Sushrut is the surgeon. And we all know about the Hippocrates. We all are taking the Hippocratic oath. He is the great Greek physician who is considered as the father of the modern medicine. Now, before going into details of the drug, we should know little about the drug development, how it comes. And when we understand this, then we can understand the various types of medications which are available in the market. The substances are recognized as an official pharmacopoeia in Pulmonary, and the substances intended for use in diagnosis, cure, mitigation, treatment and prevention of a disease, and substances other than the food intended to affect the structure and function of the body, and the substances which are intended for the use as a component of a medicine, but not a device or a component or a part or accessory of a device. That's how the drug development is described, the process of developing a new drug that effectively targets a specific weakness in a cell, and this process involves a specific preclinical development and testing, followed by trials in the humans to determine the efficacy of the drug. Now, the most important, there are stages in the new drug development. Initially, it's a very long process. We have to understand why this problem is coming of a generic and branded drugs. The process is very long. Synthesis takes nearly 1 to 2 years. Preclinical trials usually takes 2 to 4 years. Scrutiny of the grant of the permission takes 3 to 6 months. Pharmaceutical formulations, they take about a year. Clinical studies, they take about 3 to 10 years. And then review and grant of marketing permission, which takes from 1 year to 2 years. And post-marketing surveillance, now it continues throughout the life. So you can understand a life cycle of a drug is very long. Thereafter, we do preclinical tests in vitro and vivo both. And then we'll cut short this thing. We'll go into main part. The post-market drug safety monitoring. The monitoring of the drugs, they reach the market after clinical trials. When we complete the clinical trials, then it drugs goes in the market and then evaluates the drugs taken by the individual over an extended period. And direct or previously unrecognized positive or negative effects that may be associated with the drug. And this is now known as pharmacovigilance. We keep on watching these drugs throughout its life, and many times we have seen the drug which are marketed in a grand way, and absolutely they come out with so many side effects, and ultimately we have to withdraw. I can give you one example. In 80s, a drug, when there was a treatment of peptic ulcer was not available, a drug came by the name of cimetidine. Cimetidine was considered as one of the wonder drugs. It was not only, it was prescribed left and right. By that time, the various patients were coming of perforations, intestinal perforation, almost every day. We were getting in KGMU 2 to 3 patients of perforation every day. But after coming this drug, the incidence of perforation reduced drastically. And this drug was reduced and used left and right. And ultimately what happened? That we came across with the complications, side effects of this drug. And it was gynecomastia, the development of breast in males. And ultimately it was withdrawn. Subsequently, the ranitidine, famotidine, various other drugs came, and then proton pump inhibitor came. That's how we have to understand how the drugs are being developed and how this are being used and then discontinued. Now there are two important points which we have to understand, because we keep on talking about generic, branded, this and that, but we don't understand in what way we can differentiate and what are those points which we have to take into account. There is one is known as bioavailability studies. Now this is the concentration of the drug compound that reaches the systemic circulation or the site of the action. And the bioavailability of a drug is done to assess the maximum concentration of the drug in the systemic circulation. That is known as Cmax. And the time to reach this concentration is the Tmax. And the time drug concentration under the curve is known as AUC. And these things are very important when we compare one compound to another compound, or as one drug of the same compound to another drug. There is another thing that is very much useful while we are making all these decisions, is the bioequivalence tests. What happens in the bioequivalence test? That if the bioavailability of the two products is similar, the drug products are called bioequivalent, usually carried out for the generic drug products. And the study evaluates the clinical differences in the bioavailability of the two distinct drugs. There are two compounds of similar drug, two different brands are there, and if they are not equivalent, bioequivalent, then they will be considered inferior to each other. When we call it that drug is not good, that is not effective, this is the procedure which you have to adopt. And now these labs are very few in the country, but we are used where every drug has to undergo this process, and only then we give the permission for the marketing. And even thereafter, suppose, this is a very important point to understand, whenever we say that this drug is not effective, this brand is not effective, or that generic drug is not effective, we cannot say like this. We have to prove it, and the proof is by estimating the bioequivalence of that drug. There are a few labs in India, but in UP, Uttar Pradesh, there was only one lab in the Noida, but recently one lab is opened in Lucknow also. And I have given that testing of that lab, and that is very important. What does an expiry date means? This is very important, and this is sometimes very confusing among the patients as well as among the doctors. Any patient, if takes the medicine, suppose it was supposed to expire today on 22nd. If it is on 23rd, patients, they feel that now the drug has become poison. Or many times the doctors also, they feel in the you have taken the expired drug. This simply means that the final day till the drug has full potency and the safety. This is, Government of India has made it mandatory. But even then, drugs are not like that, that today they were the drug, medicine, and tomorrow it is become poison. It is not like that. Most of the time, with the good companies, usually they put the expiry date much before the drug potency and safety is reduced. Many companies, they keep it even 6 months in advance. Suppose the drug is going to expire in June, they will put it in December just to keep the safety. So these drugs, once you say, many times patient comes, sir, मैंने ये कल दवा खा ली, अब मेरा क्या होगा, कोई परेशानी तो नहीं हो जाएगी. So you should assure them nothing is going to happen. Now, branded drugs. What are the branded drugs? A drug sold by a drug company under a specific name or a trade name that is protected by patent. A brand drug is usually the first version of a new drug that is developed and tested by the company that owns the patent. The brand drug may be available by prescription over the counter or may not be available. For example, about 20 years back, you must have used a compound by the name of Tavanic. It was a drug came for the purpose of ofloxacin. It was an initial product, and initially there was another drug by the name of garamycin. These are the patented drugs, and these patented drugs by the US FDA, they give this patent for 20 years. Before that drug becomes common, anyone can manufacture it by taking a permission from the country's authorities. But till that time, no one can make it, no one can manufacture it. So those drugs are proprietary patented drugs. And companies, because as we have already discussed, they spend a lot of time and money in development of a drug. That is why the prices of those proprietary patent drugs are very high. Now, what are the generic drugs? Generic drugs, or a simple generic, is a pharmaceutical drug that contains the same chemical substance as a drug that was originally protected by the chemical patent. Now, the patent is over. Then anyone can manufacture it. The generic drugs are allowed for a sale after the patents on the original drug expire, drugs expire, and because the active chemical substance is the same, the medical profile of the generics is equivalent to the performance compared to their performance at the time when they were patented drugs. The efficacy of both the drugs has to be the same. Now, many times I have brought this cartoon, what patient is counseled. Here is a salesman, he is saying that here is the mood elevating medication that your doctor has prescribed. This has less costly generic version and it may be compared as chocolate. He is making a fun of the generic drugs, that generic drugs are just like chocolates. It is not like this. No one can, in India, the FDA is very strong. No one can produce spurious drug or these fake drugs or less effective drugs in India. If any complaint comes, that lock can be put before that factory and he cannot produce even any other drug. Laws are very stringent, but people are not aware. That's why we keep on saying that ये दवा generic है, बिल्कुल बेकार है, अच्छी नहीं. Generic drugs are equally. I'll tell you what are the importance of the generic drugs and how we can procure it. The generic drug has the same active pharmaceutical ingredient as the original, but it may differ in some characteristics such as the manufacturing process, formulation, excipients, colors, taste, and packaging. Although they may not be associated with a particular company, the generic drugs are usually subject to the government regulations in the countries in which they are dispensed. Now, here I have tried to compare the patented drugs and the generic drugs. The developed first time by the pharmaceutical company, sold under a brand name, drugs is converted under the patent protection. Only innovative company is allowed to manufacture and market the drug. In US, the patent is granted for 20 years and the generic drugs are post-patent expiry. The drug can be manufactured and sold by the other companies. Drug is called as generic drug. The generic drugs must be identical to the branded drug in terms of efficacy, safety, routes of drug administration, and pharmacokinetics and pharmacodynamics. Drawbacks of the generic. Are generic drugs quality is less? Answer is no. It has same potency and the quality. The active ingredients, there are certain comparison where we have to understand the active ingredients in both the cases are same. The prices is very high in the branded drug and in generic it is low. The insurance coverage, all the insurance companies nowadays say in particular that you have to prescribe the drugs in generics. And inactive ingredients may differ. The strength and doses are, there is no difference, and appearance and look, they may differ. Now, I would like to tell you where the generic drugs are available. We are a little confused. Only government, there are 2 manufacturers available in India. They are manufactured predominantly by government agencies under the aegis of Pradhan Mantri Jan Aushadhi Yojana and Amrit Pharmacy. Both are autonomous bodies governed by the government of India. And their prices are definitely much less. If you compare a simple drug like ciprofloxacin, the drug is costing 55 rupees in the brand, and here it is costing only 11 rupees. And the same way, the other drugs are also, they are almost 1/5 the cost of the branded drugs. But what patients take to feel better is the generic drug. They are equally effective, but what drug companies they take to feel is the branded drugs. It is a cartoon representation. The branded generic drugs, it has come another way. Branded generic is a generic drug that has been given a proprietary market name by the manufacturer, and it may be marketed similarly to how the branded drugs, but it may or may not be cheaper than the original branded drugs. The branded generic drugs attach a proprietary name to a generic drug molecule, which is usually known as chemical molecule. For example, many times these branded generic drugs, they are more popular. For example, OLG is known as a branded generic contraceptive pill, and is given for the contraception. In India, one of the biggest manufacturer of the world, the 40% of the generic drugs supplied to US are from India. Now, diving deeper into the Indian pharma market, the branded generics are also called as prescription drugs or the ethical drugs, since they are prescribed by the doctors and marketed by the pharmaceutical companies. And branded generic drugs are also called as trade generics, since it is substituted by the retailers and pushed through distributors. Generics does not have any brand name, like Amrit Pharmacy and Pradhan Mantri Jan Aushadhi Yojana, and over-the-counter drugs are those drugs which are sold over the counter without any prescription. Yeah, I would like to give one more very important example, and we should be cautious. And here we have compared that all the generic and the generics have the similar composition. It has been tested frequently by various agencies, and we have found that it is very important. Now, initially till '94, this patented was not there, and companies can make those drugs again like the other companies. But since 2004, since 2002, the Doha agreement, now no one can manufacture the drug until the patent is expired. Now, I would like to think a case study is very important. Omeprazole was made by AstraZeneca long back. And at that time, omeprazole was going to get expired as a patent. They produced another compound which was equally effective by the name of Asymptomatic. And Asymptomatic was equally effective. There was no superiority on the omeprazole. But they tried to push that Asymptomatic just to make it a patent drug and get the same profits. I think we should take precaution to understand these methods, and we should try to do use them in our practice. The only limiting point is this: the generic drugs which are manufactured by Pradhan Mantri Jan Aushadhi Yojana or Amrit Pharmacy, they are not freely available. So because of this availability reasons, sometimes we have to use these branded generics and the branded drugs. Thank you very much for your patient hearing. I think it must have cleared all those concepts which you are in need while prescribing the drugs. If you have got any questions, I'll be happy to answer them.
Thank you, sir, for a great concept clearing about the generics versus non-generic, and you have also told us the various other definitions which were really very much confusing among the prescribers most of the time. If there is any question, one or two questions can be taken.
Who is opposing?
Why the different
Doctors, hospitals, or the companies?
doctors and their organizations?
Okay. It is a basically a financial problem. As far as doctors are concerned, they don't have any problem. They are not understanding. The bioequivalence of both the drugs are equal. Efficacy is equal. If anybody produces substandard drug, I can challenge you. It cannot happen in India. Our pharmaceutical authorities in the FDA, they are very rigid, and अगर कोई आदमी पकड़ लिया गया तो उसकी कंपनी बंद हो जाएगी, कभी चला नहीं पाएगा वो. This is for sure. आप चोरी कुछ भी चला ले जाएं बात अलग है, लेकिन गलत नहीं हो सकती. जितनी ये प्रधानमंत्री जन औषधि की योजना है या अमृत फार्मेसी की दवाएं हैं, they are equally effective. And I can ask you, you can send me the sample and the complaint, I can take action. I can myself take action.
Then we doctors are believe that the multinational companies are better than our Indian companies.
Yeah,
even their standards
this is sir, a wrong notion.
Yes.
This is a wrong notion, and we should not take this notion in our mind. However, I told you, because there are only two companies. I told you there's a Pradhan Mantri Jan Aushadhi Yojana and Amrit Pharmacy. They are manufacturing drugs only, that's all. So these two companies cannot feed the whole country. That's why we have to go in that branded area, whether pure ethical branded or we have to go for the branded generic. Both are having almost the same price. It is not, they are pushed through doctors, they are pushed through hospitals. That is the only difference. Sir.
Who decides about the names of the drugs? Names of the drugs. Because there are a lot of drugs which are look like same, they spell like same, and they sound like same.
Yeah.
I give an example. Sildenafil, which was available as Sustomate, SUSTOMAT 50 milligram, and metformin available as Sustamate 500 milligram. Imagine the problem if somebody consumes 10 tablets of the same drug.
You are, sir, absolutely correct. And in NABH, they have got a very specific clause for this, that we have to keep these look like and sound like drugs at a different counters, so that there should not be any confusion. And we should try, whenever we talk to the company people, pharmaceutical company, we should try to make drugs so that it should sound differently altogether. It should not look alike or sound alike. But NABH has made a special clause for this, that these drugs which look alike or which sound alike, they should be kept at a separate counters, so that they should not be dispensed just by chance.
Sir, recently a lot of branded generics have come into the market, especially with the latest SGLT2 inhibitors and all. And they are as good as the innovator molecules. The problem is the price. Now, I think it is a failure on the government side that they are giving license to so many companies to manufacture the same drug. Not manufacture, to market the same drug. Because it's already known how it is to be, the patent has already expired. So the only answer to this is that there should be only one drug, one brand. That is the only answer to solve the problem of generics.
there is one good proposal which I can say, but it is difficult to say, that we should stop brand altogether and we should write a drug and the company's name in bold. Suppose there is a ciprofloxacin, we should write ciprofloxacin Cipla. This is good enough, that it ensures that it is a ciprofloxacin or Cipla and it has to be good. It is a good company, it is a good quality, and that's how we can stop all these problems. But I don't know, these are regulatory things, when can it be done? But in any case, it's the same thing, but this thing will disappear. We will not have hundreds of brand names. We will not have that problem. We will have only hundreds of companies, that's all. For example, if you see one herbal company by the name of Himalaya, they don't give a name to individual products. They write only one thing and then write Himalaya. That's all. So in that way we can do in the modern practice also. But here for this forum, the most important thing is, as far as possible, if we get pure generic drug, we should really adhere to the prescription of the generic drug, and we should remove this fallacy from our mind that they are not effective. This is wrong. They cannot make anything which is not effective.
Second thing, most of us have also experienced while using some say ibuprofen preparation like Combiflam. I should not name them, but Combiflam, Ibugesic, when we use, we get less gastritis rather than comparing with the other unethical brands. If some generic brand or some standard brand is available in the market and we use it on the other place, we use this Combi or Ibugesic Plus, we get less side effects. So some difference is always there because
you have raised one more question. Oh, that is very important. That question of a spurious drug is still, after so much tough laws, strict laws, even then there are certain companies who are there in the market and they are producing those drugs by the same name, by the generic names, and they are not that effective. उनको तो पकड़ करके हमें बंद कराना ही उनका इलाज है. तो spurious drug को we cannot compare with the generic drug. Generic drugs are not spurious drugs. We have to remember it, and because it is a government protected program. बोध की योजना एक तो प्रधानमंत्री के नाम से चल रही है और दूसरी अमृत फार्मेसी वो भी प्रधानमंत्री की योजना है और उनमें किसी भी तरीके से इस तरीके का एलिगेशन हम सोच भी नहीं सकते हैं बिकॉज द रेपुटेशन ऑफ गवर्नमेंट ऑफ इंडिया इज इन्वॉल्व वो whosoever may be the prime minister, but it is the reputation of government of India. It cannot happen that we can have a spurious drug from these generic companies. और सिर्फ दो ही है, तीसरा कोई नहीं है. There is no other. Baki rest all are branded generic. Nobody is making a generic compound other than these two companies. Rest everybody is making branded generic. वो उसकी मार्केटिंग नहीं करते. जैसे सिप्ला है, सिप्ला ब्रांडेड दवा भी बनाती है और उसी डिफरेंट नाम से वो जेनरिक दवा भी बनाती है, लेकिन उसमें ब्रांड नेम डिफरेंट होते हैं. So we should be aware of these things. I think we should try to help our patients to best of our efforts. And because cost is very, very significant. Our country is a poor country. Many times we get a very poor patient. Most of the time our patients are poor. So we should give this benefit. And whenever those drugs are not available, then definitely we should try to use the branded or branded generic. Thank you very much, sir.
Thank you, sir, for this wonderful talk and creating a lot of thunder and lightning on this most controversial topic of the decade.
Yeah,
Thank you.
Every physician, every patient, every citizen of the country has that in mind, whether generic or branded. But in my opinion, generic has its own place and brand has its own place. And either of them are not the competitor for the other. Why we are confusing, I don't know why government is confusing, authorities are confusing, agencies are confusing. Like in Indian society, in other segments, you see every strata. Same with pharmaceutical products, same with medications, same with the existence. Both have their own place, and we have to.
एक final word मैं और कहना चाहूँगा. Government of India, Supreme Court, and state governments, and all the companies, TPA companies, they are advocating prescription of generic drugs. But at the same time, we don't have that much generic drugs available in the market. So for that reason, we have to use sometimes, or most of the time, branded drugs. So we cannot live without one. They give these directions, but these directions are never adhered in totality. Thank you very much, sir.
Yeah. Give a big hand to Dr. A.K. Shachar, who made a very good presentation in a controversial and never-ending topic. So with that, the scientific session comes to an end for the day, but we have a very interesting session of vision for the next 5 years by governor-elect candidates. I hand over to Dr. Anuj Maheshwari sir and Dr. Muruganathan sir for the next session.
Thank you, sir. Thank you for such wonderful deliberations, and I request the chairpersons and the speakers to kindly collect their mementos from the left side of the stage. Now we have come to the session that is Vision for Next 5 Years by Governor-elect candidates. And the chairpersons are Dr. Anuj Maheshwari, Dr. A. Muruganathan, sir. Welcome, sir. And I invite Dr. Divya Saxena on stage. Vision ACP India chapter, where do you want to see India chapter in next 5 years?
Dear brothers and sisters, this time we have a unique program. Just like the election of the President of the United States, the presidential candidates will appear and then debate and argue what they can do for the country. And then the voters can, listen to them and then understand their viewpoints, policies, and then they will vote. Similar way, Anuj also has thought about this, and this year the Government of India, the Parliament has given 33% for the women. So even in the ACP, we thought we had already got 3 governors, male governors. So this time we are interested to get a lady governor, female governor. That is why we have got 2 candidates this year nominated by the ACP India chapter. One is Divya, other one is Swati. So we will request both of them to talk to you what they will do for ACP India chapter. I request all of you not to clap in between, because if you clap in between, it will misguide. So after the end of the talk, you can always clap. Right? With this small introduction, now I request the candidate Divya to present her views of what she is going to do for ACP India chapter. In a jovial way, she can say anything also. She can say after she becomes the governor, she will give everyone complimentary registration, complimentary suit, complimentary books, complimentary things also she can say. It's up to her. And after the talk, you give a round of applause, then we'll invite the next candidate. Okay, with this, over to you, Divya. You can be informal. There's no need to be very formal. What you want to do, say, if you can come into the state center also, you can speak. Whatever way you like, you can speak. Over to you, Divya.
Sure, sir. Thank you so much, sir, for the kind introduction. And a very good evening to all of you. My heartfelt thanks and gratitude to ACP Governor Dr. Anuj Maheshwari and Dr. Muruganathan, sir, for giving me this opportunity. And this is really my proud privilege to deliver my vision for ACP India chapter for next 5 years from this prestigious podium. So I have a strong urge of reciting this very famous shloka of our Hindi Upanishad. Udyoginam Purush Singham Upati Lakshmi Deven Devamiti Ka Purusha Vandati Devam Nihatya Kuru Paurushmatma Shaktaya Yatne Kriti Yadina Siddhyati Kotra Dosha. It means only the one who makes efforts wins. Cowards depends upon fate. One must throw away the concept of destiny and become industrious with the confidence and strength of a lion. And it's not one's fault if he fails in spite of efforts. And this is what we have learned from our dynamic leadership, Dr. Muruganathan and Dr. Anuj Maheshwari, over the years. So ACP, we all know that this is the biggest organization of physicians all over the world. And it is because it has pillars of strength like representing physicians with a unified voice, removing obstacles that interfere with patients' care, leading the charge to confront public health issues, driving the future of the medicines. And we all have to work on 5 core areas if we want a steady growth of American College of Physicians India chapter. And these are House of Delegates, that means a good team, members, that means a membership strength, to develop practice and clinical tools, to work for more and more researches and education, and then advocacy of the India chapter. The chapter promotes the art and science of medicine as well as betterment of the public health. The first and the foremost area we have to work for is to build a strong team. And once the team is built, we have to increase the bonding among all the teammates and to further strengthen the team as well. And for that, I think we have to identify and understand individuals' strength and then assigning the job accordingly to every team member. We know that nothing can be achieved with a good team. And taking along each and every team member is a difficult task and it's a challenge. For that, a good communication among all the members, good coordination is really necessary for the growth and the smooth functioning of any chapter. And the next core area is membership growth, and we know this is the topmost challenge to enhance the membership, which should be the first and foremost aim of every one of us. For that, we have to put our sincere efforts, joint efforts to make the chapter more popularized among the members from all over India, though it has become popular in the recent years like anything under the leadership of both the governors, but we have to work for it consistently. And definitely we should involve more and more members into the activities of the chapter, into the academic works, and into the research work also which are being done under the chapter, to invite more and more membership, and it will work as an incentive for them. And we also should organize continuous academic programs, training programs, workshops and hands-on training for all the members. There are some kind of learnings which are available on the at the institution levels only. So ACP should work towards collaborating with these academic institutions so that these skill trainings can be made available for every member, which are being done only at the institutional level. But we should also promote more and more involvement of every member into the research work, into the paper presentation, and into the academic activities. These are not only the areas of good organization. If we not work for the safety of our members, so which is equally important as the safety of patients. So we should work towards providing guidance on work-life balance, finance, and investment options for the members, including alternate income sources as well, legal advice, safe practice, so that all of us lead a happy and a safe professional family as well as social life. A central tie-up, considering the increasing litigations these days, a central tie-up can be done with an indemnity insurance company, so that the payments and the benefits all can be monitored centrally, and a good group discount can be taken from the indemnity insurance company, and all the members should encourage to get themselves covered so that they can do a safe practice. We should also, all of us are working some or other way for public. We are organizing camps, we are doing health checkup camps, we are organizing public awareness, education program, but all these should be done under the chapter headings so that the chapter can be very well popularized among the public as well, and our bonding can also be increased. The doctor-patient relationship is really going bad day by day in the recent years, so that we all should project ourselves if we are doing public services or these community health programs, and it should be done under ACP India chapter. Definitely this is our dream, and this should be every member's dream for the to uplift the chapter at international level. For that, more and more representations of members should be at the national and international level, maybe by paper publication, maybe by research work, or some other way. But we should all try to communicate every activity which is being done under the chapter to each and every member. For that, social media can be utilized in a better way. One more thing we all should pay attention towards, there is a need to make serious efforts to address the issue of the financial status and remuneration of the private practitioners. I also feel that ACP has the responsibility to see that they work with due respect and with the best, not the minimal working standards. For that, ACP Benevolent Fund can be started. We have all seen that during COVID era, we have lost so many young doctors. So this kind of fund can be beneficial for their family and their spouses. Maybe not the elderly physicians who are settled by the age, but for the young physicians. There are other organizations of physicians who are working for day-night for the academic upliftment of members, for the updating the members. We can integrate those organizations so that we can club our programs so that our population gains further attraction and momentum. So the integration is another important thing we all should look for. So finally, the period of next 5 years can be the golden period of ACP, which may be a reality with the concurrence, support, and participation of all of us. So we should follow these lines: Uttishtata, Jagrat, Prapya, Varani Bodat. Arise, awake, and don't stop till the goal is reached. Thank you so much for patient listening, and thank you for giving me this opportunity.
Please come here, please come. Now next I request Swati, please go. Please sit down. Swati, you can talk, but don't debate whatever she said, because it's no debate time. Actually, we wanted to do debate, but that will take long time. That's why this is first time we are doing. Please give a round of applause and welcome Swati. Yes, Swati.
Thank you very much, sir. Please accept my heartfelt gratitude for our, what can I say, a very, very strong legacy. Mentor, Dr. Muruganathan, sir, our dynamic governor, Dr. Anuj Maheshwari, sir, all the entire team ACP for giving me this opportunity to be here on this highly prestigious platform, speaking here for my vision on ACP India chapter. Internal medicine, basically we are all internists, and we should realize that what ACP does is focuses on the internists. We are the cornerstone of comprehensive health care. The internal medicine, we constitute the foundation of clinical care. We should realize that what we do is we apply scientific knowledge and clinical competence to the diagnosis along with empathy. The management is empathetic from adults, from well-being to integrate ailments. We are proficient in identifying the diagnosis of obscure medical afflictions. We see all the connections in the adult human body. We are giving a continued care for long-term disorders. We are treating patients with manifold and complex illnesses and promoting health care and disease prevention as well. So as internists, our association becomes very important, and that is what would be the basis of my vision. So who are we? We are guides. We are guiding in most simple, complex, diverse, multifaceted situations anywhere and everywhere. We are vital in diverse roles and settings.
We are critical thinkers who take up unpredictability and ambiguous settings as a challenge, and we care for our patients throughout the healthcare journey. Our expertise makes us vital to both patients and medical professionals. But we have problems, and these problems have to be addressed. What are problems? We have a lot of administrative work burden. Most of us would agree with that. There are inadequate physician payments many a time. There is lack of access to affordable health care. There are high drug prices. So we were just discussing the drugs which recently, and we have so many confusions coming up to us, and the internists have to face it the most. A word about ACP, because here I stand on behalf of the ACP. ACP is the largest medical specialty organization in the United States with members of more than 145 countries worldwide. ACP has 161,000 members, including internal medicine physicians, subspecialists who are related to the field, and also medical students. And the ACP targets and really aims, the mission and vision is to connect, support, inspire internists worldwide by meeting their unique needs through educational engagements and rich and mutually beneficial collaborations with other organizations across the globe on a variety of programs. And if we just look at the ACP advocacy, we realize that what we have to get, we should improve patient healthcare well-being, eliminate unnecessary administrative tasks. So that would be one of the important things that I would look into it. Then prioritization of physician well-being, championing the value of internal medicine physicians, committed to combating racial disparities, promoting diversity, equity, and inclusion. That would, these are the advocacies of the ACP. Before I go ahead, I would not stop from, and I would really applaud the 2023 Chapter Excellence Award, the gold winner being given to the ACP India chapter this time. This is a huge, highly prestigious award that has gone to the India chapter of ACP, and I congratulate our entire team ACP and our governors, our mentors for this ACP Chapter Excellence Award gold winner. The vision statement, I would focus on cultivating education and research with wellness. We need to influence change, but I would be focusing main on the culture of collaborative teamwork. All members need to align for the welfare and growth of the body. Together sounds more appropriate for collective thinking. I would like to make changes to influence adoption of change strategies for the future, keeping in mind not to compromise our existing value system. We need to strengthen our pillars of education, advocacy, research, organization, building, and its strengthening. We have got a strong legacy already going on, focusing on these things. I would like to further strengthen it and enhance its excellence. We need to build mechanisms of data collection and data sharing to understand our own population. Instead of copying from the West or trying to apply the Western knowledge, Western data to our settings, it is not possible. Our population is very unique, it is very distinct, and we need to focus more on our data. We need to advocate modern methods of functioning, integrating technology and artificial intelligence. We need to build strategies and include everyone from within with the organization and outside of it. We need to reach out to the underprivileged and the unrepresented. They need us the most. We need to give the young minds responsibilities and help them to take small steps forward, the leadership roles, and build them as leaders of the future. So I would say that the core values, what we need is the core values. Our decisions regarding the actions to be taken to attain the mission and the vision, the merit, maintaining the best quality standards to work ethically, compassion, respecting others' esteem with empathy, inclusion, welcoming and supporting diversity and inclusiveness, professionalism, equity and justice, impartial and unbiased culture, removing the hurdles which others may have. Professionalism, working with confidence, with principles as well. And then leadership should be acknowledged with endorsing the best professionalism, advocacy, and learning. So basically, I would have the vision of a teamwork where we should harmonize, have network, collaborate, support each other, work together with trust and partnership. That is what I would like to see ACP India chapter as after 5 years. Thank you very much, ACP India chapter. Thank you.
Please come, please come. I think more importantly, all of you must exercise your franchise. Last time when we conducted the election, I'm very sorry to say, only 20% of you have voted. So this time, you may vote for anybody, but please, exercise your franchise, vote for any one of them, no problem. So I think, Anuj, we can come to the center and, we must honor these two young, brave ladies who come forward to serve ACP. Whether whoever is winning, please involve the other person who loses in your team. So that way ACP unity will go and the strength will get better. So I request Anuj to give them a small, even though you come in the center, please. And all of you, please give a round of applause for both the young lady doctors who have come forward to serve ACP, and their ideas and visions are good. I request Anuj to give the bouquet to Divya first. Yes.
Alphabetically, she is before. Alphabetically, she is before, not is preferred.
Yeah. We are very careful in choosing words also. Once again, please give a round of applause for both the leaders, and we need more leaders. ACP needs more leaders, more involvement. And all of you, please exercise your franchise. Once the voting paper or ballot comes to you, many of you will not do it. I always say last year also the same experience. So this time, you can vote for anybody. Doesn't matter, but you should exercise your own franchise. Okay? This time we are very proud. The Indian ACP India chapter is going to give a lady governor. Whole country, even ACP headquarters requested us to support ACP this one. So,
thank you, Dr. Muruganathan, for being agreed to become the chair of nomination committee, and we were really in a very tough time when we had to choose the two faces, and we are very much grateful of these two female faces of our ACP India chapter who agreed to become for this most coveted job. We have been a different kind of the ACP culture, which is very much different from the rest of the organization, where we try to develop the leadership within among us. And it is not at all a kind of the competition, which is not at all a kind of the thing a person is saying something not acceptable to another one. But in fact, we try to promote each other with positive things, and we try to make the things better for the society by doing so. And I believe both of them have developed themselves for this leadership in last 2-3 years while working with the ACP Council. And I also learned a lot of things from both of these versatile females, those who has given me a lot of teaching, learning, and many of the things. In fact, Dr. Divya has been my senior from the same college, and Swati has worked very hard whenever I have given any task to her, may it be dilemma, may it be whatever. So both of them has worked very hard and excellent in their portfolio, whatever they have been given. Dr. Divya has taken up the women wing, Dr. Swati has taken up the academic wing. So both the females are having, and both the candidates of the governor-elect are having the extraordinary qualities, and you are free to choose any one of them, so that and whosoever will be winning, she will be working with me as a governor-elect for 1 year, and then the same one would succeed me the next for the next 4 years after 2025. So with this, a round of applause for both of them.
Thank you so much for this wonderful session. Now we have entered into the inaugural session. Good evening, ladies and gentlemen. This pleasant evening, I, Dr. Ankita Pandey, on behalf of the American College of Physicians, India chapter, welcome our august gathering today at the inaugural ceremony of 8th Annual Conference of American College of Physicians, India chapter. We will be starting our inaugural shortly. and being there with us in this remarkable scientific exploration.
Greetings, my friends and colleagues of the India ACP chapter. I am Omar Taimur Atiq. I'm the president of the American College.
So the stage is almost set for this awaited event, and I'm really blessed and honored to come all the way from Lucknow to be here at Bhubaneswar and to feel the warmth of the city. Thank you so much. We are indeed blessed with the presence of Dr. A.K. Azad Khan from Bangladesh as our chief guest. Sir is from Bangladesh. He is a national professor. Sir has received Independence Award from Bangladesh for social service. Sir is a DPhil from Oxford University, honoris causa from Basel, Switzerland. He is an honorary fellow from University College London. He has invented 5 ASA-based drugs. Sir has innumerable publications to his credit. I am delighted to invite you on stage, sir. Dr. A.K. Azad Khan, chief guest for the day. Please give him a big round of applause, ladies and gentlemen. I am equally elated to invite Dr. Anuj Maheshwari, Governor ACP India, on stage with us. A big round of applause. I can see the crowd. I want some round of applause for all the efforts made by these gentlemen for the success of this event. I invite Dr. Narsingh Verma, Secretary, ACP India. A big round of applause for sir. I request Dr. Anil K. Virmani, the scientific chairperson, to please join us on stage. And I invite Dr. Jayant Panda, the organizing chairperson, on the stage, sir. A big round of applause for our dignitaries. I invite Dr. A. Muruganathan, sir, the immediate past governor, on the stage. We have the ACP ambassador, Dr. Aliza I. Choi from United States. She is virtually connected to us. With the permission, may I start the session now? Okay. As is our Indian tradition, we will begin with invoking the Almighty and request our chief guest and other dignitaries on the stage to kindly flame the auspicious lamp. The tradition that transcends time and culture, uniting us in our shared journey for the light of knowledge. Please proceed for the lamp lighting ceremony. दीप ज्योति परब्रह्म दीपर ज्योतिर जनार्दन दीपो हरतु मे पापम संध्या दीप नमोस्तुते संध्या दीप नमोस्तुते. I will recite a small poem for this lamp lighting. एक दिया ऐसा भी हो एक दिया ऐसा भी हो जो भीतर तलक प्रकाश करे, एक दिया मुर्दा जीवन में फिर आकर कुछ श्वास भरे, एक दिया जो भेद मिटाए क्या तेरा क्या मेरा है, एक दिया जो याद दिलाए हर रात के बाद सवेरा है, एक दिया सीमा के रक्षक अपने वीर जवानों का, एक दिया मानवता रक्षक चंद बचे इंसानों का, एक दिया विश्वास दे उनको जिनकी हिम्मत टूट गई, एक दिया जो अंधकार का जड़ के साथ विनाश करे, एक दिया जो अंधकार का जड़ के साथ विनाश करे। और आइए इस दीपक की साक्षी में ये प्रण लें कि जीवन में हमें कितने भी अंधेरे दिखें, हम हमेशा उजालों की ओर ही अग्रसर होंगे। Thank you, gentlemen. Now is the time for floral welcome of our guest, and I am really elated and delighted to request Dr. Ajay Tiwari sir to present a bouquet of flowers to Dr. Azad Khan, the chief guest for the day. A big round of applause for this floral welcome. Thank you, sir. Now I request Dr. Sajid Ansari sir to please present a bouquet of flowers to our past governor, Dr. A. Muruganathan sir. Thank you, sir. It's a request to Dr. Swati Srivastav to please present a bouquet of flowers to our Governor ACP, Dr. Anuj Maheshwari, sir. The applause is quite low for the efforts these doctors have made. Thank you so much. I request Dr. Divya Saxena to present a bouquet of flowers to our scientific chairperson, Dr. Vermani. And I invite Dr. Anubha Srivastav to present a bouquet of flowers to our organizing chairperson, Dr. Jayant Panda, sir. And I request Dr. Ajay Tiwari sir to present a bouquet of flowers to our secretary, Dr. Narsingh Verma sir. Please give him a big round of applause, ladies and gentlemen. Thank you. Now, we will begin with a warm and welcoming address, and to extend this heartfelt welcome, I would like to invite Dr. Anuj Maheshwari, Governor, ACP India.
Thank you, Ankita. So, I welcome you all here. Before I say something on this dais, I must address my chief guest of the day, Dr. A.K. Azad Khan, who has graced this event coming from Bangladesh. Dr. Elisa Choi, who is joining us on virtual platform, and I'm really grateful of her. Despite not being able to travel India, she is still available online, still available virtually, and she has addressed us with a wonderful lecture, and now we are again waiting her for the oration. Dr. Muruganathan, our past governor, who has inspired me and who has given me all enlightening for doing everything whatever you are seeing in last 2-3 years. Dr. Narsingh Verma, who I often call as another soul of me. So he is always there. Whenever I do any endeavor, he always remains besides me and always supportive, and with his inspiration I can do anything whatever we have done in the past and we may be doing in the future. Dr. Virmani, as much as I can praise him and his endeavor, which is less. He is the senior most member of my council, but what I can say here that he has worked hardest. He is the person who kept on working not only this scientific program, he is full of the zeal and full of the enthusiasm to work for organization continuously. And initially also when I was in the process of electing the member of my council, he was ready to do any position, any job, and with any dedication. And when I took him, and he has really done the wonderful work, because the membership committee, he has been the chairman of the membership committee, and you know the membership drive is the most difficult for the ACP India chapter. That is the most difficult task. You think that this being a member of the ACP, you have to invest about 10,000 INR rupees every year. Or every year you have to renew the membership. Until unless our council is not deliverable, is not delivering to the members, probably it would be very difficult task. So making a people deliverable, making a people committed, and making a people answerable is very, very important task for any organization, but it becomes more important in the ACP when we need to renew the membership from the members. Because today anybody can become member, but this much of the crowd what you can see at this end of the day hours, in the wee hours of the day, where we are seeing this going to be 8:40, and this much of the people are sitting, they are committed people. They all are committed for the ACP and ACP's all ventures what we are doing. And because of what, probably we are getting this much of the success, our family is increasing, our endeavors are increasing, our programs are increasing. And we have finished 4 important studies on the ACP platform this year. Out of those 3, all the 4 has been presented today. And maybe we are going to have one more presentation, although that study is not being performed by the ACP. But I am really proud that people are feeling happy and feeling privileged if they are getting the platform of the ACP for presentation of their work. 83 research papers are being presented in this conference. But this is not really a small thing for a body which have been made only 10 years before, and having the 3,000 membership. I know there are the bodies in India which are 50-year-old but is still not reached to this much of the membership as the ACP has reached in so much of the small time. Dr. Muruganathan has a lot of credit of it also. Later on, we also tried. And in fact, when I could become governor, I could know, then I could only know how difficult it is to keep the membership drive and how difficult it is to sustain the membership. Making the people continue to become membership, how much difficult it is. So with these words, I request all of you, if you are not a member of ACP, join ACP, become member of ACP, you become the part of ACP and give your best to the ACP, and you will get back also to the same whatever you will be giving the ACP. So, and not only you will be become member of that, you will become the part of the 1,60,000 physicians family. ACP is a family of the 1,60,000 physicians across the world. And once you join ACP, you become the part of this family, and this family treats you always as a member of your family. So that's with this feeling, I invite all of you, those who are not member, and those who are member, they should contribute in our program. We have today found a new council of the ACP, which will work with me, my remaining tenure till 2025. And this new council is again full of enthusiasm and full of energy to do work. Multiple new things and new agendas which have been left by the previous council. Without taking much time, thank you very much for all your endeavors.
Thank you, sir. Now is the time for sharing the secretary report, and for this, with profound gratitude, I invite Dr. Narsingh Verma, Secretary, ACP India.
Thank you. Our chief guest, A.K. Azad Khan Sahab, Dr. Alisa Choi, who has joined from US, Governor Professor Anuj Maheshwari. I think his dynamism you can see everywhere. And Organizing Secretary, Dr. Panda, Scientific Chairman, Dr. Virmani, and past Governor, Dr. Muruganathan. India ACP has been very vibrant society. You can see almost every week the society has organized a program. Not only that, these programs varied from undergraduates to interns, residents, to early care physicians, to geriatric physicians, and also social programs. And not only that, we have been able, under the dynamic leadership of Professor Anuj Maheshwari, to give some Indian data by giving the research also, which is very rare phenomena in most of the societies. If the pace will continue and we will able to have more Indian data, that is the problem we are facing today, that we do not have our own guidelines. But in most of situations, we follow other guidelines. So ACP India chapter is doing very good job with cooperation of you all. As Governor has already said that we are having a lot of programs, but all this will continue only when you continue your membership, and those who are not members join membership immediately, and then you will be part of the global physician forum, and you will see that what change physician can offer. I will not take much time because already very late, and I will like to say thank you for you all. Thank you very much.
Thank you, sir. It's time to invite Dr. Anil K. Virmani, the scientific chairperson, to address the audience. Sir.
Dr. A.K. Azad Khan, the chief guest for today, our dynamic governor, Professor Anuj Maheshwari, past governor, Dr. Muruganathan, ACP India Secretary, Dr. Narsingh Verma, and my good friend and organizing secretary, Dr. Jayant Panda. And dear friends, seniors and colleagues, at the outset, I will express my gratitude to Dr. Anuj Maheshwari, the most dynamic governor I have ever seen, for giving me this huge responsibility of making the scientific program. Of course, I was not alone. He was guiding me throughout. Dr. Jayant Panda was with me. Dr. Behra was with me. The local organizing scientific team was with me. And all of us have put the scientific program in front of you. You have had the starters today, the main dishes tomorrow, and the dessert on Sunday. Please enjoy the academic feast. Thank you.
Thank you, sir. It's the time for presidential address, and we are delighted to have the virtual presence of Dr. Omar T. Atiq, President ACP. Over to you, sir.
Greetings, my friends and colleagues of the India ACP chapter. I am Omar Taimur Atiq. I'm the president of the American College of Physicians. I regret that I am unable to be with you in person at this time, missing the Lingaraj and the Rajarani temples in the temple city of India. My felicitations to the ACP India chapter for organizing its 8th annual meeting. Congratulations to Professor Anuj Maheshwari, Governor, India chapter, Professor Jayant Panda, organizing chair, and Dr. Anil Virmani, the scientific chair, for their vision, dedication, and remarkable efforts in bringing it all together. I wish to acknowledge the ACP India chapter as one of our stellar international chapters, which continues to build a professional home for internal medicine physicians in India. It arranges consistent educational programs each month, including the John Tucker Evergreen Award-winning case files for early career physicians, women's health sessions, and its latest physician well-being online lounge series called Soul Curry. These and other laudable activities earned the India chapter the 2022 ACP Gold Chapter Excellence Award, the highest award of its kind in ACP. And it is through joint collaborations and programming such as this one that the chapter continues expanding its reach in the region, bringing expert medical knowledge and networking opportunities to the internal medicine communities. The ACP is engaged with our global partners through chapters like the India chapter and many others. We have 161,000 members. We are stronger together, with 23,000 members in 169 countries around the world, and with 17 international chapters at the present time. There are a number of opportunities for all members of the ACP India chapter to get involved by contacting your chapter liaison and your chapter governor for a number of different activities that are available to you, and I would encourage you to please do so. Now, moving on, I would like to share a few words about the essence of our being as physicians. Most of us dreamed of answering the call of serving humanity, our fellow humans in distress, to profess our own humanity. We traveled a path to alleviate suffering with compassion and benevolence for our patients, patients who give us the exalted honor and high privilege of placing their life in our hands. They place us on a pedestal that belongs to a higher being, implicitly asking us to rise to that station. In doing so, they help us become better versions of ourselves. That is precisely why the physician-patient relationship is sacred, because it's transformational for both the patient and the physician. In a world partitioned by national boundaries, segregated by skin tone, separated by language and accents, riven by culture, and ripped up by faith traditions, navigating any of those barriers is overwhelming. The good news is that the American College of Physicians makes it easier for its members with resources and policies that help address those issues. We've all seen the ravages of illness and injury. It is particularly distressing to see preventable death and despair. Morbidity and mortality for some segments of our society is simply unacceptable. The profit motive in medicine has made adequate healthcare inaccessible to many. I remain in awe of your dedication and that of my fellow physicians around the world under these circumstances. Your perpetual struggle against all odds to provide efficient, evidence-based healthcare is impressive. You navigate barriers and obstacles with unmatched competence, commitment, and a sense of purpose. As a society, we must rededicate ourselves to saving lives with affordable, accessible, and efficient healthcare for all our patients, without exclusions or exceptions. Our collective human dignity requires nothing less. The American College of Physicians shall proudly be on your side as you strive to reach your individual and collective goals. As physicians, internal medicine physicians, specialists and subspecialists, we must work together to reach that aspirational end that is bigger than any of us. Never forgetting our intention to ease human mind of the vulnerability that illness and injury create, especially in the disadvantaged, by validating the indisputable human right to health. I hope that many, if not most of you, would join me for the internal medicine meeting of 2024 in Boston on April 18th through the 20th, where we would benefit by learning from world-class faculty in scientific and practice-related sessions. We can refresh our clinical skills with unmatched hands-on learning opportunities and make inspiring and lifelong connections. I'm indebted to you for allowing me the opportunity to share a few thoughts with you. My best wishes to all of you for a very successful conference. And with the latest Indian victory, Jai Hind. Thank you.
Thank you, sir, for this address. We are grateful to Dr. Alisa I. Choi, ACP Ambassador, for her virtual presence. I invite you for the inaugural address, ma'am.
Thank you so much, Dr. Pandey. I'm going to share my screen. And so, again, thank you to Governor Maheshwari, and also congratulations, Governor, and also congratulations to Dr. Vermani, Dr. Panda, and everybody who is involved in this truly remarkable and breathtaking conference that you have been putting on. And as I listened to Dr. Vermani allude to the activities for today as merely an appetizer, I must say that ACP India chapter's appetizer would be more than a full course for so many other ACP chapters. So for all of the attendees there, I am sure you're going to be getting a wonderful feast of educational, enriching opportunities over the course of the next 2 days. So let me formally introduce myself. My name is Alyssa Choi, and I am an internal medicine physician and an infectious disease specialist practicing in both general internal medicine and primary care medicine, but also seeing infectious diseases consults and practicing in HIV medicine. And I am deeply grateful to Governor Maheshwari and the ACP India chapter for the privilege to be able to speak to you all today. I'm going to open my welcoming remarks with some brief comments and look forward to speaking to you all a bit more in depth about some of the themes that I like to highlight a bit later this evening. I'm currently a regent on the ACP Board of Regents, which is the fiduciary board of ACP, and I'm also the immediate past chair of the Board of Governors of ACP, and also a former and immediate past governor of the Massachusetts chapter. So as I alluded to, I am absolutely amazed and speechless at the vast breadth and depth of the conference, and having had a chance to see the entirety of the program curriculum, I am absolutely in awe of everything that has been able to be pulled together for this 3-day conference. And again, my deepest and heartiest congratulations to Dr. Maheshwari, Dr. Panda, and Dr. Vermani on a wonderful program you have put together. Let me talk briefly about ACP's strategic priority themes. And I had the privilege to listen to Dr. Saxena and Dr. Shrivastava, and they were right on in terms of targeting what priorities can be for the ACP India chapter. What I'd like to share with you now is formally what ACP outlines as our strategic priorities. This infographic outlines the 4 different hubs of the wheel of ACP's priority themes. And I'll spotlight briefly the valued professional identity, the membership growth and engagement, and the innovation and strategic alignment. And my oration later this evening will focus much more on the diversity, equity, and inclusion. So the valued professional identity, a number of you have spoken already about the importance of us as internal medicine physicians. And one of the core strategic aims of ACP is to increase the enthusiasm and our pride about being an internal medicine physician, and also to amplify what is the value that we bring to healthcare, to our patients, and to society in general as internal medicine physicians. With that, the college has undertaken a substantial look at what we do, how we communicate what we do to the larger community. And with that, I wanted to emphasize one quick point, that while many of us, including myself, in the recent past even, would refer to ourselves as internists, I spoke a little bit about this as a Board of Governors talk I gave about a year ago. It turns out that the word internist creates a lot of confusion among people who are not in the medical field. So as part of increasing our professional identity, ACP is now favoring calling ourselves internal medicine physicians, so that there's no confusion about what an internist means, as some surveys of non-medical people had identified that some people think an internist is an intern, someone who is in training, and that's not completely true. So we at the college want to celebrate the essential critical role of internal medicine specialists and subspecialists. And for all of us, as we are still going into almost year 4 of the COVID-19 pandemic, that essential critical role could not have been made any more clear in the COVID-19 pandemic. Internal medicine physicians were at the crux and were the critical component to being able to take care of patients throughout this pandemic. Some ways that ACP is showcasing the leadership of our internal medicine physicians and our members is through our online website, noted here, and you can access it to stay up to date with what the college is doing. The previous comments had alluded to the importance of staying connected, and we do that in the college through social media. I'll share some of those direct platforms shortly. As I alluded to, using the term internal medicine physicians, and let's keep propagating that as our core identity. There's also some other ways, including in our email signatures. If we are an FACP, we can include a logo. If we are an MACP, including our logo or other links to the college in our email signature. And then look for ways that you yourself, as a proud internal medicine physician and also a proud member of ACP, can talk about your career and your journey and what it means to you to be an internal medicine physician. I'm so privileged to have the opportunity to speak about that myself to all of you later tonight. One of the other strategic priorities, as alluded to, is membership growth and engagement. And I heard Governor Maheshwari specifically talk about that, as well as others in the leadership of ACP India. I wanted to not redundantly repeat what President Omar Atiq said, but I wanted to amplify and congratulate ACP India for a truly remarkable accomplishment of attaining the gold level Chapter Excellence Award. That is not easy to do. As a governor myself of a chapter that was very fortunate to achieve that goal, I know firsthand how much work and effort it takes on behalf of the governor of a chapter to achieve gold, but also to all of you as chapter members and chapter leaders. And I wanted to applaud ACP India chapter. In a very brief tenure of time, you have become truly a standout chapter, not just among global chapters, but among the college itself. And I am just so proud of your chapter for your dynamic energy, your engagement, and for everything that you have been doing to promote internal medicine and the college. I'll talk a bit more about diversity, equity, inclusion later in my talk, so we'll only briefly speak about it in these welcoming remarks. But just to say that one of the core strategic goals of ACP is to achieve a culture both within the college and also in the House of Medicine at large, both nationally in the US as well as internationally, to create a just, equitable, and inclusive culture of belonging by promoting values of diversity, equity, and inclusion, and to do this intentionally. And finally, the fourth strategic priority aim is innovation and strategic alignment. And one thing that has become very clear is the role of AI and how it will interface with medicine and the practice of medicine. I won't speak at length about that, but just to reassure all in attendance that the college is very well aware and is certainly doing its part to better understand how innovative strategies like the use of AI will intersect with what we do in medicine, but other aspects of innovation and strategic alignment that have already been occurring in the college includes endeavors like the ACP app library, which enables you to find safe apps that you can actually recommend to your patients to combat misinformation and disinformation and promote a sense of self-empowerment among our patients, particularly those who have chronic diseases, so they themselves can also learn and become a helpful partner with you as their physician. Now, in my final slides, in my welcoming comments, I wanted to focus on the idea of ACP being your professional home. It is my professional home. I am a subspecialist and I'm a member of other societies proudly, but I could not be more proud to call ACP my professional home. And with that, I wanted to spotlight for those who are members in the audience, this will be familiar to you. For those who are not members of ACP India, I urge you to look at the ACP India chapter website here, where there's a wealth of information, both about what the India ACP chapter can offer for you, and also so many different ways that you can remain engaged in the chapter and to help continue to propel the activities of the chapter forward. I alluded to earlier the role of governor and just how involved that is in achieving a Chapter Excellence Award. And I also wanted to acknowledge just how remarkable it is, all that this chapter, your chapter, has accomplished in just a very short period of time, not even 10 full years at this point. I have not had the privilege yet to meet Dr. Gupta, the interim initial governor of the India ACP chapter, but I am so thrilled to be able to call Dr. Muruganathan and Dr. Maheshwari friends and colleagues, and I had the good fortune to see them in person at their India ACP chapter reception in April, and I very much look forward to returning the favor and being a bit of a host to both of them and to any of you who do come to Boston for the ACP meeting in April. But again, congratulations for everything that you've accomplished in going from a provisional status as a chapter to a full chapter. And also, I must acknowledge just how challenging it must have been for Dr. Muruganathan and Dr. Maheshwari, continuing now still to be a governor during such an uncertain and turbulent time as we continue to navigate through COVID-19 and the pandemic after effects. So ACP is not only the largest specialty organization within the United States, but it is the largest specialty organization globally. And in fact, despite our name, American College of Physicians, ACP is truly a global organization. And so the importance of our global chapter members, including your chapter, the India ACP chapter, I cannot stress enough just how vital a role all of you play in the work that ACP does and in our ability to promote our values of professionalism, care, and concern for our patients throughout the global House of Medicine. And while I had truly hoped to be able to join you in person this year, this is a screen capture of my ability to join you all virtually last November. And I will say that there aren't that many good things or positive silver linings that came out of COVID-19, but our facility and agility to connect with each other through virtual platforms has truly been one of them. And I do hope that the virtual connection I have shared with all of you today will very rapidly convert into an opportunity to meet and greet you personally in person sometime very soon. Now, this slide looks familiar if you were watching Dr. Atik's address. I wanted to spotlight that the ACP is, in fact, a global organization. And in fact, there are not just ACP India chapter, but 17 total international ACP chapters. And every single one of these international chapters are crucial to the mission and the success of the college. And thus, as members of one of our very important, very valued global chapters in the Indy ACP chapter, I urge each of you to find a way to contribute, to get involved, and become a part of ACP so that you too can feel that ACP has become your professional home. This slide may also look familiar from Dr. Atik, but I wanted to take this moment to particularly spotlight a new way for global engagement. There is, as of this year, a new award for ACP called the Inspirational Global Member Award. Now, I will give a caveat that ACP is very, very specific about no self-nominations for any of our awards, and that it is a confidential process. Thus, whoever is being nominated should not be self-nominating themselves, nor should they be aware that they are being nominated. But with that being said, I urge the leadership of ACP India chapter and any of you as members, if you wish to nominate a fellow colleague within the chapter, this ACP Inspirational Global Member Award may be an opportunity for you to spotlight a friend or a colleague, another member of the college that you feel deserves this type of recognition. And I wanted to show this slide. It may be familiar to Governor Maheshwari, who saw this at one of the virtual meetings and town halls, but we truly are a global community. And this particular screen capture is a number of different meetings and town halls I held. And in the center here was a specific virtual town hall when I was the Board of Governors chair that was directed at global chapter members. And so global governors, global chapter governors joined for that, as well as the other 4 screen captures from the various different regions of the domestic United States and Canada chapters. So, if I haven't convinced you yet to make ACP your professional home, please take this in mind. In the US right now, we are facing a substantial physician burnout epidemic, which you may or may not be experiencing as well in India, but there's clearly a corporatization of medicine, commodification of the sacred relationship that we as physicians share with our patients. It has become almost a consumer-driven product. That only fuels the fire of the potential for developing physician burnout. But I have made ACP my professional home, and I urge you to consider to do the same, because a way to create an antidote against the 3 C's of physician burnout, corporatization, commodification, consumerism, is the 3 C's that ACP can offer, which is collegiality, connection, and community. And through these 3 C's, you can build ACP bonds that will be everlasting. And this was, in fact, when I had a chance to join the ACP India chapter reception, not this past April, but in April of 2022. And I am so happy and so pleased that not only have I developed a professional home in ACP, but I truly feel that some of the bonds that I have built, certainly with Dr. Muruganathan and Dr. Maheshwari, and hopefully with some of you, will be everlasting bonds, and that we will be part of an ACP family. And with that, I wanted to just spotlight ways that you can continue to stay connected with ACP, and also ways that you can stay connected with me. Now, one last slide, which will again look familiar, but I cannot resist because I will actually be a quasi-host for the ACP IM meeting in 2024. While I am not the current governor, I certainly will be happy to take on hosting responsibilities to support our current Massachusetts governor. And I really hope to see many of you in person when you do come to Boston next April for the ACP meeting. And with that, thank you very much for the distinct and honor and privilege of being able to speak with all of you today. And I look forward to speaking to you a bit more later this evening.
Thank you, ma'am, for the encouraging and motivational address. I invite Dr. Anuj Maheshwari, Governor ACP India, for the election results.
Chairman, nomination committee wanted that I must declare the results of the elections here. So I'm just doing so. So today the term of the previous council has been over and new council has taken up with me for remaining part of my tenure. That would be around 2 years. So one vice president, all the council members has been elected unopposed. So that is again a very great thing for the ACP. One vice president, Dr. Jain Kumar Panda, has elected as a vice president. Advisory council member from North Zone, Dr. Mohammad Sajid Ansari. From East Zone, Amit Kumar De, he couldn't come today because of some personal family problem. From West Zone, Dr. Pratap Jethwani, he is also not well, so he couldn't make today. From South Zone, Dr. Vinayak Hiremat, if he is here, he can show himself. I think he is not here, but he was here before some time. From Central Zone, Dr. Abhishek Srivastav, Jabalpur. And the wonderful job which has been done by Dr. Amit Gupta now has been handed over to the lady who has been invented by him only, Dr. Preeti Singh Dohat. Where is he, if she is here? No. Okay. One representative for the women wing, Dr. Padma Shri Gulati, she also couldn't make to travel Bhubaneswar for her family reason. One council member for the advanced career physician. This is a new area of the working has been started in the ACP council, because a lot of things are to be done for the advanced career physicians, those who are in their 70s or 80s and they are not in touch with much of the updation. So ACP has decided to work for them also, to bring them in the streamline, those who are not in touch with the routine medicine, although they are practicing, but not with that of the enthusiasm as it should be. Dr. Suryakant is the person who will be looking after that segment. There is another segment we have rediscovered, that students and resident activities. Earlier it was merged with some zone persons, but now we have given the separate responsibilities, and Dr. Anchin Kalia from Jaipur has been elected for that. If she is here, she can introduce herself. No. Another thing, one more new post has been created for the international collaboration, and Dr. Amit Gupta has been on this post. So he is the person who is repeating himself in our new council also as a council member for the international collaboration. One student member, Mr. Abhinav Jha, who has been elected, and one resident member, Dr. Arnav Kalra. Arnav Kalra has been registered. If he has reached here, then he can stand up and introduce himself. No, I think he is not here in this crowd. So Dr. Arnav Kalra, who is from the Rishikesh AIIMS. So this finishes the elected, and nominated members shall be announced later. Nominated and special invited members shall be announced later. Thank you very much.
Thank you, sir. Now is the time for our chief guest to address the audience. Dr. A.K. Azad Khan, sir, a man with distinct vision, a person with illuminating ideas. Sir, please be here with us. I request you to kindly address the audience. A big round of applause, everyone. Thank you.
Namaste and salam. Please allow me first to thank Amit and Anuj Maheshwari for the kind invitation. Although I am not supposed to be the chief guest, but this chief guesthood has been thrust upon me. But the point is, I don't feel like guest. I feel like at my home. I cannot be a guest at home like that, you see. Historically, Orissa, Bengal and Bihar was one country. It is not by choice of ours, it has now become different country. So please allow me to feel at home, and I really feel at home. You see, this Congress, I am especially impressed by the holistic approach of medicine. You see, I am a gastroenterologist, and I know that modern day specialists have become more like technicians. The holistic medicine is almost disappearing. It's nice to see that it hasn't disappeared, you see. It reminds me of a famous saying by a famous person. You see the Osler Hall here. William Osler was a research professor of medicine at the University of Oxford. And he was a very wise man. I would not say clever, wise man. And this is about 120 years back. He said at that time that the success of a physician depends on whether he can keep the patient and his family amused long enough for the disease to run its natural course. Because at that time, we physicians had nothing in our hand that would influence the course of disease. We were practicing an art. Subsequently, it has started to become science. And to the extent, it has become more like a technical science. But the fact is, a successful physician is the one who can deliver the science in the form of an art. And this conference, I had a feeling that I have seen that. I will not make a long speech. I did not address the people with this address, Anuj, and those, the leaders of the American College of Physicians India chapter, and ladies and gentlemen, thank you again. Thank you for inviting me.
Thank you, sir. Blessings have always been the guiding force through the toughest storms in life, and we are always short of it. I invite Dr. A. Muruganathan, the immediate past governor, to please bless us with his words of wisdom. Sir.
The dynamic governor, my brother Anuj, today's chief guest, my brother, President of ACP, Dr. Omar, my sister Elisa Choi, my good brothers, Dr. Virmani, Dr. Narsingh Verma, Dr. Jain Pata, and my dear brothers and sisters. It gives me pleasure. Every year, Anuj makes me to bless people. I'm blessed to have that position, and I'm standing in the area of Lord Puri Jagannath. So I invoke his blessings, and I start my just felicitation for 3 minutes. At the outset, I must congratulate Anuj for his accomplishment, achievement, and awards. Please give a round of applause for the Anuj excellent doing. And a leader is very happy when the successful leader also succeeds him, also achieves and accomplices. It's a proud moment for me, especially. Then today's scientific feast and the organizing conference was excellent. So both Virmani and Jayant Panda deserves real appreciation, and God bless them. And of course, Secretary, as usual, he rocks. And now there is a saying, blessed are ones who always keep on learning, keep on working for others, who has got passion for service, who has got compassion, who has got empathy, sympathy, who always practices devotion, dedication, and determination, and who has got commitment, and who has got cordial relation. So those are the people who make the other people happy. So these are the people who are blessed. And knowledge is very, very, very important. In these conferences, you gain knowledge and skill. And also third important thing is attitude. So there is a saying, who is a knowledgeable person? What is knowledge? Whom to follow? There is a saying, he who knows not and knows not he knows not is a fool. Shun him. He who knows not and knows he knows not is simple. Teach him. He who knows and knows not he knows is asleep. Wake him. He who knows and knows and knows is wise. Follow him. So we got a lot of people who are really wise people. I see Bansi Sabu, I see Vasant Kumar, I see Jyotirmay Paul, who is talking to somebody else. Please listen, Jyotirmay Paul, and Sekhar Chakravarti and other leaders here. And then my friend Suranga from Sri Lanka also has come. So many knowledgeable persons have come to share the knowledge. So let me conclude. A bell is not a bell until you ring it. A song is not a song until you sing it. Love is not a love until you share it. ACP is not ACP unless you search and share, serve and care. Godspeed, good luck. Thank you.
Thank you, sir. Now is the time for felicitation, and I request Dr. Anuj Maheshwari, Governor ACP India, to kindly present a memento and a shawl to our chief guest, Dr. A.K. Azad Khan. Thank you, sir. Paying our debts of gratitude is the most profound task, and for the vote of thanks, I invite Dr. Jayant Panda, the organizing chairperson. Sir.
Most respected chief guest of the evening, Dr. A.K. Azad Khan, Governor of ACP India Chapter, Professor Anuj Maheshwari, past Governor Dr. A. Muruganathan, Scientific Chair Dr. Virmani, Secretary ACP Dr. Narsingh Burma, and the whole galaxy of personalities upstairs in the auditorium. First thing I'll tell that be rest assured the fact that I am the last speaker, because after vote of thanks none other are going to speak. And hats off to you all, your patience until 9 o'clock in the night, right from the morning you are here listening, interacting, discussing, socializing, and even in the function, you are there till late night. Now nobody wants to stay local. Everybody wants to go global. Suppose we are in medicine. Our common platform is medicine. And in medicine, what is the latest in the world? Everybody wants to know. So from an effort of uniting the physicians locally, at the state level, at the country level, and with an organization which works in the global level. And such a forum is American College of Physicians. Though we are not very old in forming the India chapter, the acceptance and the growth under the leadership of Dr. Muruganathan and Dr. Maheshwari is tremendous. We have seen ACP activities starting in India around 10 years back, and you know, API is almost 80 years for now. So it's the time for us to go beyond the country, beyond our people, and see the globe what is happening. That's why this response, and all want to know, share their own feelings with everyone. Year after year, we see very successful conferences. I see many known faces whom I meet in the ACP forum. So first of all, I thank all of you for your love, for your commitment, for your attendance, for sparing your valuable time and putting your energy in making the conference effort very successful. Then in my series of thanking, first I'll thank Lord Jagannath, because in Odisha we surrender everything to the Lord, we take the blessings and the work. And I'm sure by blessings of the God, nothing wrong can take place. I'll thank my good friend, Professor Anuj Maheshwari, who has chosen Bhubaneswar to be the venue. And there are many exotic places to house the 8th ACP, but his love for the soil of Odisha and soil of Lord Jagannath has brought all of you here. So I request all of you to give a big hand to the ACP India, which has taken a endeavor giving us a responsibility of hosting this conference. I thank our Governor, Professor Anuj Maheshwari, our Secretary, Professor Narsingh Burma, and the whole team, the ACP Council, advisors, for taking Odisha and Bhubaneswar a venue and giving us an opportunity to perform for this scientific feast. I salute my international faculties who are even difficulties of visa, rain, travel, participated in this program. Show also the doyens of the national medical science in the country. Dr. Shabu is here, Dr. Shashank Joshi, Dr. Mohan will be reaching tomorrow. As already mentioned, Dr. Bashant Kumar, Dr. Shattar, all who are here are a doyen in the field. I'm not taking name. Each and everyone at the national level, at the state level, have done their best preparing the topics innovatively assigned by Dr. A.K. Birmani. You will see the scientific program. Each session's name is innovative. Each topic is not a sponsored topic or a biased topic. It's an innovative topic every physician need to go through. So again, give a big hand to the scientific chair and his effort, because content of any program is the scientific, and he has done a marvelous job by presenting the scientific program, and much before the event he has presented, so a lot of additions, deletions and work on the program could take place. I'll thank my organizing committee. Many are here, all the chairmen of the subcommittees, the members, my postgraduates. They have worked for the event, and though the concept is not very old in Odisha, they have given their interest to make the program successful. My team, SCB Medical College Department of Medicine, starting from HOD, all the members are here, and they have done a great job by supporting the event. Besides, the pharmaceuticals who have supported us in spite of all uncertainties and NMC guidelines, the hotel, Taj, Vivanta and the team, the media persons, event manager, concept, and the RX who are with us this evening have given their best to make this conference a big success. One day is over. You have 1.5 days more. You'll see more science, more socialization, more fellowship, and I'm sure you will all enjoy this proceeding for the time to come. Finally, I wish in this endeavor of going global with the ACP as forum which all of you have chosen, we can take the organization high and we all also can go high, achieving our aim, updating ourselves, ultimately giving the benefit of the science to a needy patient in the distress. Thanking you all again, and with this praying near Lord Jagannath that again and again the event will come to Odisha and we will have the opportunity of serving you all. Thank you all.
Thank you so much, sir. Now let us proudly rise for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you so much. Thank you for being a part of this illuminating session, and may our time together be marked by meaningful discoveries.
Now this is the time for the last program of the day, that is the oration by Professor Elisa Choi. She will be doing this virtually. So before I invite her on the screen, I must thank her for this oration, and we have already introduced her. She is not only the past chair of Board of Governors of American College of Physicians, but also a very good friend of the India chapter. So with these words, we request Dr. Elisa Choi to kindly start your oration. And also I would like to say that the felicitation of the oration I shall be doing once I will be joining her in the Board of Governors meeting Orlando. So over to Dr. Elisa Choi.
My thoughts are really my own and will, unless I actually reference that. Is And what you see here is the DEI circled as part of the 4 prongs of ACP's priority themes. So I won't go through the other themes, but we'll be focusing my remarks right now on the DEI component. And what exactly is this acronym JEDI that I alluded to? JEDI is justice, and if you jump down to the bottom of this slide, there's a dictionary definition that means it is treatment of all members of society in a fair way with regard to any specific issue, and it also includes equitable distribution of resources and participation in decision making. Now, diversity is defined here. Equity is about fairness. Inclusion means you are actually engaging in the diversity. So think about inclusion as the action step of the diversity, which is the representation. And ACP, in this link here on YouTube, actually has a video that talks a bit about our commitment to being a diverse, equitable, inclusive, and anti-racist organization. And I did want to include this slide about anti-racism. I know it may be different for many of our global chapters, but certainly in the United States, I wanted to set this as a set of definitions so people can understand what we mean. Racism is really a belief that there are some fixed inherent differences among different human racial groups, and that it enables one group to have dominance over another, or that it can be viewed as superior rather than inferior to other groups. But anti-racism is actually a doctrine that rejects that any particular racial group is superior over any other. And so in order to really achieve equity, regardless of what we're trying to do it with, one has to have a bit of an anti-racist ideology and philosophy, because if you are not actively anti-racist, then one is buying into a belief, whether or not one feels they're racist, you're buying into a belief that some group is superior than others. And that is the exact opposite of what equity is trying to achieve. Now, I talked about in my title, how to be a JEDI advocate. And I know some of the speakers earlier had also spoken about the importance of the ACP India chapter to do some advocacy. So what actually is advocacy? Well, it's actually the process of supporting any particular cause, or to support or argue in favor of something, to plead in favor of something. And if you are interested in word origins like I am, it really breaks down into a meaning of to call. So for us as physicians, as advocates, as ACP members who are working on behalf of our patients, we need to expand the scope of our profession to beyond the examining room or the hospital and advocate for our patients, for our community, for our profession. And that is why it's so important that advocacy is a component of everything that we do. In the next series of slides that were provided to me courtesy of Joanne I, who is one of our senior staff persons in ACP, I'll briefly highlight ACP's own DEI journey and won't go into too much detail, but suffice to say that this is actually a fairly recent process that was undertaken by ACP as well. And it initially started in the fall of 2016, where there was policy that was developed to address the gender pay gap, specifically that are faced by women within the field of medicine. Soon afterwards, then in the spring of 2017, there was a diversity and inclusion task force that was initially formed. And one of its chief goals was to consider forming a standing committee about DEI. And so a year after that, there was, in fact, a standing subcommittee, the Diversity and Inclusion Subcommittee, which started to begin some foundational work. And then most recently, as of July of 2020, there was actually a Diversity, Equity, and Inclusion Standing Committee that directly reports to the ACP Fiduciary Board, which is the Board of Regents, and it is composed of between 10 to 16 members. So some ACP resources that I wanted to make sure all of you are familiar with is that as recently as 2019, there was a new updated diversity, equity, and inclusion policy that ACP drafted. And the print is small here. The slide is not for you to read it over, but I did give you the guide, the website guide that you can go to link to the exact policy. But this was a crucial foundational piece of work in ACP's own journey in being a DEI supporting organization, to have our own policy that reflects those actions. And here is, in fact, that landing page when you go to this website, acponline.org/DEI, and please avail yourself of this opportunity and look through all of the various resources, including the video I alluded to earlier, but so many other resources, including in the gender equity field. So ACP has really built on this great foundation, doing a number of other things, including co-sponsoring grant programs, establishing an anti-harassment policy and a reporting process, and also surveying current and past leaders of the college to help assess what ACP's DEI needs are. And importantly, and that includes ACP India chapter, there is national support to establish local DEI and women in medicine committees. And I know and applaud the ACP India chapter for various gender equity and women's health issues that have emerged. And that is all part of ACP's DEI journey. It is not just about what ACP National does, but also what is happening at the chapter level. So here's another slide courtesy of Joanne I, which summarizes ACP's DEI initiatives and what has been accomplished now. And rather than read over every single bullet point, I did want to focus on a couple things. Developing speaker diversity and inclusion principles are very important, and ACP India chapter is doing a remarkable job with that too. Also, focusing on DEI programming both at annual meetings and also in webinar series. And again, I wanted to applaud your chapter for many of these efforts. And also intentionally revising the descriptions of awards and MACP descriptions so that there won't be biased language that will actually make people think differently about who they would want to nominate. And then on the policy and advocacy front, this is also a very full slide, but I'll just highlight and emphasize that we issued a formal commitment as ACP that we are, in fact, an anti-racist, diverse, equitable, and inclusive organization. And there was, in fact, a vision for healthcare that ACP put out. I'll talk about that in a bit later on in the talk. And I will just introduce the idea right now, though, that being a DEI-focused organization is not just about the workforce. It affects what we do in the health of our patients and why it's important to be equitable in that. Some recent ACP activities, again, briefly summarizing from information that was kindly provided by Joanne I. There is an Equity Matters program, which is a multi-organizational coordination and consortium and collaboration. And there's also member demographic questions. So as any of you who may be new members, if you recall that you may have been asked about race, ethnicity, gender, etc., please know none of this is mandatory, but it enables the college to be able to better understand who are our grassroots members so that we can then be sure that our membership is being adequately reflected in the leadership of the college. And other activities I'll briefly highlight. There is a DEI grant program that is co-sponsored by ACP. There's also something called a Women's Wellness Through Equity and Leadership program, and it's a sponsored program from multiple different organizations, as well as a council of subspecialty societies that participates in a lot of these DEI activities. And let me point to the culture of ACP. And I saw that this was mentioned by the two governor-elect candidates, and I wanted to applaud their acknowledgement of this, but our ACP national culture is driven by these various components of what we cultivate at ACP. And it is important that we build in a respect and understanding and empathy, and that, in my opinion, is part of what is embodied in DEI. ACP has also committed staff as a DEI initiative, and they have a focused goal, these are outlined here, for how they as staff members can help ACP achieve diversity, equity, and inclusion is part of our stated goal. And you can see here the 2024 stated desired end goal for the college is to achieve a culture of inclusivity, equitable, just, and anti-racist culture in ACP. So looking ahead, ACP plans to keep DEI at the forefront as part of everything we do. And this is an important point I want to emphasize. DEI will be embedded in everything the college does. It is not some separate silo that's happening concurrently while everything else is happening, but every activity, whether it's chapter meetings, national meetings, policy and advocacy making, anything and everything the college does will in fact have embedded in it principles of DEI, and that includes trainings on implicit bias, that includes developing leadership programs that will really try to make a more equitable leadership representation. And the ACP is committed to increasing diversity across the college, and particularly for you all as members of the ACP India chapter, that includes supporting and really amplifying the commitments and the contributions you all can make as global chapter members. As I alluded to in my welcoming remarks, ACP is an international organization, and we want better representation from all of you as well. And if you look at the stated ACP core values, you can actually see aspects of DEI are embedded right in our core values. And so we have made a commitment as ACP to be an anti-racist DEI organization. I will add, though, that there has been a journey that ACP has taken, and it's not a perfect one. And what you note here, the print is very small, but all you really need to take away is that even as ACP has made its recent journey towards being diverse, equitable, and inclusive, it is acknowledging that it wasn't until after 1947, which is not that long ago, that there was any record of activity that involved a Black member. So that is something that we need to do better, and ACP has committed to make sure that we do, in fact, do better. And one way that we do that, so when Governor Maheshwari comes to these Board of Governors meeting, he is actually representing your chapter, and his predecessor, former Governor Dr. Muruganathan, similarly, when he comes to Board of Governors meeting, represents your membership. But what did our Board of Governors used to look like? This is a slide courtesy of our ACP CEO, Dr. Moyer. So even though the picture is black and white, I hope in the audience you can appreciate just how white the Board of Governors was and how male the Board of Governors was. And that's not that far long ago. That was just in 1982. So part of the membership demographics that are being requested, as I alluded to, it enables us now to do better, to understand who are the grassroots rank and file members and how are we doing representing them in our leadership, like, for example, at the Board of Governors. And there's numerous different characteristics, and one of this includes IMG status and also certainly your country of origin, as well as your global member status. And the Board of Governors are fairly well represented in terms of these things, the age, the location of the governors. I will say, although gender is fairly well represented, we are still not as equitably represented as women members of the Board of Governors relative to our membership. And there are underrepresentation among the Board of Governors in several of these areas, including international medical graduates, and also in some of the subspecialties. But we're making some strides, and in the next series of slides, I'll go very briefly through to show you who currently are leaders in ACP and why there's been a bit of a sea change just in time, in my opinion, to enable us to be a more just, equitable, diverse, and inclusive organization. So let's first start off with our CEO. As Governor Maheshwari and past Governor Muruganathan know, this is Dr. Darylyn Moyer. She becomes the first woman ever to be CEO and EVP of ACP. took an awfully long time for that to happen. So this has been a mission of hers personally. And we also have a chief strategy officer, Miss Adrienne White-Faines. And while she works on general strategy altogether, she is also someone who embodies DEI in everything she does. And then there were a number of firsts. Susan Thompson-Hingle was the inaugural leader of the Diversity and Equity and Inclusion Task Force and Subcommittee. Ana Maria Lopez, the past president of the college, was, I believe, the first Latina woman to be a president. And then this was a 2-for-1 in the year of 2020 to 2021. For one of the few times in ACP history, there was both a woman president and a woman chair of the Board of Regents. And both Dr. Fincher, Dr. Ganser were wonderfully proactive in making sure that there was DEI moving forward for the college. And let me show you a few other firsts. So Dr. Janet Jokala, who is a fellow infectious diseases physician, she became the first woman treasurer of the college ever, most recently. And then you also have Dr. Sue Bornstein, immediate past chair of the Board of Regents, and current chair, Dr. Barrett, also women. And then we do have, now I focused a lot on women, but I will say, and much credit to ACP India's current governor, Dr. Maheshwari, and past governor, Dr. Muruganathan, for having the vision to be what I call a he for she, a male who wants to amplify his female colleagues. And in doing so, they have put up a slate of governor-elect candidates who are both women. So thank you to both of you for being such wonderfully supportive he for she. So these slides show men in ACP leadership, including who you heard from just a while ago, Dr. Atik. So these men are all he for she. They have also taken on the mantle of promoting DEI and gender equity as everything in what they do. And in particular, I'll speak in a bit about my past role as past governor of Massachusetts, but my predecessor was George Abraham, and I wouldn't have become governor without his support. Now, this slide gives me personal pride because what you see here is my immediate predecessor as BOG chair, Dr. Rebecca Andrews, my successor and current BOG chair and dear friend Priya Radhakrishnan, and soon to be chair, Dr. Angela Johnson. As far as I'm aware, this is the very first time in ACP history that there have been 4 women in a row that have become chair of the Board of Governors. So as I'll speak about later, we will do our utmost to ensure this won't be the last time this ever happens. And I was so privileged to be able to work with Dr. Heather Brislin when I was a chair of the Board of Governors last year. She became the first parliamentarian of the Board of Governors who was a woman ever in the history of the college. So the tide is turning, but we still have a lot of work to do. And I just wanted to acknowledge 2 other he for she, past chair of the Board of Regents, Dr. Thomas Cooney, and past treasurer, Dr. Gregory Kane. Both of these gentlemen have been marvelous he for she and are always trying to amplify and really promote DEI principles. So while this picture hasn't changed, in terms of what 1982 looked like as a Board of Governors. As you saw from the preceding series of slides, there is change. It has been happening and it will continue to happen as ACP continues to anchor on DEI as one of its core principles. Now, I wanted to share some personal slides over the course of the next few slides, talking a little bit about Massachusetts. When I was a governor, I helped to start an actual committee focused on justice, equity, diversity, and inclusion for the Massachusetts chapter. Just recently, there was a co-chair change. So formerly, Dr. Christopher Estervern was co-chair. He will now be co-chairing, he will be stepping down as co-chair, and Dr. Suzanne Martin will be co-chairing with Dr. Carol Vincent. I will say, though, that this committee has been marvelous. It was grassroots, solicited completely through not appointment. So it was all volunteer. And this committee is what well represented racially and ethnically, gender balanced, and also representing LGBTQ physicians. So I'm very, very proud of this committee, and they're doing some great work. And one of the very first things that they did for the Massachusetts chapter was to actually revamp our own chapter JEDI policy, mirroring what was being done in national. We had quite an outdated DEI policy before this committee undertook the codification of an actual updated policy. And you don't need to read this in detail, but just know that that was one of the very first steps that it did. And then one of the second steps that this committee did was to actually survey our grassroots members. What do they want our committee to do? And in that, the survey results found that members wanted to understand, what is DEI? What does that mean? And how can we be better at DEI? And one of the things that came up was they wanted an educational program. So the Massachusetts Chapter JEDI Committee actually sponsored virtual book groups to talk about a book that's written by Professor Ibram X. Kendi, who is currently at Boston University. He talks about, in his book, how to be an anti-racist. And we had a very successful book group, 2 separate occasions. And it was really honest conversation, but it was in a safe environment where people could very much express their questions and feel comfortable doing so. Other ways that I personally have been able to be involved in DEI work, I am a co-producer and a guest in the past, but current co-host of a podcast sponsored by ACP called The Day Shift. Obviously a play on words, DEI, but Day Shift, and it has some great podcast episodes that focus on a lot of different aspects of diversity, equity, and inclusion. I alluded to Dr. Carol Vincent before. She is now the co-chair of this committee of our chapter, but she and I had a wonderful podcast discussion talking about anti-racism in healthcare education. And our JEDI committee also had an incredibly moving panel where members of our chapter who identified as members of the LGBTQIA community spoke about their personal experiences. And it is one of the most impactful webinars that I have ever attended. I will also say on a personal note, back in March of 2021, when in the US there were shootings that happened to Asian women in Atlanta, some of whom were of the same ethnicity and background as myself, I was shocked and really, in a way, felt threatened like I'd never been threatened before, because it was a clearly racially motivated shooting. So I took it upon myself to create a statement that was endorsed then by my chapter's council, and then collaborated with various other chapters within the US to make a statement against anti-Asian racism, violence, and bias. And we also collaborated with other chapters to have a town hall where we talked about some of the anti-Asian racism and discrimination. And if it wasn't known and obvious to you all in the audience, this has emerged. Anti-Asian racism has emerged because of COVID-19. I'll talk a bit about that in the next few slides. But other ways, and I believe your chapter is already doing it in that you have awards for your chapter that acknowledges women's health achievements. So when I was a governor, we created 2 awards that distinctly recognized work in diversity, equity, and inclusion, and also for achievements in advancing the careers of women in medicine. So if you have other areas in your chapter you want to amplify in the DEI space, consider creating an award that directly recognizes those efforts. And then I was very fortunate that National ACP granted me some small seed money to start off an effort in our chapter called the Leadership Development for Women in Medicine Committee. And we had several virtual meetings and really focused on understanding, why aren't there more women leaders in medicine? Why are there fewer women in medicine leaders than men, and what is behind that? And it is still an ongoing effort. We were fortunate that we had Dr. Darylyn Moyer join us for one of those sessions. And I share this collage for a few reasons. First off, it is September, and in the US right now, we are celebrating Women in Medicine Month. I shared this collage in my last year as governor to show that there has been a surge of women leaders in our chapter. I will say that I became the first woman governor ever in the history of the Massachusetts chapter. So from that standpoint, the India ACP chapter is doing superbly. You're a chapter that has not yet even been around 10 years, and you're already moving the needle forward. Meanwhile, Massachusetts was a chapter for nearly 100 years before a woman became governor. So congratulations on all of your progressive efforts. But I won't take credit for these women emerging as leaders, but what I will say is, and I'll paraphrase something that our own CEO, Dr. Darylyn Moyer, says all the time, you can't be what you can't see. So if women don't see other women in leadership, they may feel like that is not a path that is open to them. So if nothing else, the only thing I'll take credit for is that I was visible as a chapter leader. And hopefully the same will be true for your chapter, and not just for gender. If there are people from parts of India that are not represented, amplify them, support them to get into leadership so others from their regions or others from their particular geographies will feel like there is a path for them to merge in leadership. I'll just go through a few slides here to highlight ACP's efforts in gender equity. There is a position paper that ACP put out about achieving gender equity in compensation and career advancement. And here are the links for that particular paper. Here is a landing page, and for those in the ACP India chapter, if you weren't aware, there's actually a whole section in the ACP website where there is a Women in Medicine section. I urge you to check it out. It's full of resources and also great starting material for any gender equity efforts that you want to undertake in ACP India chapter. And I also wanted to share this particularly with this group because I was part of the founding steering committee of an affinity group for the Pan-Asian community. And I invite all of you as members of the ACP India chapter to get involved. We deliberately wanted to make this a global Asian affinity group. And so please reach out if you have interest in some of the activities that we'll be undertaking. But I will say that this group was really such a source of support. I alluded to earlier some anti-Asian violence and racism directed at us in the past several years. When COVID first hit 3 years ago, we started to hear, as many of you I'm sure also did, that there were some awful, brutal, violent attacks happening against Asians who were being accused of being carriers of COVID-19. And basically, I will, without getting too political, say that the former administration of the United States government unfortunately did not help that situation and created a very inflammatory set of language that also created a lot of anti-Asian hate and racism. So our Pan-Asian Affinity Group put together this piece as part of our advocacy efforts to really make people aware that this is not acceptable. We also put on a webinar that talked about bias and microaggressions that were directed against our physicians. And then I'm going to pivot a little bit to my own personal advocacy. This is me standing in front of a group in front of the Massachusetts State House, where we had a press conference. This was literally several days right before, in March of 2020, we completely shut down. We had started to hear about reports in Asia, reports in Europe, reports in other parts of the US, where there were Asians who were being attacked and being accused of causing COVID-19. So we put together a group of us that held a press conference and repudiated and denounced all of that Asian racism. So other advocacy that I did, and hopefully can be a source of inspiration for all of you to take action and be advocates. As I alluded to, I'm currently a co-producer and a co-host of this Day Shift podcast. But before I joined, I actually was an invited guest where I talked about topics of Asian women physicians and leadership, and talked a lot about the term the model minority myth. In the US, the model minority myth means that if you're of Asian background, you're a model and you're being a minority the correct way. I won't go into a lot of detail because that is an entire talk in and of itself, but suffice to say that that is a false narrative and it has hurt more than helped our Asian community in the US. I also talk about what we call the glass ceiling for women and the bamboo ceiling, which is what Asians often face in trying to advance professionally in leadership. Some more personal advocacy that I became involved with. I was invited to give a talk at the Joslin Diabetes Center and Harvard Medical School affiliate to talk about anti-Asian racism and COVID-19. And I titled my talk Pandemics in Parallel. And here is me several years back. I will say that this Asian data bill has finally, in several years now, passed, but this was me at the State House along with Representative Taki Chan and George King, who is Chief Scientific Officer of Joslin Diabetes, talking about the importance of having Asian data, specific Asian data for health disparities. Now, I'm going to pivot because although my talk was about being a Jedi advocate, I'm going to make the connection for all of you that this is important because ultimately it affects our patients and health equity. So the CDC has prioritized health equity as a goal to achieve. And ACP has also put out position papers to address social determinants of health. And broadly speaking, social determinants of health are social factors, non-medical factors that might contribute to poorer and inequitable health outcomes. And that may include, in fact, things like where we work, where we live, what gender we are. So all of those can affect inequitable health outcomes. And so let me give you some definitions. Health disparities, they're differences in health outcomes, and health equity is when everyone has the chance to be as healthy as possible. So I hope we can all agree we want to get rid of health disparities and achieve health equity for our patients. And here are some more detailed definitions, which I won't read through, but these are from the World Health Organization. However, I wanted to spotlight my underlined portions here, which is that those who experience health inequities do so because of a lack of political, social, or economic power. So when you think about it that way, becoming a Jedi organization, becoming a Jedi chapter, being a Jedi advocate is to help equalize the inequities. And it doesn't have to be about race or ethnicity or even gender. It can be about economics. Who is more economically successful than others? That will determine who often has better health access and outcomes. And here's a formal definition of social determinants of health. Again, I won't read it over, but just note that race and discrimination can actually be a social determinant of health, and particularly germane to what we may be talking about in our chapter discussion here at ACP India, gender is a social determinant of health, and gender inequity can be a social determinant of health leading to worse outcomes in health, particularly for women patients. So some of the aspects that women may face inequitably, not just in India, but in much of the world, is lack of access to appropriate reproductive care, some worse outcomes in certain cancers, some worse outcomes in less accurate diagnoses or access to care in cardiovascular disease, like in myocardial infarction or other cardiac care. Certainly, intimate partner violence and domestic violence disproportionately affects women than men. And also there's emerging data to indicate that women who have HIV and AIDS will have worse outcomes for multiple different reasons. ACP has addressed the disparities and discrimination in healthcare through a position paper, extremely comprehensive. I won't go through the details, but here's the links, and I urge all of you to access that. And then in my last series of slides before I conclude, I wanted to really hit home the takeaway message that being a Jedi organization, being an advocate for justice, equity, diversity, and inclusion is helping patients. I show you here my medical assistant who happens to share the same ethnic background as I do, and here's my Harvard medical student who worked with me. And both of them have enabled patients who have a similar background of being from Korean ethnicity to feel comfortable, to be able to share more honestly, more candidly what their health concerns are. So to be able to represent our patients by being better Jedi advocates can enable them to feel a sense of trust with who they get their care from. This slide is really here to remind me to mention that being a Jedi advocate and how it affects patient care can even affect things like, for example, how rashes and skin conditions might be diagnosed. People who have darker skin complexions may have disproportionate delay in diagnoses because many of the textbooks, certainly in the United States, talk about skin conditions on fair skin or much fairer complexion. So those who have different skin tones will have a disadvantage in being diagnosed. And then ACP has continued its linkage of Jedi advocacy and health equity by putting out position papers supporting our Indigenous and Native American communities, and also position papers supporting the health of our lesbian, gay, bisexual, and transgender patients. Now, this is a little bit of a facetious slide, but I'm assuming that all of us, myself and all of you in the audience as members of ACP India, would view yourselves as being Asian. So we have a superpower. We're invisible. Take a quick look at this data. and you will see that there's no Asians anywhere. So we unfortunately have become invisible. That is our superpower, and it is not a superpower we want it when it comes to medical data. And in fact, unfortunately, I couldn't resist. This was in October. I noticed that there was a tweet about COVID-19 data, and if you notice, there's no data on Asians. And so I couldn't resist, and I had to communicate out into the Twitter universe that there's absolutely no excuse at this point in time in 2022 to omit any racial or ethnic group. So not only is it important that we are seen so we know how we can achieve professionally, we need to be seen so that we are counted in our healthcare. And I put this up because there's a wonderful early career physician from our Massachusetts chapter, Dr. Shreya Trivedi. And for those of you who do podcasts, she is one of the leaders of the Core IM podcast. She and I were having a conversation, and I mentioned to her when she used the word minority, I told her I've tried to stop using that word because she's of South Asian background. I'm of East Asian background. What I said to her is, people who look like the two of us are actually the majority in the world. And I hope that all of you in the India chapter can appreciate that. So in the US, we're treated as a minority, but we're actually the global majority in the entire world. So in my closing comments here, I'll just leave you with some infographics. So this is often something that is shown to help differentiate what is equity versus what is equality. Equal treatment is everyone gets the same height crate, but then it's not equitable because this poor person here can't see anything. So equity is giving everyone the same view. And then you can also get rid of all of the crates and you will just have complete equity there. But you know, when I thought about it, I always thought having a chain link fence blocking people didn't really feel like justice. So here's an updated infographic. And what you can see is the difference between what reality is, which is true, unfortunately. Some people aren't even starting at ground level, going all the way to equity. But now we're liberated. We belong. There's nothing holding us back, and we all have a view of the playing field. So how can you be a force for Jedi? First, get involved with your ACP chapter. Please don't let your attendance today be the only thing or the last thing you do. You are blessed as a chapter with having wonderful, dynamic, engaged, energetic leaders in former Governor Dr. Muruganathan and current Governor Dr. Anuj Maheshwari. And from what I heard in the talks, both of the governor-elects will be fabulous governors as well. So please get involved with your chapter, join a committee, and consider drafting a resolution, and Dr. Maheshwari can help you with that. And I invite you as global chapter members to start a grassroots resolution. It doesn't have to be US-based, and please do make that effort because Dr. Maheshwari and his successor can represent you with those resolutions. And then finally, I'll say this. If you're a first for anything, you can be a force for Jedi by making sure you are not the last. And that goes for anything. I'm a first woman governor. I made sure that there was never going to be me being only the first and last. And similarly, champion those who are unseen, who have no voice, who've never been heard. When you blaze a trail, clear the path for those who come after you. And remember that you are a voice, not just for your profession and your colleagues, but for all your patients when you are a force for Jedi for health equity. And what you can do is to be a Jedi expert. I will leave you with this quote from Margaret Mead, and just note that this was the viral picture that went viral on social media. This is my shoulder here, so I didn't really get into the picture, but this was just one way that we all gave our voice to the effort against anti-Asian discrimination, and each of you can do something similar. And I wanted to give my most sincere gratitude to these two Jedi champions. You are blessed as a chapter to have Dr. Muruganathan and Dr. Maheshwari, who they are absolutely Jedi champions, and certainly he for she's. And it was so lovely to see them. And my remaining last 3 slides are hopefully going to leave you with an energy to achieve on your own in accomplishing Jedi. This is Reverend Martin Luther King. He is certainly well known within the United States, and he had a very compelling quote about injustice and health and how those two are shocking when they're present together. And then I also leave you with a quote. This is Patsy Takamoto Mink. She became the first Asian American woman ever to be elected to U.S. Congress. And in the U.S., we have something called a Title IX amendment, which prohibits discrimination based on gender in any organization or educational institution that receives federal funding. So she's been a trailblazer in her own right. And she has a very compelling quote here, too, which I won't read, but I will let you absorb. And then finally, as I'm speaking to you all in the India ACP chapter, I wanted to leave you with what I find such an inspirational quote by, as I understand it, the first Indian woman physician who practiced Western medicine at the bottom here, Dr. Anandabai Gopal Joshi. Her quote has resonated with me in that she writes, "My soul is moved to help the many who cannot help themselves." And I leave you with a collage of very much women in medicine from India. And with that, I wanted to thank you so much for your attention and pardon my keeping you from a delicious dinner meal. So thank you so much.
Felicitating you, which is due of today's oration. Usually the purpose of oration is in getting an opportunity to felicitate, and I couldn't get because you couldn't travel to India. So next, whenever I shall be visiting Orlando, I would be very happy to get an opportunity to felicitate you there. Thank you. So nice of you, so kind of you. Have a good day. Thank you.